Hello.
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 More people are coming. Tell them also. People are coming. Yes, sir. Sir, he will help. The sister is there. He will help. I will tell him. I will. Good morning and Sairam, esteemed guests, distinguished dignitaries, faculty, and the most talented and cherished nurses from across the globe. I am Dr. Annie Arvind, the consultant pediatric cardiology at SMS IMSR. And on behalf of the organizing committee, I welcome you all to the academic feast, the first international conference on pediatric cardiac intensive care, 2025, a hybrid event. Let's begin the proceedings of the day by invoking the blessings of Almighty through a small prayer by the students from this hospital, Dr. Hridaya and Dr. Preeti.
श्रीगुरुभ्यो नमः हरिः ओम् गणानां त्वा गणपतिगुं हवामहे कविं कवीनामुपमश्रवस्तमम् ज्येष्ठराजं ब्रह्मणां ब्रह्मणस्पत आनः शृण्वन्नोतिभिः सीदसादनम् प्रणो देवी सरस्वती वाजेभिर्वाजनीवती धीनामवित्रयवतु गणेशाय नमः सरस्वत्यै नमः श्रीगुरुभ्यो नमः हरिः ओम् सहना भवतु सहनौ भुनक्तु सह वीर्यं करवावहै तेजस्विनावधीतमस्तु मा विद्विषावहै ॐ शान्ति शान्ति शान्तिः.
Thank you, Dr. Hridaya and Dr. Preeti. Since the origin of the first dedicated pediatric intensive care units in 1950s, pediatric cardiac intensive care has emerged as a distinct subspecialty to cater to the unique needs of the children with congenital as well as acquired heart disease. With developments in perfusion technology, refinements of the surgical techniques, most complex congenital heart malformations can either be completely repaired or palliated in the present era. Also, there has been parallel developments in the pediatric cardiology, such as early diagnosis and rapid stabilization, improvements in imaging, advanced interventional techniques, and newer treatment options for chronic conditions like pulmonary arterial hypertension and chronic heart failure, and this has also complemented the growth in this field. Moreover, the trend towards early primary repair, especially in infancy or the newborn period, has now been established as it is the current trend. Hence, it becomes imperative that every pediatric cardiac unit should have a dedicated cadre of specially trained nurses for the specialized intensive care of these critically ill children. This, of course, translates into better outcomes. To quote Florence Nightingale, the founder of modern nursing, nursing is an art, and if it is to be made an art, it requires an exclusive devotion, as hard a preparation as any painter's or sculptor's work. For what is having to do with dead canvas or dead marble compared with having to do with a living body, the temple of God's Spirit? It is the finest of fine arts, and it's a progressive art, such that to stand still is to go backwards. This 1.5 comprehensive program is thus an endeavor towards advancing nursing excellence in pediatric cardiac care through various lectures, discussions, and hands-on training sessions by the experts across the globe. It's a unique opportunity for you to strengthen your understanding of basics, learn up-to-date clinical practices in peri and post-operative care of your little patients, and foster collaboration. With this background, I would like to request Dr. C.S. Hiremath, the organizing secretary of the conference, senior consultant and chief cardiac surgeon, SMS IMSR, to come on the stage and deliver the welcome address.
Good morning, Sai Ram. Offering my reverential pranams to the divine lotus feet of Bhagwan Sri Satya Sai Baba and our master, Sadguru Sri Matsun Sai. I welcome you all for the first International Nursing Conference on Pediatric Cardiac Intensive Care. This is the first time of its kind we have been conducting in the country, where exclusively the program is focused on pediatric cardiac intensive care. If you have gone through the brochure of the conference, the scientific brochure, we have tried to include very good topics which are very much required for the nursing care. We have with us the international team headed by Dr. Sanjiv Nichani, who is a pediatric intensivist himself and is the chairman of Healing Little Hearts Foundation, United Kingdom. We have many other surgeons, intensivists, nurses from UK, Czech Republic and other countries. This conference has been done in collaboration with All Institute of Medical Sciences, New Delhi, where our institutes have an MOU, and we are privileged to have 3 of them who have come all the way from Delhi. Dr. Umesh Singh, who is a pediatric intensivist, Dr. Anubha Devaguru, who is associate professor at All Institute of Nursing, and Cecilia. Thank you, madam, for coming down here. We have very senior faculty sitting amongst us today. We have the first pediatric cardiologist of Karnataka state, Dr. Vijayalakshmi, with us today. Very proud to have her amongst us. In fact, she was my teacher, my mentor. We have Dr. Prasanna Simha, my teacher and mentor, with us, the HOD of Jayadeva Institute of Cardiology. Pediatric intensivist from Manipal and Spurs Hospitals, Dr. Vishwanath Kamoji. The trustee of the Healing Little Heart Foundation, Miss Lesley. I asked her, what topic do you want? She told, I will talk on leadership in nursing care. She wants to see that many more nurses become leaders. That is the topic of her choice. We are very much waiting to listen to her. Not only that, most of the surgeons, cardiologists, cardiacs, and intensivists, they have come forward to take classes for the nurses because you form an integral part of our system. Today evening, we have the inauguration program. I request all to attend the program to see what exactly it's happening and where we are heading towards. You can interact in your tea breaks, lunch breaks with the international team to seek out other opportunities, how to get yourself trained. They are very much friendly with us and they keep visiting us regularly so that you can also plan for further training. If you want to go abroad and all those facilities can be discussed with them and you can take it forward. I thank our senior professors in the College of Nursing, Dr. Shivanand and Dr. Guli, who are here. They've been kind enough to support the system, and especially the other nursing team members, starting from our nursing superintendent and about 3 to 4 deputy nursing superintendents who took a lead in conducting this conference. I once again welcome everyone for this exclusively pediatric intensive care conference. We also have a special topic, how artificial intelligence can be utilized in nursing care. Tomorrow we have sort of a debate or a panel discussion where people from Indian Institute of Science, the director of Indian Institute of Science, is here, and one of the AI masters, one of the 50 top AI masters in the world, he is here with us tomorrow. So see that you utilize these sessions. We have crossed registration of 476 and I'm still crossing. I already crossed 500. Spot registration I have crossed around 30 plus, and that's a huge number. I have a very limited capacity. Another bus is on the way from Jayadeva Institute. I think there will be another 80 people. I don't know where they will sit. But anyway, who has come first, you got your seat. Once again, I welcome you. A small request, when you move around in the front, try to avoid moving around on the front. The people are coming late. I welcome them again. Once again, special welcome for those who are coming late. First thing what you've got to do as a nurse is to cultivate discipline. And discipline starts from within first. Then only patient discipline happens. So this is a take-home message from here. I've been talking. She's working along. That's still, you need to look into those things also. There are about 6 cameras going live telecast across the globe. So kindly, I would request all of you to be very conscious when you move on the front rows. Kindly move behind if you are going outside. Avoid moving from the front rows. Thank you once again. I welcome you all to this conference.
Thank you, sir, for your wisdom and leadership. We now begin with session 1. I invite the chairpersons for the session on the stage, please. Dr. Sampath Kumar, Dr. Sanjiv Nichani, Dr. C.S. Hiremath, Dr. Jerneja Ravnikar V's, and Dr. Madhu Mahadev.
That this conference has been endorsed by the Indian Association of Cardiothoracic Vascular Surgeons, the Pediatric Cardiac Society of India. That's a privilege, this conference to be organized. You need to attend both the days. If you want your certificate, there's a feedback form also which is there. Unless you give the feedback form, no certificates will be issued. Please, madam. The other chairpersons are there online. Dr. Sampath Kumar, you are there, sir?
Yes.
Can we see Dr. Sampath Kumar?
Yes.
The audiovisual team, can you show his video, please? Yeah, thank you. Dr. Sampath Kumar is one of the senior professors and previous head of the Department of All Institute of Medical Sciences, our teacher, mentor. So he's here with us. Thanks.
Now I welcome Dr. Ivars, the pediatric intensivist, and RN Ieva Zarina from Latvia on the dais to deliberate on patient transfer from cardiac operating room to the pediatric ICU.
Hi, everyone. I'm nurse Ieva. I'm pediatric intensive care nurse, and I am coming from Latvia. My colleague Ivars is still in the ward. He's coming, but I try to speak alone. So I find my presentation. Can somebody help me, please? It's always, it's scared to start first, but I will try. Handover. No, it's not mine. Okay, sorry about technical problems. Firstly, I want to thank you, everybody who is here. It's a pleasure to be here. And Dr. Hiremath, you have a very good hospital. You have very good staff, very well-trained nurses, and your staff is so good. So this week was incredible for me. Thank you. So patient transfer from cardiac surgery OR to pediatric intensive care. Handover is my master thesis, what I made in 2019. From this time, handover is my team where I always speak about. I always train my staff. When I coming to camps, I try to make handover how I see. So I know about handover, I think a lot, but in this 15 minutes, I just want to say some key points, what is important for me, and maybe I can give you something good, so we'll see. What is handover? It's actually, transfer of patient care responsibility. When surgeons and anesthetists come from OR, they just give a responsibility to ICU team. And mostly important thing to get responsibility to nurses between health providers, ensuring continuity, safety, and clear communication of essential information. when you do handover, you hand over as a responsibility for patient to another person. Everybody wants this kid who are after surgery, who are super complicated, maybe on a ventilator, maybe on inotropes. Everybody wants he comes better, and everybody wants the team who take care do the best. Actually, handover starts not so long time ago. Firstly, about handovers, they start to speak late 80s in the USA. In 2007, Joint Commission Healthcare Organization recognized the importance of handover approach introducing in medical errors. In 2010, Yahoo developed a care standard that required healthcare providers to use standardized process for patient transfer, emphasizing that structured process. And of course, 2014, it's come on NHS. In my country, it's come for 5 years later. Short handover strategy. If you know, before to ICU, you will have most cases, like 10 cases next week. Please inform CICU administration as soon as possible. If Dr. Hiremath know next week coming healing little hearts and do 10 or 15 cases per week, please inform already ICU. How I said, as soon as possible, because they need to plan how many ventilators they need, how much staff they need, what medications they need. They need do a lot of work before. On the day when patients are already in ICU, minimum what you have to inform ICU, it's right in the guidelines, it's 13 or 60 minutes before arrival. It's a time when ICU need to set up bed, set up ventilators, maybe prepare sedatives. It's most important thing, what I want to say, you can't come from OR straight away without informate ICU. Mostly you inform about estimated arrival time, patient weight, always anesthetists or surgeons or who will do this handover. If you can say before about the patient weight, do this, because in pediatric we give medicine by weight, yeah? ATT size, it's very important because somebody needs to set up a ventilator and you need to put the size of ATT. Necessary equipment, specific care requirements, maybe isolation. When patients are on the way already transport from OT to the intensive care, I actually want to say it can do by one person, because when you transport patient, anesthesiologist oversee airways. He check transport monitor, but somebody need to be on medicaments. If nurses, you have an anesthetic nurse, I don't know, you have a physician assistant, yeah? But in some countries, we have anesthetic nurse who do handover together with anesthesiologist, and it's easier, it's safe for patient, because if this patient will wake up on the way, anesthetist can do all the job. He maybe are on the way to, on the ambu bag. He check monitor, patient is waking up, somebody need to give medicine. And it's easier when you have your nurse with you or a physician assistant. One point what you need to remember, ICU nurses, when patient is coming, never disconnected monitors or ventilator system until it's safety, until anesthetist said, yes, please do it. And if you disconnect, just say, I disconnect saturation probe, yeah? Because everybody needs to know what you do, especially anesthetist who is who take care of this. very short handover strategies. Always follow a fixed sequence during handover. It can be done by one person, I already say. It must be happened on the patient beds. Here I saw all handovers was happened in the beds, but I saw some days when doctor do by phone. Anesthetist hand over patient and surgeon call by phone what he did. Yeah, my next question. In handovers, where's the surgeons? In this hospital, it's different because surgeons already in OR. But if surgeon has a time, you need to come to nurses and say, hey, we did something like this, we operate this, and they need to know because they take care of your patient. They will be next probably 24 hours or 34 hours with your patient, but you operate. If you have a time, just come and say, nurses, what is your plan? And maybe it's you have a different plans of this patient, or every time happen something that you can just ask or just tell your nurse. Very good practice is use closed loop communication. We don't have the time speak about this, but this when sender gives a clear message, receiver repeats back message, and sender confirms, like, Katrina, please take adrenaline. And you already answer me, and I confirm that I hear. This is very important because sometimes you tell some nurses take adrenaline, and 5 nurses take adrenaline. And you waste the time, you waste the staff time. So key points of handover. Anesthetist, first, name, surname. In my small country, we have a persons with same names. You are a big country, it can be. Age, because of medicine. We need to give medicine by age in pediatric. Maybe hospital number or ID number, what you have. Information, when everything is set up, please. One is speaker, another listens. If anesthetist speak, we stop and nurses listen. It's only one time when you hear this anesthetist, because after handover, he go to the different case and he will forget. If he speak, please listen. Clinical summary, diagnosis, med history, current condition, recent events, treatments, investigations, and any change and conditions. Last 3 points, tasks to be done, what needs to follow up, including urgent actions, warnings and risks, allergies, critical care conditions, potential complications, responsibility transfer, clear confirmation, and who takes the care. It's like a scheme. Black points are medical stuff. You see how much stuff is there. It's okay, because we have very complicated kid after cardiac surgery with a lot of stuff. And if we need medical stuff, so please, we can do. Standardized approach, 3-step. First, critical, when came patient, airways, CVP, ABP, temperature, ACG. If you have a nurse, okay. Medication management, pumps, drains, then stop. Second, communication, anesthetist speak. Maybe we have surgeon, he speak. Nurses, if you have some question, just ask. It's only one time when you can ask what they did in OR. And thirdly, please, all other things. Anesthetist will go back to OR. You can do documenting, check catheters, dressings, and care invitations. Actually, why we do need this handover? Effective handovers improve patient safety and save hospital money. Money by reducing errors, preventing adverse events, and optimize workflow. Poor handovers can lead to longer hospital stays. legal costs and inefficiencies. Standardizing handovers protocols in change care quality and resource management minimize errors. You save hospital money. It's a handover what I take to here. It's example I give to Dr. Parimala and Dr. Marek. We use this in this week. Actually, you see the first line, what nurses need to do firstly, together with physician anesthetist, a physician assistant, sorry. Then anesthesiologist start report. Then, sorry, surgeon was super busy, but it's okay, it's fine. After ICU report, some nurses already know they have opportunity to ask anesthetist, maybe what about concentration of these medicaments, or do it. Okay, thank you. Handover is an essential nursing duty and responsibility, and it is up to us nurses to handle to his property. Take care, nurses, of your handovers here. Thank you.
Thank you, Ieva. You've been very kind to the surgeons. Well, first of all, you've highlighted one of the most critical parts of the patient journey. But you've been very kind to the surgeons. As far as I'm concerned, it is not negotiable. The surgeon must come and hand over. It's very simple. The reason for that is very simple. The surgeon is the expert on this child's condition, has worked the child up along with the cardiologist, has intimate knowledge of what he or she has done. And therefore, that knowledge has to be shared with you in the ICU. You're an intensive care nurse, I'm a pediatric intensivist, so the patient can be looked after optimally. Unless that information is transmitted, then patient care will suffer. It's not negotiable. And thank you for highlighting such an important part of the patient journey. Do we have any questions?
Because sometimes another thing that we have to highlight is intraoperative events which have occurred, which can have a bearing on the care. Another point which I would like to highlight is during transfer, though it's been mentioned, but the key, I think, which every nurse should think, that there should be one sign of life at all times during the shifting of during the shifting of monitoring things. One sign of life must always be there on this monitor to that monitor, this monitor to that. I think that is the key which people tend to miss.
In fact, as sir mentioned, it's very important. In this one sign, once the system missed, and in that period, the patient fibrillated. And we ended up losing that case in one of my experiences. So that's very important that shifting monitors in cardiac surgery is that at least you have one line on table always while shifting. Thank you, sir, for bringing out the point.
Okay, thank you.
Thank you. Thank you.
Thank you, ma'am. Moving on, I invite on stage Ms. Katrina Belousko, RN from Latvia, to talk on nurse workload in the PICU and the use of Therapeutic Intervention Scoring System, TISS 28, to evaluate the same.
Hi. So I will try to close this presentation. I don't know if it's going to work. So, hi everyone. Adjust the microphone. At first I want to say a big thank you for everyone. This week was incredible. I'm so happy to be here. It was my first time in India. I'm so incredibly happy about your culture and all the people that I met this week. It was incredible. I'm so happy. So for those who I haven't met this week, my name is Katrina Belousko. I'm an intensive care nurse and a nurse as anesthesia, in a nurse and also in anesthesia. And today I'm going to talk about nursing workload in pediatric intensive care unit using the Therapeutic Intervention Scoring System, who is also known as TISS 28. So to understand why this 28 is needed, we're going to speak a little thing about background. If you look in an overall picture, in recent years, the average age of the patients who have been admitted to the intensive care units, the severity of their illness, as well as the complexity of the care and treatment have increased worldwide. And nursing tasks in particular have undergone large changes due to the rise of the new technologies in a patient care, which has changed the profile of the critical ill patients and requires highly skilled nurse work. Specialized patient care increases the intensity and workload of nurses, necessitating the definition of the adequate staffing requirements. In one of the studies in 2010, the workload was explained as the amount of time, effort, and tasks a nurse needs to handle for the patient in a specific time period based on the patient care needs. As we know, nursing staff is the largest workforce in intensive care units, and staffing costs and strict budget requirements demand the determination of appropriate staffing levels in each unit. However, healthcare managers often face challenge to allocate the correct number of human resources in specific units. And this was a call for a need to create the quantitative data system which would justify the requirements of the care staff in each unit. And then the TIS-28 was made. The first tool to calculate and present nurse workload was made in 1974. It was TIS-76, but the same authors made the system more simply to its last version, Therapeutic Intervention Scoring System 28. The System 28 was made in 1996. So basically this 28 is almost 30 years old. This 28 is quantitative data system that records the amount of care activities and procedures performed for a patient within a specific time interval. So basically it's the shift that we are working in. In Latvia, we usually work 12 hours. I saw that you work here differently. You have like a morning shift, then evening shift, and a night shift. In Latvia, we do 12 or 24 hours. This is based on a principle. The more severe the state of the patient is, the higher the TIS-28 score is, so the longer the nursing time is spent on a patient care. About this 28 structure and to understand how it looks in real life, our system could be divided in these 7 categories. There are basic activities, respiratory support, cardiovascular support, renal support, neurological support, metabolic support, and some other specific procedures. And each category consists of few care activities. There are total 28 care activities, each assigned a specific TIS-28 point value. When nurse completes this tool, the nurse marks all the care activities required for by the patient clinical condition during a single episode of the care. So the total TIS-28 score, when she calculates all these things, she gets the total TIS-28 score, and it represents the level of the care the patient requires from the nurse. If we check this chart, it's from my hospital, then to understand it, like to try to tell how to understand it. So if the patient TIS-28 score is up to 10, then one nurse can take care of 3 patients. But usually the patients who have admitted to the ICU, their TIS score is 20 and above. So if this score goes up to 20, so the nurse and patient ratio should be 1 to 40 and above, then usually it could take 2 nurse to work with this patient, so improve the patient's safety in a unit. Okay, now I'm gonna tell of something how to use this 28 in research. This is also on the master thesis. I did what I did when I finished my master degree studies, and the name of it is Nursing Workload in Pediatric Intensive Care Unit using this 28 system. The study was conducted under the main Children Clinical University Hospital in Latvia. And to understand, we live in a really, really small country. Our population is less than 2 million. So we have only one children's hospital in our country and only one pediatric intensive care unit. Yes, I'm going to change my... the study participants were all the patients who have admitted to the PICU in 1 year interval. So the total number of the patients are 698, and in total 3,630 TIS-28 forms were filled in. And this 28 was completed every 12 hours. And this study assumes that 28 points define the workload of the nurse within every 12 hours. Here we can, I'm going to show just some slides about data that I receive in my results. Here we can see graphical representation of the TIS-28 score for one nurse in a 1 year period. The orange line represents the average TIS-28 score observed for the one nurse over a 7-day period, and the dashed line indicates the adequate nursing workload as it was defined 28 points. And as we can see over the year, the nursing workload has been uneven. Intensive care units typically show a rapid increase in intensity, exceeding the adequate workload for the nurse, followed by sudden drop in intensity. In spring, starting in April, an increased peak jump was seen when the largest score of TIS-28 points per nurse was observed, when one nurse had to work with a patient who this score was about 100. In this particular case, increased workload was associated with the not enough nurses during the shift. And this is one of the reasons why it's important to assess the unit's workload in the daily basics. The nursing workload was statistically significant, different between type of the shifts and days, and seasonal differences were also observed in the study. During day shift, media of the sum of 28 points per nurse was statistically significant higher compared to the night shift. So as we know, in day shift, we need more nurses than in a night shift. And this is graphical representation of the TIS-28 observations in our PICU unit. This is our PICU unit in Latvia. So every circle represents bedside. So we have 11 beds. The nurse station is in the middle. So in a bed 1, 8, and 11, these are isolators. To understand what I'm going to tell you, how big is the circle? If the circle is bigger, then the more patients are admitted in that bedside. And the colors indicate the TIS-28 point scores that were put in this bedside. So dark blue color represents the smaller, like low intensity care patients, and the yellow color represents the higher intensity patients. The bed 9, 10, 11, they are cardiac ICU beds. By looking at this TIS-28 point score graphical representation, it is possible to conclude that nurses spend approximately the same time on a bed 4 and 10, but bed 10 have higher intensity patients because these are cardiac beds, but bed 4, 5, 6, and 7, they're like general surgery for general surgery cases. Oh no, can I go back? Previous. Yes. The busiest was the bed 8, and which is linked to the fact that 8 bed site is most transparent on the side of from the nursing station, and this is isolator. So patients with the worst health status are placed there. And such an analysis is really important in planning the deployment of the patients and nursing stations, and visualizing of that in real time could improve the work in a unit. This could make work for nurses easier and improve patient safety. In conclusions, the intensity of care in ICU is inconsistent and may sometimes require more or fewer staff than allocated over a year, and it's necessary to assess the nurse workload in intensive care units daily to be able to give a quick response to sudden increase or decrease in care intensity. This allows for adjusting the number of the care staff, either increasing or decreasing it without unnecessarily using staff reserves. Ensuring an adequate number of the staff is essential to maintain high quality care. The results of the study and review of the literature shows that the objection of the nursing workload is still necessary, and the search for the most suitable model for calculating the nursing workload for the Latvia health system, and maybe in your health system too, should be continued, because this 28 is 30-year-old, and the manipulation, everything that we do in an intensive care unit still improves. So the information is quite old in the instrument. Thank you. There's a QR code. If you want, you can try to scan it. So it's gonna lead you to the TWIS 28 online. And if you were interested, you can check and calculate it for your latest patient. Yeah, that's all from me. Thank you.
Thank you, Katrina. We'll have questions after one more session. Before we'll ask questions later. Give me 2 minutes. I would like to invite Dr. Ivars, who is a pediatric intensivist. In fact, he was there in the first talk, and he was in the intensive care. We had operated around 35 cases last week, and one child was critical with the chest open, so he got late coming to the auditorium. I request Ivars to share his thoughts on his topic.
Okay, thank you. So unfortunately, I missed Ieva's talk, so a few words from me. So the importance of good quality handover cannot be overstated, especially in patients that change caretakers many times, or very complex patients like cardiac patients. And study shows that a lot of information gets lost in the process of handing over from one team to other, and especially critical is in the transfer from cardiac OR to the ICU, when there are a lot of things to keep in mind, and a structured handover where you relay all the important aspects of patient care is very, very important to keep up with the quality of care. So what Ieva tried to implement was the so-called F1 principle, that every person has a role. And so one is changing the wheels, the other is filling up the gas tank, and to make sure that both the patient care stays uninterrupted and that all the necessary information is relayed. So we had good success, I think, in with cardiac patients. The handover is improving. Still, a few years after Ieva's work, and a bit less success with other types of patients that come to our ward, mostly because of different sources of admission, like emergency or other ORs. But I think we have made very good progress. And for some of us, it's like already in our back of our minds. So, but I think there's still room for improvement, and you will see that structured handover is what makes our lives easier and saves actually some time as well.
Thank you, Dr. Ivars.
So, Katrina, that's really interesting. Do you think this, you've been here for a week,
Yeah.
and do you think this can be translated into the Indian nursing psyche and work
It really,
patterns?
yeah, I think it really could, because the TIS-28 is really simple. We have in our hospital, we have it in a computer system. We just click and it's really fast and it calculates and goes straight to the system, and you can use these data all the time for some like year to see what happened in year and the last year. And yes, but maybe there is like a nursing activity score, NAS, who is the newest version of the TIS-28. We still are in, we still try to admit in Latvia. And I think this year we're going to start using NAS. I hope so, because it's better and it better represents the nursing workload in the intensive care unit.
Thank you.
Yeah, we have online Dr. Sampath Kumar from Delhi and Dr. Madhu Mahadev from Mumbai. Sir, are you there? Any questions from your end? Dr. Madhu? Shiva Kiran, can we get Dr. Madhu online or Dr. Sampath Kumar if they are there? Yeah, I think there are some connective issues. Yeah. No.
In the meanwhile, can I ask a question? See,
Please go
one
ahead,
of the major problems that I have is shortage of nurses. I mean, it's ideal when you can translocate nurses to accelerate and decelerate the nursing numbers which are needed. How would, like in my hospital, I'm literally running with 1:3 nurses, though we want 1:1. In such a situation, I can see that better allocation from areas where there is less intensity may help optimize. Any thoughts on that?
I think this is a problem worldwide. We have the same problem in Latvia. What I can say, we are trying to use the principle, if we don't have enough nurses in a day shift for in an intensive care unit, and a lot of patients are planned to move from the UR to the or intensive care unit, we do the closure principle, just intensive care is closed and that's all. If there are like really severe cases that have to be done, we start calling the nurses and try to get more nurses for the night shift. But if there are cases that can be like planned for next day or 3 days, in next 3 days, then we start to plan how to get more nurses in the day, that day, and respect the nurse work and respect the patient safety. But
can you hear me?
Yeah. Please, sir. Please go ahead. Dr. Sampath Kumar, as I mentioned, from New Delhi. Please go ahead, sir.
Yes. Recently, there has been a publication in the Annals of Thoracic Surgery on the timing of transfer of patients from OT to the intensive care unit. There is a correlation between what time the patient arrives in the ICU and the outcomes. Children who come earlier in the day, say around 11 o'clock, 10 o'clock in the morning, fare much better than those who are transferred to the intensive care unit much later in the day or even at night. So I think this is something that should be interesting to the surgeons, to make them start the surgery much earlier in the day rather than later in the day.
Thank you, sir. Thank you for the input, sir. We'll definitely follow this. We started at 5, so sometimes at 2 also, we have done that. Thank you. Thank you, Dr. Sampath Kumar. Dr. Madhu is there?
Yes, I'm still here.
Why it is echoing, Shiva? Okay, Madhu is not there. Yeah. Thank you. Thank you, Dr. Miss Katrina. I think we'll go ahead with the next talk.
Okay, thank you.
Thank you, ma'am. The next talk is on the leadership in nursing, qualities and why it matters. With immense pleasure, I invite Miss Lesley Mistry on dais. She is the lead nurse and trustee of the Healing Little Hearts Foundation, a UK-based charitable organization. Over to you, ma'am.
So how do I move the slides on? Do I just click that each time once? Okay, thank you. Good morning, everyone. Just like to say thank you so much for attending today, and thank you, Dr. Hiremath, for this, well, for our collaboration and for giving us the opportunity to bring our teams here to work with your wonderful staff. So this is my 3rd time here and I absolutely love it. It's an amazing place. So my name is Lesley Mistry, and it's truly an honour to be here to speak to you today about leadership in nursing. I'm not entirely convinced I'm qualified to do so because you have the most accomplished, most inspiring leader here in Sadhguru Sai Madhusudan Sai. Yeah, so anyway, let's see. So I work closely with Dr. Sanjiv, and together we run Healing Little Hearts Global Foundation, which is probably the busiest children's heart charity in the world. Let me tell you what that looks like. So over the past 12 months, we have completed 31 missions. Sorry. Providing heart surgery to 459 children. 4 of those missions were here at Satya Sai. And in total, we operated on 108 children. While we've operated on another 30 this week. Since we were founded 15 years ago, we have done 246 missions in 23 countries in 6 continents around the world, operating on over 8,000 children. So over the past 11 years, as a leader of the charity, I've had the privilege of assembling and preparing teams for missions. Sorry? Yeah, I've got it. Preparing teams for missions all over the world. It's a huge logistical undertaking, pulling together specialists from different countries and cultures. This week is one example. We have team members from Latvia, Slovenia, Czech Republic, and the UK. (2024) was a very busy year for us. 300 volunteers were recruited to take part in our 31 missions, mainly like this week's team. It's wonderful to see these volunteers come together, arriving as strangers, but leaving as friends at the end of the week. I also provide guidance and pastoral care before, during, and after missions, making my
myself available for troubleshooting worries and concerns. Alongside coordinating teams and logistics for Healing Little Hearts, everything from flights, visas, vaccinations. I'm also a registered nurse with over 30 years experience. I currently manage a busy outpatient department in a private hospital in Leicester, which is around 2-hour drive from London. There we care for around 10,000 patients a year. In my humble opinion, I think a leader should have the following characteristics. I'm a great believer of leading by example, being a compassionate, professional, caring, and empathetic role model, both to your patients and your teams. I feel good communication is essential, actively listening and giving concise and clear instructions. You should trust and believe in your teams and give them responsibility and empower them to make decisions, putting forward their ideas. And you should endeavour to empower and display resilience in challenging situations. It's very important to me, though, that I recognise and appreciate my teams, each individual. It makes them feel valued, it boosts their morale, and it motivates them. I also have an open door policy where people can come to see me. It's a safe place and they can speak to me about anything, any concerns, and if they need to share or ask for any advice. Having travelled the world with Healing Little Hearts, I've been struck by incredible leadership. I've witnessed, but especially what I've witnessed here and who I'm going to talk about. So first of all, I would like to speak about Dr. Hiremath. Are you listening? So he is the epitome of leading by example. His energy is compared to, well, ever-ready or Duracell batteries, whichever you use, and his enthusiasm is infectious. He's always eager to start surgeries. Yesterday it was 5:30, I believe. Do you ever sleep, Dr. Hiremath?
Yeah, I sleep 2 to 3 hours, I sleep.
He connects with everyone, is very caring, and he creates an environment of positivity and teamwork. Now let me tell you about Sister Usha. Where is she? Oh, okay. She truly embodies compassionate leadership. She's always here supporting her team, particularly in challenging situations. One camp last year, we witnessed that she was still working and she was really not well. She shouldn't have been here, but she takes pride in her work and she's got boundless energy and she loves what she does and she works from the heart. Oh, there she is. And we have Annie Arvind, Dr. Annie Arvind. Her leadership style is gentle, but powerful. She has a smile. You've missed yours. She has an ever-ready smile. She has a can-do attitude, and she puts everybody at ease in all stressful situations. And you're very hardworking, of course. So you have the power to inspire your colleagues. You also have the ability to be like Sister Usha and create workplaces where people are proud to work, proud to care, and proud to be part of something bigger than themselves. Each and every one of you is a leader and can lead sick children like these, away from ill health to good health and a brighter future. Thank you.
Thank you, Dr. Lesley. In fact, I was not aware that you have written some slide on us. Thank you so much. In fact, we appreciate you as leader, you and Sanjiv Nichani. In fact, they do appreciate our work so much, and they have been moving across more than 24 plus countries for the last 15, 16 years. And I think this is the only place where last 6 months they have come almost 3 to 4 times here. That means they love the place, they love the people, and they want many more leaders like them to be created. They set an example for us. They learn from us and we learn from them. That's how it is. The concept of one world, one family, our Sadhguru's mission keeps going on. And nursing is a primary role. And in fact, if you ask me, they are more compassionate than surgeons or doctors. That makes a difference in patient care. This, you will know the importance of a nurse only when you fall sick. That I keep telling in number of people. In my own examples, I have fallen sick 4 times, undergone 3, 4 surgeries, and you know her value only when you fall sick. Till that time, you'll never know her value. I don't recommend everybody falling sick, but before going to that stage, know their value. And as you mentioned, creating leaders, set a role model, set an example. They are examples for them, us. We are examples for them. That's how we keep learning ourselves. That's how we have collaborations with various institutes, and that's how we can make a better society, a better world, and make a better life who can always cherish your moments. And that gratitude they carry, and that can be taken forward. Thank you, Lesley, for joining us. We look forward for many more meetings like this in the near future.
Thank you, Lesley ma'am, for such kind and appreciating words. We come to the end of this session. Thank you, chairpersons, for moderating the session.
Just one announcement, the inauguration today at 6 p.m. has been preponed to 5 p.m. and TV and high tea will be served after the inauguration. Thank you. Can go to the next session.
We move on to the next session, which focuses on basics in pediatric cardiac intensive care. May I request the chairpersons to come on stage and chair this session, Dr. Prasanna Simha, Dr. Petr Plasil, Ms. Katrina Belousko, and Ms. Anubhava Devaguru.
I think we can, Dr. Anil Tendolkar is on the way. We can just put him as last talk and start off with the who is able.
Dr. Peter?
He has gone to the ICU. On turn-wise, the intensives are exchanging their duties. He'll come, he'll join. We can start off. Yeah.
So ideally, the pediatric cardiac critical care nurse should possess basic knowledge about the anatomy and pathophysiology of the common congenital heart diseases, the surgical treatment for the disease, the cardiopulmonary bypass and its effects on organ systems, strong physical examination skills, accurate interpretation of hemodynamic and lab data, active participation in bedside rounds, pharmacology of cardiovascular drugs, recognition and management of the common post-operative complications, excellent communication skills, meticulous care of invasive monitoring catheters and tubes, and compassionate support of the families are among the skills that distinguish a cardiac critical care nurse. This level of expertise is acquired over a considerable period of time. With immense pride, I request Dr. B.R. Jagannath, the organizing chairman for the conference, and the honorary senior pediatric cardiac surgeon, SMS IMSR, to kindly come on dais and take us through the physiological implications of the palliative surgeries for congenital heart disease.
And I know, no, she's. Where is the? Sai Ram, and good morning to all of you. We had an excellent session so far. I think you heard many of the visiting team who had come and helped us out in the ICU and in the OR and you heard their experiences so far. Now, what we are looking at is the physiological implications of palliative shunts, palliative cardiac surgery, that one, yeah. So you can use this.
Yeah, we have Dr. Tendolkar with us. Welcome, sir.
Oh.
He's come from Mumbai,
I
senior
thought
teacher
probably we
cardiac
should,
No, sir, you go ahead with the talk.
okay.
Yeah. Either better.
Back. First slide. I think you can use this. Okay. Right. So with that, warm welcome to Dr. Anil Tendolkar. He's been my guru and guide, mentor, and whatever you say, not only for me, for many of the cardiac surgeons around the country. His passion is basically teaching, and his teaching extends not only to cardiac surgeons, it extends down to the ward boy. I'm looking forward to hearing him. This talk actually should have been at the end of the session, but to fill in the time, I've taken it up as the first. So today, I'm going to just walk you through some of the palliative procedures that are performed during cardiac surgery. So now let's get the definition right first. What is palliation? So when you talk about surgery, if you cannot do a complete anatomical and physiological repair, it's called palliation. During the care of a patient, if you cannot completely cure the patient back to original status, it is again called palliation. And end of the life, when you can make things comfortable for the patient, it's again called palliation. So palliation means to make comfortable, to improve quality of life, but not a total permanent solution. This is what is called as palliative, right? So now let's just look at what are the palliative procedures that are possible in cardiac surgery. First is, if there is reduced pulmonary blood flow, then you can increase the pulmonary blood flow. There are procedures, we will go into it. The other one is when there is pulmonary overcirculation, like when you have shunts at cardiac or various levels, and the load on the lungs is high, you can reduce the pulmonary blood flow without totally correcting the whole thing. Now, there are certain situations where the blood, which is purified, circulates in one side of the heart, whereas the impure blood circulates or recirculates in the other side of the heart. And the only way life is possible is when they intermix with each other. And this mixing can result in all deleterious effects, and that is palliated by increasing the mixing of blood. There are special situations like single ventricle, that is both anatomical and physiological, single ventricles. And then there are congenital valve stenotic lesions where we cannot offer a permanent cure, but we can temporarily palliate them so that they can grow further. So these are possible palliative procedures in cardiac surgery. So now we'll come to the commonest one. I'm sure most of you would have seen this operation. It's one of the first operations recommended by Blalock, Helen B. Taussig, performed by Blalock. This is called a Blalock-Taussig shunt. It is basically to palliate cyanosis. And the cyanosis is basically because there is less amount of blood going into the lungs, more amount of unpurified blood going into the body by mixing through the VSD. I will not take you into the technical details. There are various reasons why these shunts are done. Basically, it is either to grow the pulmonary arteries, to increase the blood flow into the pulmonary arteries. And in our setting, this is basically done either in infancy or neonate. When Blalock and Taussig introduced it, it was done in older population. That is now currently what is being in the third world countries. In our setting, in India especially, it is usually as a neonate or as an infant. In developing countries, like I already told you, children come up for shunts. And in the Western population, usually it is done in neonates. It can be done from the front. It can also be done from the side, right, left, depending upon various other factors. So now what are the implications of this shunt procedure, which is done to increase the pulmonary blood flow? One thing you must understand is that the basic pathology which the child came to us with has not been addressed. What we have done is we have improved the pulmonary blood flow, and therefore we have reduced the cyanosis. So when the child comes to you in the ICU, the saturation can never go up to 100%. Now, acceptable range is around 80 to 90. There are situations where you would accept slightly lower saturation, but better hemodynamics. We will come to that a little bit later. But for the time being, what you must understand is, A, saturation will never become 100. B, the saturation will be in the range of 80 to 90 if it is done for a palliation for tetralogy of Fallot or its variants. Bigger children with shunts which are large usually behave well, do not give you much of a trouble. They grow using the increased amount of oxygen. But in neonates, the whole body volume is very less. The margin for error is extremely small. You will be using smaller size shunts, and therefore they can tend to give you trouble. They do not give you too much time like what the bigger children do. There could be shunt thrombosis, which means the shunt can get blocked. You're talking about 3 millimeter or 3.5 millimeter or 4 millimeter size grafts, and they can close very quickly. There could be shunt overflow. What you need to know as nurses is that the saturation monitor is your main guide. Whether the shunt overflows or whether the shunt underflows, the saturation will drop. It drops precipitously if it is what you call shunt thrombosis. But if it is shunt overflow, in addition to that, there is another monitor which is called EtCO2 or carbon dioxide levels in the ABG. And this will give you a guide. More importantly, your airway pressure on your ventilator will tend to go up. That means pressure in the lungs is increasing, and the most possible common cause is that the shunt is flooding. Well, I would like interaction. What would you do if you find the saturation falling in a neonate? Any answers? what would you do? Sir. Can we get interaction? My intention basically is that this program should be interactive. You should probably come up with what is this one. And since no questions were forthcoming from any of you during the previous session, yes, tell me, that's good, excellent. Yeah, you will increase the FiO2. That's good. You will increase the ventilatory rate. That's good. Any other suggestions? Sorry? You will increase the fluids. So we got some good suggestions, please. I mean, I am not here to tell what is right, what is wrong. What I'm appreciating is that there are some suggestions coming forward, which is what I want to encourage. Right, exactly, fine. Yeah, tell me, anything else?
Can you please give a mic, please?
Yeah.
I request to take a mic and speak because it's online. The people who are online can't hear your question.
Sorry.
I would request you to introduce yourself. That will be good for the audience.
Sorry, I'm Padiseva. I'm a pediatric intensive care unit nurse from Fiji. Okay, as for your question, sir, for that one, I think we'll have to increase the rate, the flow of oxygen, or increase the rate of ventilation. But it will depend on the conditions of the patient, what other surgery they come with, whether it's his tough or any other condition. Then from there, then we do the interventions. Thank you.
Okay, good. So what we had was a lot of suggestions. But first, what I would request you is, because their time is extremely short, first thing is raise alarm. That is basic. Call for help. This is the first thing which you must understand, right? Call for help. And then after that, the first thing you need to look for is look at the ventilatory pressures. If the ventilatory pressures are going up, there is a high likelihood that the shunt is flooding. If the ventilatory pressures are normal, it is high likelihood that the shunt is getting blocked. Heparin, by which time you will have your cardiac people coming in, and they will probably take decisions much faster. But what I want to emphasize is you need to raise alarm at the earliest, not later. And there could be other complications like bleeding, etc. Due to lack of time, I'm restricting the interaction. Okay, so basically, call for help. Neonates do not give you much time to react. Look at the trace in the arterial line. See for rhythm disturbances. Trace in the saturation probe, which can be a lot of issues. Check the temperature of the patient because the probe might be in wrong position. Look at the tube ventilator, tube position, ventilatory things. In addition to that, check the drugs, which are inotropes on flow. Heparin infusion, if it's not on flow, it needs to be started. Take the bag. Arrest may need a massage, and keep the emergency trolley bedside, reopening trolley to be looked into, defibrillator, and bedside echo. This is what I expected. Well done. Quite a lot of answers did come up. So we will move on to the next step. This patient is discharged, and after he is discharged, He may have heart failure because now his pulmonary blood flow has been improved. The blood returning to the left ventricle has improved. So therefore, the left ventricle may start to have a little bit of failure. That is in the form of excessive sweating, feeding difficulty, excessive weight gain. All these things need to be monitored very carefully in the ward. Post-discharge, he may outgrow the shunt so that the saturations gradually keep coming down. He becomes easily fatigued. In a patient for whom you have reduced the pulmonary blood flow, or I mean, when the pulmonary blood flow is excessive, if they do not grow into that excessive pulmonary blood flow, then early PAH could develop. This was extremely common in pot shunt, which was done ages ago. The pulmonary artery may not grow. So we need to ask for an echo, check weight, saturation, general examination, and look at timing of correction. So now we come to the next type of shunt, which is called a Glenn shunt or a systemic vein to the pulmonary artery shunt. Most of you are familiar because many of you are working in ICU setting. So I will not again go into the technical details. It's there in the diagrammatic form for you. Now this Glenn shunt is usually done as the first stage of single ventricle repair. It's usually done in infancy. You cannot do it as a neonate. Can anybody volunteer and answer why you cannot do it as a neonate? I hope everybody understands what's the difference between neonate, infant, toddler, adolescent, adult. Can somebody? I see a lot of heads nodding, but I don't see any answers coming up. Yep. Excellent. 28 days is a neonate. 1 year is infant.
1 to 3 years is a toddler.
Excellent. So now we know that, you know, that's good. So now this operation is usually done in infancy. In our setting, it's usually done between 1 and 3 years of age, although we are also beginning to do it in infancy. And in older age, staging is possible in the developing countries. It's usually done from the front and usually done along with an atrial septectomy to improve mixing. Again, what to expect? So the saturations will be around about 80 to 90. Again, it will not go to 100. You should look at the Glenn pressure, which means the pressure in the SV, superior vena cava. And this Glenn pressure should be around about 12 to 14. As time progresses, this 12 to 14 usually drops to around about 8, 10. If it is high, it means that the Glenn may not be flowing adequately when you'll have to call in the people, other people to help you out. If the Glenn pressure is extremely low, then check your transducers. Carbon dioxide in the ABG usually reflects how well the lung is perfused. That is an important thing. They do better with early extubation and spontaneous ventilation, and you as nurses need to watch the breathing pattern. Many of you would not have known how a post-Glenn shunt patient breathes. It's slightly different. Observe it next time when you're looking at those patients. You will be able to identify it. Watch the quality of drainage in the chest tube. Initially, it will be bloody, but then after the bloody discharge settles down, if clear fluid comes out and is normal, it's acceptable. But very likely, the fluid might be clear and increased in volume, or it could become turbid. If it is turbid, it indicates Glen failure, or it indicates that there is chyle in the pleural discharge. This is essentially important when you work as a nurse. Ideally, do not keep any infusion in the superior vena cava. Use the IVC line for all infusions. Watch for air while injecting drugs, especially in this particular situation, because injection of air goes directly to the brain in this situation. Heparin infusion, complications of cardiopulmonary bypass need to be watched for. I think you need to go through the list on your own. And after discharge, keep watch for puffiness of the eyelids. Oxygen is usually not needed in these patients because the saturations will vary from about 70 to 85 or even about higher 90. Remaining things, please go through. The only thing is, on periodic follow-up, the Glen pressure usually tends to come down and remain around about 12, 14. If so, they are ready for the next stage. But if the Glen pressure tends to go up, it means the pulmonary vascular resistance has increased, or else the Glen stenosis has started occurring, in which case you need to evaluate before going into the next stage of the operation. So now this is another operation which is done for reducing the pulmonary blood flow, where you put a small band around the main pulmonary artery and reduce the pulmonary blood flow. Again, it's usually done through the midline, but it can also be done by left thoracotomy. Now here, again, because you are reducing the pulmonary blood flow, accept a saturation of 80 to 85. Now, chest may be kept open and variations in the pulmonary blood flow, which is necessary, assessed by echo. Time aita? Okay. If I'm exceeding the time limit, I could stop.
No, Dr. Enig, just see that he is up to the time only, sir, because we are running short of time already.
I know, that's why I just this one. So, okay. So now this is where you are increasing the mixing of blood. This is called a Blalock-Hanlon septectomy. Again, saturations 80 to 90%. You can tolerate a much lower saturation around about 70. And then you have Norwood and single ventricle situation, where it is a little more complicated. And usually you will be helped by the intensivist who will be around by the bedside, unlike in the previous versions which I talked to you about. This is just a historical operation where they called a Brock procedure, where they cut across the pulmonary, right ventricular outflow tract and pulmonary artery. It is done to improve the pulmonary blood flow, not practiced nowadays. So to conclude, palliative procedures are an important part of congenital heart surgery. Although less practiced, done predominantly in small babies, needs efficient post-op management, expect saturations of 80, and call for help earlier rather than late. Thank you.
Thank you. Thank you, sir. Any questions for Dr. Jagannath? Katrina, you're supposed to be on the stage. I don't know why you're in the audience.
Carbon dioxide in case of Glen's procedure. Sir, how will you interpret carbon dioxide in ABG in Glen's procedure?
In Glen procedure?
Yeah, if it's increasing or decreasing.
Okay. PCO2 is a very, very sensitive indicator of pulmonary blood flow. So any changes in the level of PCO2 usually gives first indication that the shunt is either overflowing or the shunt is underflowing. Both of them can produce changes in PCO2. This is keeping in mind that the ventilatory parameters are all perfect. I think
Dr.
Another small comment that if you keep the bell of the endotracheal, bell of the stethoscope on the endotracheal tube end on, you can hear a continuous murmur very well.
yes,
As regarding shunt is blocked and not.
yes,
And,
that's
and if you have got end-tidal CO2, end-tidal CO2 should come normal if the shunt is functioning well. Low end-tidal CO2, don't be happy. That means the shunt is blocked.
that's correct. So you got your answer?
Thank you.
I think one of the most important things is to understand what Dr. Jagannath has said, that a blocking shunt is a medical emergency. So speak up. The nurses should speak up and make it, they think that there is a problem. The acceleration to call the whole, the team to intervene is vital, because the patient is going to die soon if you don't act fast.
Okay.
Same thing for a PA band. A PA band is notorious for a child just dropping
Exactly.
down dead if you don't keep a close watch. That's where the nursing is very important. Subtle signs of flaring of the nose or this thing, something like that can be the first indicator before, and these children just drop dead.
Okay. Thank you.
Dr. Jagannath will have the.
Thank you, Jagannath sir, for discussing the hemodynamics of the palliative surgeries for patients for whom the corrective surgery is not amenable, and how this physiology helps us to manage these patients post-operatively. We have Dr. Anil Tendolkar with us. He's a renowned pediatric cardiac surgeon from Mumbai. Sir, we welcome you on the dais for your talk. Yes, sir. Sir will be talking about the anatomy and the physiology of the cardiovascular system.
Just as a note, there are 4 generations of cardiac surgeons inside here, with Dr. Tendolkar being the first one. I can see my student, I can see I'm sandwiched in.
Thank you, Annie Arvind, for the kind words. Let me confess, I'm not a pediatric surgeon, and I'm mainly an adult surgeon. I'm sincerely thankful for inviting me for a pediatric ICU conference. At the outset, let me apologize for being late. And you all will agree that anatomy should have been the first topic. It is like prayer to the God, and then you proceed. But just because of my schedule, I am very sorry, extremely sorry. Can I have my slides, please? I'm supposed to complete the anatomy of heart in 15 minutes. So I will try my best. It will be almost one-liners per slide.
By the way, while sir is getting ready, he may say that he's not a pediatric surgeon. Trust me, I learned my pediatric surgery from him.
Thank you, Prasanna. But in the current scenario of pediatric surgery, it was not pediatric surgery. It was a congenital heart surgery. More of congenital heart surgery than pediatric surgery. Anatomy of the heart. ये मेरा नहीं है. Anil T. नीचे हाँ Anil T. Anatomy. Thank you. Heart. Adult heart is a 4-chambered heart, and the heart is, how do I go to next? Here. Okay. Adult heart is a 4-chamber structure, and it is situated on the diaphragm with the major cardiac mass to the left, and it is surrounded by pericardium. All it means, peri means all around, a structure all around the heart. And anatomically, this will elaborate later on. The heart is between two lungs. The heart, out of the four chamber, the atria are posterior and superior structures. Is there a pointer? Oh, this is the pointer. Atria are superior structures, and even though you say right atrium and right ventricle, the right atrium and right ventricle are actually anterior and to the right, and left ventricle and left atrium are actually left and posterior. This is always should be kept in mind. Particularly, I am told there are some OT nurses, OR nurses also, or no OR nurses. If there are, they should always keep in mind that if anywhere surgeon is opening an RA, it is always a chamber very near, and LA is posterior. So accordingly, the instruments should be provided. The atrium receives systemic blood. The blood coming from the body is called systemic blood. And the part of the body above the heart drains into superior vena cava. This blue structure which you see is superior vena cava, pointed over there, formed by two brachiocephalic veins. As the name suggests, brachios means arm and cephalos means head. So there are right and left brachiocephalic veins, which in turn will have one brachial vein, that is subclavian vein, and a cephalic vein, that is the jugular vein. Very interestingly, as if for ICU nurses and intensivists, God has made the right internal jugular vein, the right brachiocephalic vein, SVC and RA absolutely in straight line. Just see, as if it is made for us. As a result of which we always pass a triple lumen catheter, or for ECMO, the venous catheter or the outlet or catheter always through the upper, not that you can't pass from the left side. See the angle the left internal jugular makes with the right. The inferior vena cava, very small portion is in the thorax, and it drains the body below the heart, and the heart itself drains through coronary sinus into right atrium. So this is a picture of right atrium. It has got a free wall which has been made into a window to show you inside, and inside you see a septum, interatrial septum. And the hallmark of this interatrial septum is this fossa ovalis. Don't get carried away by these medical terms. They are pure English words purposefully translated into Latin to impress everyone. So instead of saying oval shaped depression, we will get depressed. So we say fossa ovalis. So you feel, wow, some new fancy structure. Okay? The interesting part of this fossa ovalis, at the apex of the fossa ovalis, is this foramen oval. And this foramen oval is extremely important for maintaining the circulation when the fetus is inside mother's womb. After the birth, as the baby cries, the pressure changes and the left atrial pressure goes up, and you can see the foramen is not like this, but a flap-like structure. So they fall on each other. The two septae fall on each other and the foramen closes. Moment you hear a word patent, it means it's supposed to close, it has not closed. So when you hear patent ductus arteriosus, remember ductus arteriosus is supposed to close, it has not closed. Many of my girls, while saying patent ductus arteriosus, say patient ductus arteriosus. They think the patient with PDA is to be called patient ductus arteriosus. From RA, we come to RV. RV is made up of two parts, membranous part, that circular one which is shown over there, and a muscular part. And muscular part is divided into three. Inlet, as we enter the RV, under the tricuspid wall, body or trabecular, and outlet as the blood goes out. Mind you, these divisions are made by human beings, not made by God. God doesn't give VSDs according to textbooks we write. God creates the VSD, and this was not supposed to be a joke. Anyway, it was supposed to be a joke. Thank you. Thank you for appreciating the joke. Okay? So these are why I'm telling you this to the ICU nurse, because this is how the VSDs will be written down. So it only tells the operating surgeon where to look for. The inlet VSD will be easily approachable through tricuspid valve, while outlet VSD will be easily approachable from pulmonary artery. That's why these names are given. Another important part of it, I will talk to it little later. There are 4 pulmonary veins, and for convenience, we are called them right superior pulmonary vein, right inferior pulmonary vein, left superior pulmonary vein, and left inferior pulmonary vein. 4 pulmonary veins drain into LA, and see the distance they have to travel. Left-sided pulmonary veins hardly have to travel any distance, while the right pulmonary veins have to travel a long distance. So sometimes they get tired, and instead of opening into LA, they open into RA. That's why it is called PAPVC, partial anomalous pulmonary venous connection. As I told you, all that is right is anterior. So the easiest pulmonary vein a surgeon can see is a right superior pulmonary vein. Those 2 gentlemen and 1 lady, finish your pointing. So I can, because you are disturbing my concentration. Okay? Now, nomenclature itself is a huge task, and with people like Jagannath sitting in front of me, I will be little careful in telling you the nomenclature. The simple rule in pediatric cardiac surgery is there is no rule. That is a simple thing in pediatric cardiac surgery. Anything is possible. All I told you, heart is surrounded by pericardium. Heart may not be surrounded by pericardium. Am I right? It's called absent pericardium. Heart is situated on the diaphragm. Heart may not be on the diaphragm. Heart may be outside. So all varieties, everything is possible in cricket and cardiology. So remember this. So most important concept I want to give you today is AV valve, atrioventricular valve. So as there are 2 atria and 2 ventricles, we have got 2 atrioventricular valves. So the tricuspid valve, which we understand with 3 cusps, is called right AV valve, where the mitral valve is called left AV valve. Why I'm telling you, just little later I will tell you. And similarly, the veins, systemic veins coming from the body and pulmonary veins coming from the lungs. So the right atrium receives systemic veins. So right atrium is called systemic atrium. Have I confused you? No? I can go further. The right ventricle pumps into pulmonary artery. So it is called pulmonary ventricle. Left atrium receives blood from pulmonary veins. So it is called pulmonary atrium. And the left ventricle pumps blood to the body. So it is called systemic ventricle. Fantastic. You are really intelligent and good. No, I meant it. No joke. She thinks everything is joke. Next time I will make a sign to tell you it's a joke. Now let us come to this AV valve. AV valves are called apparatus. Apparatus is a small machine. So AV valve consists of this order. See at the bottom. Sorry, see at the bottom. Both the AV valves are asymmetrical. So anterior mitral leaflet is small, bigger in area, small in attachment. Posterior mitral leaflet is large attachment, small area. They are not equal. Same thing about tricuspid valve. The 3 leaflets are not equal like Mercedes-Benz sign. No, they are unequal. And all the AV valves, both the AV valves have got a structure called annulus. Attached to annulus, annulus is like a door frame. Attached to the annulus is the cusp or leaflet, that is the door. Chordae, papillary muscle and ventricle. So this order you have to answer, and the echo report will be in this order. So So both the AV valves will have annulus, leaflets, chordae, papillary muscle, and equally important is ventricle. And in congenital heart disease, as I told you, anything is possible. Anything can go wrong. The PML, the posterior leaflet, is divided into three parts: P1, P2, P3. And corresponding spots are called A1, A2, A3. And all the echocardiologists, cardiographers will report to you in terms of so and so segment is prolapsing, so and so segment is tethered. So this only to understand it properly. Very important, in congenital heart, there is no confusion. In India, there is a lot of confusion. This water belongs to which state? Two states fight as if they are USSR, Ukraine war. Like that they fight. In congenital heart, there is no fight. The AV valves belong to the ventricle. So the tricuspid valve belongs to RV and mitral valve belongs to LV. If LV goes anterior, mitral valve also will go anterior. And RV goes posterior, tricuspid valve also will go posterior. So the AV valve is a property of ventricle. From that, now we come to the valves of the great vessels. And this is the longitudinal section from the ascending aorta. Part of the ascending aorta which encloses aortic valve. And this part is called aortic root. This beautiful picture is drawn by Anil Tendolkar. So you have to pardon. Yeah, that was a joke, correct. So the aortic valve consists of, aortic root consists of aortic leaflets attached to the annulus. Just above the annulus, aorta is slightly dilated. It is called sinus of Valsalva. There are three leaflets, so there will be three sinuses of Valsalva, but there are only two coronary arteries. So there will be one sinus without coronary artery. And above that, point number 4, the sinus ends and a tubular aorta starts. That is called sinotubular junction. All these structures have suddenly become important with development of various aortic valve repair procedures in children. Otherwise, we never hardly bother about such a detail about aortic valve. As against AV valves, the aortic valve and pulmonary valve are identical, same three leaflets and like three pockets. Just imagine my shirt had three pockets, so you can see the three pockets, and these pockets finally will be joined on both the edges will be joined. This is how an aortic valve and pulmonary valve will be seen. Aortic valve, pulmonary valve have got identical structure but for the coronary artery. That is the reason why we can do a variety of repair procedures in children using pulmonary artery as the valve. Or you can do a switch, simple arterial switch. We can just simply switch the outer artery because the valves are identical. And this is how it actually looks in a heart aortic valve. And that is the membranous septum just below the aorta and the mitral valve. Oh, sorry. Coronary arteries, there are two coronary arteries. Both take origin independent, have got independent origin from aorta. Every word I am speaking has possibility of something else happening. So instead of two arteries, there could be one artery. Both arteries originating from aorta, one artery could be originating from pulmonary artery. So all sorts of varieties can happen, and you will have congenital heart disease affecting coronary artery. They are either of origin or of the course or of the termination. Instead of terminating into the muscle, they may terminate into the lumen of right atrium or right ventricle. Just like AV valves, coronary arteries follow LV. And fourth component of a heart is the conduction system. and for which I wish to introduce you the concept of syncytium. Are you aware? Syncytium? Obviously, you are not aware. Syn means together and cium means tissue. Though we say there are 4 heart chambers, both the atria contract together and relax together. Both the ventricles contract together and relax together. So, functionally point of view, there are only 2 syncytia, atrial syncytium and ventricular syncytium. And though in pictures and actually atria and ventricle are in touch with each other, like India, Pakistan, they don't talk with each other at all, except Wagha border, where the 2 countrymen can cross, and that is AV node. So any operation performed around AV node is likely to damage the conduction system. So this is a list I have provided: primum ASD, AV canal operation, VSDs, Epstein, and in adult patients, aortic valve replacement and TAVI, trans-aortic valve implantation. If it's done, they are likely to damage conduction system. That's why in ICU, you will never see RA pacing wire and RV pacing wire. They will be called atrial pacing wire and ventricle pacing wire. You don't require wires for 4 chambers. You just require 1 wire, 2 wires for atria, 2 wires for ventricle. Understood? That's the reason, because they work as syncytium. This, I think, will ease your understanding. The cells which are in future going to form heart, when our mother's embryo gets fertilized, these cells come together, form a tube. This tube fuses in the center, and see that fused center? You have got atrium, ventricle, and truncus. Truncus is a combination of pulmonary artery and aorta. And this further gets bends and folds, and more important, it undergoes partition. So simple. Partition vertical, partition horizontal. Horizontal partition are AV valves, vertical partitions are atrium and ventricle. So any of these partitions do not happen, or happen but do not fuse, or they develop in wrong direction, that will result in formation of various intracardiac defects. Last is circulation. All of you are fully aware of the circulation. I want to tell you, most important, that don't say blood goes to lung for purification. Give up. Do you ever say that? Blood goes to lung for gas exchange. Oxygen is absorbed and carbon dioxide is thrown out. Both are important functions, remember. Another concept from ICU point of view nowadays you must have is right heart and left heart. The one which you see blue, the terminal part of SVC, RA, IVC, RV, initial part of pulmonary artery is right heart. And the red color structures which you see, terminal part of pulmonary vein, LA, LV, and initial part of the aorta constitutes left heart. So nowadays you have got right heart bypass, left heart bypass set up in ICU. So remember, you must have a concept that heart, though we call it heart as one, actually it has got 2 hearts. And remember, the normal cardiac circulation is a cross circulation. And oxygenated blood must go to body for deoxygenation. It is not oxygenated blood should keep on oxygenating and deoxygenated blood should keep on deoxygenating. That's what happens in transposition of great arteries. These are the pressures in various chambers of the heart. You can take a quick photograph. Okay. Now, are you aware of these words? Regurgitation. Blood passing in reverse direction of a physiologically connected chambers is called regurgitation. And blood passing between unphysiologically connected chambers is called shunt. So LV to RV is shunt and LV to LA is regurgitation. I had shown you this photograph to tell you that heart is between two lungs. Correct or wrong? Physiologically wrong. Physiologically, the lungs are between the hearts. You have got right heart, blood goes to lung, and from lung, blood goes to left heart. So if right ventricle pumps too much of blood into the lung, right ventricle pumps blood at a higher pressure in VSD, the lungs will be damaged. Too much of blood under too much of pressure. Similarly, if the left ventricle fails, left ventricular end diastolic pressure will rise and there will be a traffic jam backwards. So from LV to LA to pulmonary vein to pulmonary capillary and pulmonary edema. So from physiological point of view, just keep in mind that the lung is between two hearts. If you remember this, you'll appreciate the various problems associated with cardiac surgery. Thank you very much for a patient. Supposed to answer questions? Any quick anatomical, physiological questions? Thank you.
Thank you, sir, for taking us through the basics of anatomy and physiology of this complex organ heart in such a simple way. Now I feel privileged to have the opportunity to invite on dais Dr. B Vijayalakshmi, the first lady cardiologist of Karnataka, and discuss the pathophysiology of congenital heart diseases.
It's not there. Yeah, that's the one. This one here, yeah, okay. Om Shri Gurubhyo Namaha. Always, whenever the master blaster Tendulkar has batted, all over the world, everybody feels very difficult to bat. But today, after the master, not blaster, the master of master teacher, Tendulkar has spoken, my job is very easy. I'm very happy to speak because whatever anatomy is defective, it becomes a pathology. So you have all understood the anatomy. So my job is very easy. Congenital, the word has come from Latin word. The con means together, genitus means from birth. So congenital heart disease is usually defined as the structural abnormality of the heart or intrathoracic vessels present at birth. And abnormality in cardiocirculatory structure presents even discovered in, it has gone. Okay, abnormality can be detected at birth or intrauterine life itself with the fetal echocardiography. So the heart beats, you all know, 80 per minute. So per day, it is 1,15,000 and throughout your lifetime, unimaginable. And what is more important that it pumps almost 5,000 gallons of blood every day. And the amount of fuel required to pump that, with that you can take Queen Elizabeth ship from London to New York and back to London. And that's the amount of work our heart is doing. And when anything goes wrong, then it becomes defective, and that is the pathology. So here it's simple, as he has told. It has got only 4 chambers, 4 vessels, and just 2 partitions, 1 cover, and then under the rib cage. So anything goes wrong in between this, that becomes the pathology. So with each beat, the blood that is pumped, it goes into 60,000 miles of blood vessels. And that means going round the world 1.5 times with every beat. And that is the incredible work that the heart is doing. And when something goes wrong in any part of the structure of the heart or the blood vessels, then that becomes pathology. So here, this is how, the heart is the best example of the perfect harmony in the world. The perfect harmony in the world, because whatever the amount of blood is pumped from the right ventricle, the same amount comes back to the left, and the left pumps the same thing to the systemic, and that comes back. But when there is a defect in the septum, whether it's the atrial septum or the ventricular septum or the arterial, whatever the structure that Dr. Tendolkar has told, if there is a alteration in that, that leads to the pathology. And the master cardiologist is Joseph Perloff. When he spoke about to the 1,000 cardiologists in Hyderabad, when I was a postgraduate, I took the autograph of him. He was quite old at that time. With the trembling hand he gave. But then later on, he wrote the foreword to my book, Comprehensive Approach to Congenital Heart Disease. So that's how we know it's a relay race. The teachers, they teach the next generation and the next generation. So I congratulate this for having this program. So when we come to the etopathogenesis, the factors that can affect are 1, genetic, the 2, radiation or drugs intaken in the first 3 months of pregnancy, intrauterine infections, or the rheumatic heart patient is taking anticoagulants and then her fetus gets the problem, and then lifestyle changes leading to obesity, cardiometabolic syndrome causing premature coronary artery disease or cardiovascular problem, and a diabetic lady can have the baby with the congenital heart disease. So this is how these are the causes. So the pathology is the abnormal physiology states, specifically the functional changes that occur, a particular syndrome or the disease occurs. So all this can happen in the first 3 months of pregnancy, and the ectopia cardis, which we talk about now, 3,000 years back itself, it was described. And that's how we know all the defects can occur in a syndromic patient. So now we'll start taking what are the factors that can change. Either the maternal factors like rubella syndrome causing the PDA, pulmonary stenosis, VSD, ASD, or maternal drugs like lithium, now they are banned, then thalidomide and the fetal hydrontine syndrome, and these are the conditions that occur. But what is most important that all the women, all the people should understand is alcohol abuse. The alcohol abuse has become the number 1 because lithium and all those things are not there. And the alcohol, when they consume, the fetal alcoholic syndrome occurs. Not only the brain and the face becomes abnormal, and what they get is 50% of them get VSD, ASD, tetralogy of Fallot, or coarctation of aorta. So that is the most important thing that everybody should know, that alcohol consumption during the pregnancy is not good. Then apart from that, the sex hormones and the other drugs also can cause the congenital heart diseases. Now, formerly when the religion was strong and the science was weak, the men mistook magic for medicine. But today, when the science is strong and the religion is weak, men mistake medicine for magic. Today, whatever interventions we do, whatever the pathological changes, we correct them, and that, it looks like a magic because there is no scar, nothing. And when Krishna Paramatma was telling about the Chakra Vyuha, the fetus inside, the Subhadra, it was saying, yes, yes, yes. But then we thought it is a mythology. No, Today, whatever is happening in the fetus, we can do the fetal echocardiography and detect most of the diseases. For example, in this patient, you can see that I have done the echo, AV canal defect is there. When we do the blood karyotyping, we know that it is a Down syndrome. And then we explain to the parents that this is likely to have a Down syndrome because it is genetically proved. And then these are the features. And even if we correct the AV canal defect, we cannot change the mental and the other features. And as a result, these are the features that we see usually. And as soon as we see the Mongolian EDC, the facial expression itself, we can make out it is the Down syndrome. Then we come to the Noonan syndrome. You can see that the webbed neck, the neck is so classical, and the hypertelorism. That means in between the two eyes, the distance is wide, and that is called as the hypertelorism. And these children will invariably 50% have the pulmonary valvular stenosis and other defects like AST, VST, and hypertrophic obstructive cardiomyopathy. So the moment we look at the child's face, we know that this is the these are the things that are likely to be there, and then we try to evaluate that. The Williams syndrome is alpine faces, the mental retardation, and typically they have got the pronounced features, and this alpine faces is classical. Apart from hypertelorism, the spatulous lips, and then the malocclusion of the teeth, and all these patients, they can have kyphoscoliosis, supraaortic stenosis, and then along with that, they can have pulmonary stenosis, VST, and AST. So these are the pathological things that we can see in the Williams syndrome. Then we come to the Ellis-Van Crieveland syndrome. Here, dwarfism is there. You can see the child, the dwarf. Then polydactyly, you can see that 6 fingers are there than the toes. And then the syndactyly, and all these patients can have the other symptoms. And this is how the moment you look at it, whatever the abnormality you find outside, they are the indicators for us to see, look into the heart, and that's how we make the diagnosis. The Holt-Oram syndrome, you can see that the hand is folded. When we take the X-ray, you can see that the absent of the radius is there, the clubbed hand, absent radius, hypoplastic first metacarpal, all this indicate that it is a Holt-Oram, and invariably they'll have the atrial septal defect. And this is the Marfan syndrome. When you look at the stature of the patient itself, you can think that it is a Marfan syndrome. And then when they fold, you can see that the thumb is coming beyond. And that's how we know it is called as the Steenberg thumb sign. And then apart from that, you can see that the arms are so long, almost touching the knees. And that's how Arjuna was supposed to have the long arms. But this is the Marfan syndrome. You can see the fingers, how they are. The moment you look at the patient, you know it's a Marfan syndrome. Coming to the rubella syndrome, invariably they are born with the congenital cataract. And this is the extreme form of rubella syndrome, where the eyes themselves are absent. And invariably, these people will have the microcephaly. And apart from that, pulmonary stenosis, peripheral pulmonary artery stenosis, VSD, and the PDA is very important. And they can have an intrauterine growth retardation, and all other problems will be there when there is a rubella syndrome. But thanks to the rainbow thing, in vaccination, now rubella syndrome has come down considerably. Now, 5 basic questions one has to ask is the patient cyanotic or not cyanotic? That's the basic question. So then we divide into cyanotic and non-cyanotic. Is the pulmonary artery flow increased or decreased? Or which is the dominant ventricle, right or the left? And then all the pathology, it lies on this. And this is what Paul Wood's 5 principles are given. So we divide into cyanotic, acyanotic, and beware of the duct-dependent circulation. Because the moment duct starts closing, suddenly the child deteriorates, and that time the nurses and the doctors, everybody becomes panicky. Within 24 hours, the child will start deteriorating. So the first thing that all the nurses you should carry in your pocket is the oximetry. So oximetry is the 5th limb, and here clinically the nails and the lips, they will be blue, but any saturation which is more than 94, no need to panic and call for the help. And when it goes down, the gold standard is If it is the fifth vital sign, and the moment it is less than 90, you have to call the doctor for the attention. So congenital cyanotic heart admixture occurs at 3 levels. One is at the atrial level, and there the first one is the total anomalous pulmonary venous connection, tricuspid atresia or mitral atresia or common atrium. So here the mixture of the pure and the impure blood is occurring at the atrial level. And the next one is the ventricular level, where there is a single ventricle, tetralogy of Fallot or double outlet right ventricle. Here the admixture of the oxygenated and deoxygenated blood is occurring at the ventricular level. And the arterial level mixing is in the truncus arteriosus. So here the physiological classification, we classify into tetralogy physiology, in that, or the transposition physiology, or admixture physiology, we say that the pre-tricuspid or the post-tricuspid. So pre-tricuspid are the total anomalous pulmonary venous connection, and the post-tricuspid were the ventricular levels or the arterial levels. So here you can see that we start with the inspection. As soon as you look at the patient, you have to see that if there is a chest retraction, you can see that how beautifully the chest retraction is seen. That means the moment you get a child with the chest retraction, that means that the left ventricular heart failure, and you have to attend very immediately. But over the period, the child can develop the chest deformities like the pectus excavatum and the Harrison sulcus, and those things are to be seen. Now we'll come to the pathology one by one. So the first one is at the interatrial level, and that is called as the atrial septal defect. So when there is the shunt at the atrial defect, invariably it is left to right shunt. But once the pulmonary hypertension becomes suprasystemic, it reverses. So it goes from the right to left. So that is the pathology at the atrial level. So when that pathology is there, there are different types of atrial septal defect that can be in the fossa ovalis, that Dr. Tendolkar showed you the fossa ovalis, and that place, if you have an AST, it is very easy to close with the device, and that's how you have to look for that. So the other features are very important. And here what is more important is today, without surgery, with the device closure, we are able to close the AST, and the ostium secundum AST is the commonest one. This is how we put the device and pull it back and then remove the screw and come back. And here you can see that he is the Kurt Amplatz, who is the invented the Amplatzer device, and today we are thankful to him. Hundreds and thousands of children without scar, without operation, without anything, they are totally normal. The first child that I did, now she has become a doctor practicing. So absolutely normal. And what is important is the nurses who are assisting us are very important. So the material given by them, everything has to be very clear. And this is how we know before and after you can see. In the past, we used to just do the 2D echo and then do the device closure. We used to have the residual shunt, but no more. Today, we have the 4D echo. Literally, we can see what is the shape and the size and how it is extending. Everything can be made out. And this is one of my patient where I did, you can see from the RA side, you can see from the LA side. You can see from above, you can see it from below. So all over you can see the rims, and you can decide whether you can do the device closure or not. This is how the 4D is actually looking into the heart. Now coming to the next common is the VST. Dr. Tendolkar showed you how the interventricular septum looks. So depending on that, you can see that if there is a hole in the membranous system, we call it as a membranous VST. And if in the middle of the septum, we call this the mid-muscular VST. If there are multiple, we call them as the Swiss cheese VST, depending on the type of subpulmonic, or subarterial, or subarterial we call. So depending on the position of the VST, we can decide what are the things to be done with the surgery, which have to be done with the device closure. So inlet VST and subarterial as well as a subpulmonic, they go for the surgical closure, and the rest of them can be done with the device closure itself. So this is the one of my first VST closure in 1998, and now he has become a chartered accountant. This is how, beautifully they become normal, and that is the way it is. Then we come to the PDA, that is the connection between the aorta and the pulmonary artery. And that PDA, initially we were closing with the coils. And sometimes the coils used to embolize. And once in 1997, Kurt Amplatz came out with the device for that. So today we have the devices right up to 16 millimeter, and the custom-made devices can be brought. And this is how, that is the PDA, and this is once the device is put, it is completely closed. So this is 100%. So for 4 millimeter PDA, Dr. Hiremath used to put 4 inches scar on the lateral thoracic. But today, we just put 2 millimeter nick in the groin, and even if the patient wears the bikini, nobody can make out the child had a heart problem. And that's the beauty of the intervention. And here you can see that our children used to be very tiny and the low weight. When I told Kurt Amplatz, our children are very less and their devices are bulky, he came out with the angle devices and then the ADO2, that is the Amplatz duct occluder 2. Now they have come out with the still smaller devices without polyester material. Newborn babies, even 900,000 grams babies, the PDA can be closed. And that's how the pathological correction can be done with the intervention. So here the pulse oximetry is very important, because anything less than 90 is cyanotic. Anything above 94 is all right. So any difference in the upper limb, lower limb has to be seen. So don't be happy by looking at the oximetry only in the upper limb, because here we can make out the central cyanosis. Clinically, the congested conjunctiva, that is important, and then the lips and the tongue and the oral mucosa becomes cyanotic, and then there will be clubbing and cyanosis physically, but then you have to see that it is recorded by your oximetry and tell the clinician. So here the transposition physiology versus they can have the decreased flow or the increased flow. So we have the 2-1, and those with the increased pulmonary flow, they'll come with the tachypnea, weight loss, and the failure to thrive, and then the congestive cardiac failure. So here in tetralogy of Fallot, the squatting is a hallmark. Almost most of the children, when they exert, they squat. And apart from that, here you can see that in the RV type, you have the tetralogy of Fallot, pulmonary atresia, DORV, VST, and the DTGA and the VST. And the LV type, we have where the LV predominance is there, and there we have the tricuspid atresia, single ventricle, pulmonary atresia, and the LSVC, that is the left superior vena cava draining into LA. Totally the child is cyanotic, and that has to be corrected. So the commonest cyanotic congenital heart disease is the tetralogy of Fallot. In this tetralogy of Fallot, we call tetra means 4. What are the 4 pathologies? They are the malaligned VST, overriding of aorta, infundibular stenosis, and the right ventricular hypertrophy. These are the 4 things, and because of 4 things, it is called as the tetralogy. Actually, it is a monology. Because of the malaligned septum, all these 4 things are occurring, and that's how it is called as the monology also. So bluish discoloration and all this can be made out on the echocardiography. In the DTJ, you can see that the great arteries are transposed. So the aorta coming from the LV has come to the RV. The pulmonary artery, which has to arise from the right ventricle, has gone to the left ventricle. So the transposition of the great arteries has occurred, and this is dangerous because the patient has to be treated or operated within 1 week, and then you have to be, the nurses have to be very careful, because anytime the child can start deteriorating once the PDA starts closing, and that's how we know it is very important to make the diagnosis. So here I'm showing the X-ray difference. Where there is a decreased flow, there is a oligemia, the lungs are dark. When there is an increased flow, that is the plethora in the DTGA large VST, then that is the lungs are flooded. And that's how we know, by looking at it, you can tell that the child has got the decreased flow or the increased flow. So this is called as the egg-on side appearance, because the pedicles are, great arteries are one behind the other, anteroposterior. And that's why pedicle looks narrow and the egg-like shape is seen. in the X-ray. And coming to the low saturation with increased flow, that we have the total anomalous pulmonary venous connection. So here you can, there are three types can be there. One is the supracardiac, you can see in that, and other one is the intracardiac, and other one is the infradiaphragmatic. Among them, infradiaphragmatic, where the whole confluence is coming and then coming below the diaphragm and going there, they are likely to get obstructed and they present much earlier. So these three types are very important to distinguish in the pathology. And this is called as the snowman in the snowstorm. That means because of the anomalous connection, the upper part also becomes roundish, and that looks like the snowman because the lungs are flooded with the increased flow. That is the systemic as well as the pulmonary flow. Both are coming to the lungs, and as a result, it looks blurred, and that is called as the snowstorm. So this is how the TAPVC looks like. And then we come to the Epstein's anomaly. Here, the anterior tricuspid leaflet is tethered to the interventricular septum and joins much lower. So the part of the right ventricle becomes atrialized and becomes part of the atria. So atria becomes huge and the right ventricle becomes very tiny. And this is the Epstein's anomaly. Here, the cyanosis in neonate appears after some times, and invariably they can have palpitation. And then when the ECG, there is a tall P wave, and this Helen tossing called is a Himalayan P wave. Himalayan means Himalaya peak is the Mount Everest, Sagarmatha, the tallest. And that's how you can see that the P wave is so tall. The moment you see like this, you have to think of the Epstein's anomaly, and that is the money bag appearance on the X-ray. Then we come to the truncus arteriosus. Normally, you have to have the aorta and the pulmonary artery. When they are together, only single trunk is coming. It is called as the truncus arteriosus, and the pulmonary artery is coming from the side. And there are 4 types, and here, this is how you can see that the second sound will be single in such a patient, cyanotic, and the cyanosis is inversely proportionate to the heart failure. If the heart failure is more, cyanosis is less. If the heart failure is less, the cyanosis is more. And here, this is the tricuspid atresia. You can see that you can have the pointer. You can see that this is how at the level of the truncus, I mean the tricuspid valve, it is atretic. That can be a thin membrane or a thick tissue. And once there is a tricuspid atresia, all the superior, inferior vena cava coming to the RA through the AST come to the LA and LV becomes predominant. And that's how we know this is the tricuspid atresia. And in the echo, you can clearly make out that there is a thick muscle tissue at the level of the tricuspid valve. Only one valve is there. It anatomically, it is tricuspid atresia. Physiologically, it is like a single ventricle. So the repair also will be like a single ventricle. And here the single ventricle, Dr. Jagannath was telling that the interventricular septum itself is absent. When there is a hole, we call it as a VST. When the septum itself is not there, we call it as a single ventricle. And the fish, they have the single ventricle and they survive. The man who eats the fish cannot survive with the single ventricle, and repairing becomes very difficult. So here, in single ventricle, both the bloods will go into both the PA and aorta, and when there is a normally related great arteries, we call it as a Holmes heart. Otherwise, they can have the transposition of the great arteries also. Friends, whatever the pathology is, we can correct it. But once they go into Eisenmenger's, nothing can be done. The most beautiful lady, Madhubala, she had a large VST, they had missed it. She went into Eisenmenger's, then she vomited blood and died. Then today, no child should have. Whatever the pathology, we can repair it or we can cure it. And that's how we know it is very important to make out that the child doesn't go into Eisenmenger syndrome and they have to be treated in time. When I became the pediatric cardiologist in 1998, almost 12.8% of them used to come with the pulmonary hypertension, and today it has come down less than 2%. That means the peripheral, the nurses and the cardiology, the physicians, pediatricians, all are detecting and sending them for the repair at the early stage. And this is how the knowledge has to be important, and it is the teamwork. Just understanding the pathology is not important. The nurses, the technicians, and the doctors, all of us, we have to work together to save the precious life. And that is the most important. So here, when we come to the familial, familial hypercholesteremia is another congenital defect. Here, the cholesterol itself production is more, 1,500. And the patient, they will come with the xanthelisma and this deposition of the cholesterol. And the youngest child that I have catheterized and operated is a 9-year-old child with the hypercholesteremia. And these children have to go for the liver transplant also. So friends, when I became I wrote for CSI, I wrote about the congenital heart disease. I said, children are unique and special creation of God, worth far more than any earthly treasure. Hence, they need the special care, and especially when they are born with the disabling heart diseases. Heart care in children requires highly skilled, dedicated pediatric cardiologists and cardiac nurses with the appropriate equipments and the technology to save the precious lives. And what is more important is, whatever you do to adult, it is only palliation. The lifespan is not changed. But when you treat the children in time, 65% of them can be completely cured and they can lead a normal life without any scar. And hence, we have to work together. We are the team. And I can say that God could not be there everywhere. And hence he created the mother who could take care of the children. But I go one step ahead and say, the doctors could not be there all the time. So they created the nurses who can take care of everyone. And that's how, round the clock you work to make the life better. And so to work vigorously for the cause of your country, job and family is duty. That everybody is going to do the duty. But to work voluntarily for the cause of the poor, downtrodden, and suffering is a charity. That's what the Sai institutions are doing. But to consider charity as duty and work vigorously and voluntarily for the cause is the nobility. And that's what the Satya Sai, Madhusudan, Sanjeevani hospitals all over the globe are doing. So thank you very much for your kind and the patient hearing, and thank you. When I started with only 10 beds in 1998. Now in Jaideva, they have a separate hospital for 300 beds, and that is the progress.
Thank you, ma'am, for refreshing the basics of pathophysiology of congenital heart disease and how simple bedside clinical assessment can help to understand the hemodynamics of congenital heart disease. Here, I must confess that our generation of the female pediatric cardiologists have always been in awe of ma'am, her dynamism and her skills. And if only an iota of that skills and dynamism can come in us, so we'll be truly blessed. Thank you, ma'am. It's an honor for us that you are here.
Thank you, Dr. Vijayalakshmi. I think I have a question. In one of your slides, you mentioned that consuming alcohol by a mother increases 50% chances of a congenital heart disease. How does it add if the father also consumes alcohol? Does the percentage increase?
In fact, if the father consumes alcohol, they have the sterility, the motility. Yeah, they don't have children at all. So that is still worse,
Thank you. Thank you for this clarity.
It's very famous, provocates the desire, takes away the performance. So father will not be performing. Father to be.
Thank you, sir. Thank you so much.
Now, I'm deeply honored to call upon our next faculty, Dr. Roman Gebbar, a highly experienced pediatric cardiac surgeon from Czech Republic, who will deliberate on the key physiological implications of corrective surgeries in congenital heart disease, the understanding of which is essential to guide the post-operative management.
Show me how to guess. Good morning to everyone. Ladies and gentlemen, Bangalore 25, more up, this one, yeah. Yeah, this. And this RG India should be, hopefully. Yeah. Start from the beginning. The lecture start.
Sai, Shiva, can you help? What is the problem?
Yeah, open it as a presentation. Should open as a presentation. Yeah, it is now. This you can use. No, there is no pointer. Yeah, there's no pointer. Okay, good morning to everyone, ladies and gentlemen. I am glad I am the last one in this block that all theoretical aspects of pathology, physiology, anatomy, and palliative procedure has been already said, that I can be really practical and take you to the theater. How can I move with this? I'm sure. Yeah. So I would like to take you to the theater and just to show you our journey through the left heart. As was said, the left heart is a mitral valve, left ventricle flow tract, aortic valve, ascending aortic arch. And I would like to show you some practical things from surgical theater. So any minute of these videos is usually 1 hour of surgery. Operation is not so short, like you will see. And we are doing these videos during surgery using camera, which is not so easy because you have a camera in your view, but anything is possible. And then we are just having these pictures, not only for students, but even for us, because in some complex anatomy, it's nice to have these videos for the next procedure if it's necessary. So, but it's not working, do it. Yeah, it's it. So, sorry, I can't hear it. It's special. I can't hear it. My computer can hear it here. Okay, this is mitral valve stenosis. I don't know how it's not possible for me to hear it here, but can be following this. So we can see the mitral valve through the septum, and now we see that mitral valve is stenotic. Actually, that's a big problem with the leaflets. You can see there's an anterior leaflet, and I believe there is a small hole in anterior leaflet and with the posterior leaflet. But the problem is when you test the valve is working, but the problem is the valve is not opening because of problem with papillary muscle. We are tethered together, and they are quite shorty and quite very short chordae, secondary chordae, like here. And the valve is not opening, especially posterior leaflet. So we are starting with assessing the valve, and then we need to make more freedom for the valve to open. Just remove what valve doesn't need for the valve function. Sometimes we need to open the space, just splitting the papillary muscles like here, to have the chance for posterior leaflets to have a space to go somewhere and open for the blood, which is coming from the left atrium to the left ventricle. So we are closing the hole in the leaflet, still more opening the papillary muscles, just splitting them. Be careful not to damage other secondary leaflet, which we open, which we cut, and then we'll open it's already closing and no much insufficiency on it. So we are happy with this. And this is a piece of pericardium, which we use for closing atrial septal defect. This is the operation at the end, and you see the heart beating nicely. And then we check all the procedures using the videos, and now you see on video how nicely the valve is now opening, and there is stop much stenosis and hole with in an atrial defect. So hole was closed by patch. So here is something very special. This is left ventricle, and you see the big mass in the left ventricle wall, which is tumor. It's quite rare. It's a benign tumor. It's almost always is fibroma. It's compressing the left ventricle cavity, the first. And what is the most dangerous thing on this tumor is that it's causing life-threatening arrhythmias. Usually it's ventricular tachycardia, sometimes ventricular usually it's ventricular tachycardia. And the only you can do for this chart is to remove this tumor, and then you are at first you are opening the ventricle not to be compressed by the tumor, and second you are reducing the risk of arrhythmias. So this is the tumor. You see the whitish tissue in the left ventricle, and now we are usually starting on beating heart, slowly removing the tumor, just excising the tumor, which is whitish through from the myocardium, which is pink. Not all the operation can be done on beating heart, so we stop the heart. This is here. We just flush the blood out from the heart to have not to have a blood anywhere, and then it's continuing. The white tissue again is a tumor, and the pink tissue is a ventricle muscle. So very carefully you have to do it, because at the end of the operation you need to have a functional good left ventricle. So it's not possible to damage any of this muscle, because you need it for the function of left ventricle and the end of the operation, of course, for the whole life. And you see how big the tumor is. It's almost the same size like the whole ventricle. And slowly, step by step, we are removing the tumor. At the end, you will see the diameter of the tumor is 4.5 centimeters and 3 centimeters. And we need to remove all the tumorous tissue. Sometimes we need to do it in steps, not in one piece, like here. And when we remove, you will see the big hole in the ventricle. It's just like someone bite it. So I need to reconstruct the wall of the right ventricle, not to bleed and to have a good function. So you need to close the ventricle in layers, not to have any hematoma in the wall, which is compressing the function again. And now we are inserting cardioplegia, and we can see any of the bleeding spots, and we need to treat them. So we are sure there is no bleeding inside. We will be closing layer after layer the whole left ventricle wall again. But you need to be reminded there's a systemic ventricle with a high pressure inside, that we need to be very cautious not to have any bleeding, because it's difficult to treat them because it's in the posterior wall. So this is the end of the operation. You see this, no bleeding at all. Now his tumor is gone. And now you see the function of the left ventricle, which is normal. So other important thing is left ventricular outflow tract obstruction. Here you see, I can't do it, sorry for that. you can see the valve and the ventricle, and there is a former patch closing VSD, and you see the colors. There is a severe stenosis just below the aortic valve, and this is a reoperation. And the plan in this operation to enlarge the outlet tract of the left ventricle, but do not destroy mitral valve or aortic valve. See, now we open ventricle. You see the pulmonary valve, and this is the stenosis. Actually, it's quite complex surgery, this one, because it's redo it. It's not first operation at all. Now we see left ventricle from the surgical aspect through the aortic valve. We see very tiny structure there, and we need to open the septum just below the aortic valve. It's quite difficult operation. You can do this from both sides, either through the left through the aortic valve or through the right ventricle, like we do right now. And we need to create a new ventricular septal defect, like we are doing, and put a patch. And using this patch, you are enlarging left ventricular outflow tract. It's a quite demanding operation. We see how aggressive we have to be incising the muscle in the septum. So this is the ventricular septal defect. And now we are using the patch to close it. And then this patch is enlarging the whole left ventricular outflow tract. This is the patch now. It's insertion of the patch right now. Now we check the left ventricular outflow tract through the aortic valve, and then we see it's free or not. It's completely free. It's no obstruction anymore, and we can do it. This patient, I don't remember the precise diagnosis right now, but he had a problem with the pulmonary valve as well, that we are replacing pulmonary valve by conduit with the valve. And now you see how enlarged left ventricular outflow tract is now, and good function of the left ventricle at the end. So next on is aortic valve. This is a neonate. You see that is a valve is quite small. This gradient through the valve is 90. It means there's a severe aortic stenosis. It's a neonate. You see the valve is a little different from when you see the valve later on. It's not matured, and it's that's the reason why the operation is difficult, because it's very fragile. What we need to do, we need to create a larger area of opening of the valve. So now we are splitting the valve to the commissure, and we need to be done very precisely. Otherwise, we can end with severe aortic insufficiency. Sometimes the leaflets are quite thick, and we need to shave them just to have a more space when the valve is opening. So at the beginning it was unicuspid valve. At the end we created bicuspid valve. You can see the bicuspid valve here, how it's opening now. So this was a neonate. This is now you see the valve function, which is nicely opening, and the gradient is of course less. But this is definitely not the last operation for this child. It's 100% that we need to do something else in the future, hopefully in adult-sized patient. The next is a little bit similar, but different in two things. At first, there is aortic stenosis, but at second, there is aortic insufficiency. And then even left aortic tract is narrowed. So the replacement valve only is not all we can do. And we have to do the Ross-Kono procedure, which is quite complex procedure. Ross-Kono procedure means that we need to replace valve, aortic valve by pulmonary valve, and replace the pulmonary valve by homograft. Now we are cut pulmonary valve and aortic valve, and we are just removing pulmonary valve for next use for aortic valve. Of course, the both orifices are not the same size, so we need to enlarge the annulus of the aorta to put this bigger pulmonary artery in. Now the autograft has been removed. We are looking inside the right ventricle. The next step is remove the coronary arteries, just because we need to reimplant them back to the autograft. And you see this was left, this is right coronary artery. We need to mobilize them to be able to put them back. Now we are excising stenotic valve, you see what we're doing. But we see the annulus and the outflow tract is pretty small. It's pretty small. This is causing the stenosis, not only valve, but this is the whole area below the valve. So we are opening widely to the septum, the outflow tract again. But this is more demanding. This is quite small charts. And then we need to, inside, there is no pink tissue like should be. There is a white tissue. It's called fibroelastosis. And this fibroelastosis is important because it's blocking dilation of the ventricle and it's causing diastolic dysfunction of the left ventricle. And we are trying to remove this porcelain, almost porcelain from inside, just to make the function of the left ventricle better. And now this insertion of the pulmonary valve to the aortic position. Slowly, we are using continuous suture for it. Now it's into place. And now we need to reinsert the coronary arteries and suture it to the ascending aorta. Now we are preparing homograph for pulmonary position because we need to replace the pulmonary valve with other valve. So now we are suturing the homograph to the right ventricle. And this is the end of the operation. We see homograph nicely work, and there is an autographic coronary reimplantation just below. So, and this is how is it after surgery. So I don't know, there was echo, but this is now is missing. There is other patient, this is interrupted aortic arch. At the beginning, you see dysfunction of the ventricles, a very large VSD, and there is this interruption of the aortic arch, which is interrupted by this 14 millimeters. Now we see when we now open the heart, we see a nice ascending aorta, but even smaller than pulmonary artery, and we are ligating the duct. This is critical congenital cardiac defects. It means that any of these children is born and must be operated in days. And of course, the children are living on open duct. So if the duct is closed, the patient is dying because the lower part of the body is supplied by the duct only. So we are now excising. Duct from the pulmonary artery, closing pulmonary artery, and now we are just dissect the descending aorta, to be ready to be anastomosed to ascending. So this is incision in the ascending aorta right now. So there's incision in the ascending aorta up to left carotid, and then we are suturing descending aorta to the ascending. So we are creating new arch again, which was missing before. Sometimes it's better to put some patch inside to have a larger structure and not so steep shape for the blood which is coming down. So we are just opening a little bit more by this plastic. So the interrupted aortic arch is almost always connected with ventricular septal defect. So the first is we need to repair the arch, and then we need to close the ventricular septal defect. Before we started to use descending aorta perfusion, we did this part of operation with total body arrest. We had to cool the patient to 16 or 18 degrees. Now we are doing with total body perfusion. It means no need to cool the patient so much. And now we are closing the ventricular septal defect by a running suture in this patient through the pulmonary artery. So in terms of repair, this is completely repair. This is anatomical repair. So it's a biventricular repair, and if the child is lucky, can be like an ordinary child for the rest of the life. Even the beginning of the life for this child was so problematic. Dysfunction of the ventricle and late diagnosis in this girl. So now it looks after the operations, just nothing special. Normal function of both arteries and normal arch. And then we see the closed VSD and nicely working. And then we see the flow through the newly created arch. And the last video I would like to show is a little bit special. This is hypoplastic left heart, which is not I am quite sure that many children with this diagnosis is born in this country, but it's very, very difficult to repair this patient. But again, this is not repair. This is a palliation, and it's a palliation for the whole life. So we need to speak with parents if they really want to have this palliation for their child for the rest of their life. And the majority of Czech parents decide not to operate on a mostly terminate the pregnancy, not to have a child with the diagnosis. So we are starting to create a shunt. This is a BT shunt, because the shunt will be at the end of operation the only source for pulmonary blood supply. And now you see the duct, and you see the nice small arch, but very small ascending aorta. So I mean, the complexity of the operation is that you are doing very long procedure in very little child, usually is a newborn, 2 or 3 days old. And at the end of the operation, you have palliation. You are not able to repair the defect because there's only one ventricle, the right one. The left one is either missing or hypoplastic. So there is a palliation. Palliation means that it's more demanding, not only for the surgeon to do, but even for postoperative care. There was a homograph tissue which we use for creating new arch and new ascending aorta. The first step is to enlarge the atrial septal defect, because we need the blood from pulmonary veins freely going to the right ventricle, not to have any obstruction for future Fontan operation. Now we are closing pulmonary artery, which is disconnected. And now we are just, we need to dissect all the vessels coming from the arch to the brain, and then descending aorta. Now we are opening the arch down to the descending aorta. This is cardioplegia through the very tiny ascending aorta. The ascending aorta is maybe 3 millimeters only, but the ascending aorta, because it's aortic atresia, is only like coronary artery. This is not normal ascending aorta. Now we are opening the whole ascending aorta, and using this patch, we are suturing pulmonary artery to the ascending aorta, and using homograph, we create a new outflow from the ventricle. It means at the end of the operation, you will have the atrial septal defect for mixing the blood. You will have the one ventricle, which is right in this case, to pump, to eject, and you need to be free flow to the whole body. And the pulmonary blood supply will be through the shunt, which is on the left. So using this homograph tissue, we are creating a new ascending aorta, a new arch. So for surgeon is quite demanding, but because at the end of the operation you have a low saturation, 80 something, you have a bleeding, you have a quite unstable patient because the only ventricle which is working is the right one. So, but it's the only chance how to save the children's life. The first it's called Norwood operation, but first Norwood was done in 1981, 84 maybe. So in 80s, last century. So, and that is the end of the operation. You see, there is one vessel only now. They are connected together from the heart, and now we are anastomosing. Yeah, we are anastomosing to the pulmonary. So this is the end of the operation, and this is how it works after that. So what is the passion for cardiac surgeon to do this? To have a healthy, smiling child at the end, because this is innocent smile you can't get from any of adult patients, you can get only for child. Thank you very much.
Thank you, sir. Now we break for tea. It is organized in the ground floor of this block at the Levine Gallery, and we assemble back after 15 minutes. Also, the delegates who have not yet registered, I request them to please go towards the reception and register, because that is important for your KNC credit points and for your certificate of participation.
पता है ना ऑन करना है
I request all to be seated, please. We will start off with the next session, that is Basics in Pediatric Cardiac Intensive Care. The small change in the program, Dr. Parimala Prasanna Simha, we had an emergency, so some of the team members have gone to the operation theatre. We'll call upon Dr. Anil Tendolkar to give his delivery talk on clinical science of adequacy of perfusion. And for this, the chairpersons, I would request Dr. Vishwanath Kamoji, the Deputy Nursing Superintendent Mary Rodriguez. In that, 3 of them have gone to the operation theatres. Dr. Nichani is here. Sir, I request you to chair this session. Dr. Marek is here. He's gone to the theatre. Kindly maintain silence, please. When a speaker comes on stage, please maintain silence. That's the respect you're going to show. Please understand. From morning, I've been observing, when speaker is there on stage, you'll be gossiping. You come here to learn. Kindly understand. We'll have a group photo at the end. People spend time down taking selfies, photos. Yes, the campus is very nice. I'll take you for a campus tour also. But here, time is very precious. We have 550 people sitting online also there. Please understand. And I request everybody to cooperate. Your nurses, life is in your hands. If this is the attitude, I don't know, it will be difficult. Discipline should come from within. From morning, I've told. I should not be after you. Come inside, learn. This should not happen, please. Over to Dr. Tendolkar, please.
That's why I put them in that order. Good afternoon. Nice to see you back in time from tea to meet the next tea, that is Tendolkar. So, as I confess in the morning, I am not a pediatrician nor a pediatric cardiac surgeon, but I always took interest in ICU management. So I thought I will share my thoughts about intensive care management. May not be pertaining to pediatric. Today's intensive care is like this, with machines. And the modern intensivist in the morning, if I ask him how is the patient, he takes a photograph and sends to me on WhatsApp that this is the patient. Now you decide how is the patient. So I thought there are few things all of us can know, doesn't require any costly equipment, can be practiced anywhere in the world, any corner of the world, any time of the day and night. So what does clinical means? Clinical means diagnosing something, doing something using your sense organs. So your inspection, your palpation, your auscultation, you can see the patient and say, this patient is bad. You can see the patient, hear about the patient and tell this patient is bad. So I am going to talk about this, aspect of nursing care. Then there are two words. One is circulation and another is perfusion. And very few people know what is perfusion. Circulation means blood going and coming. Like government schemes. Government gives money to the people. That is circulation. That money reaching each and every common man who requires that help is perfusion. So if the cells get nutrients, it is perfusion. Blood going and coming back is just simple circulation. Another very important word which I feel all the ICU nurses must know is trend. Trend is the way it is behaving. Respiratory rate of 18, normal, abnormal? Normal. 18 becomes 22. Normal, abnormal? 22? Normal. 22 becomes 28. Normal, abnormal? 28 respiratory rate? Normal. But if you see last 2 hours, a respiratory rate of 16 has become 28, it tells you it is abnormal. So this is the trend of any parameter is far more important than the absolute value. A patient with post-operative patient respiratory rate 36. Abnormal, normal, abnormal. Next hour 36, next hour 36, next day 36, 2 days later 36. Now, ayyo amma, 36, 3 divasa. Goes home 36. Eating very well 36. Now suddenly it becomes normal. Understood? So this is the importance of trend. And nowadays many scopes show you the trend. Trend of heart rate, trend of blood pressure, trend of respiratory rate, everything. So remember this word, trend. The ICU management, I always feel, should be preemptive. You should detect it early and react. Rather than reactive. Patient has arrested, as usual, patient always arrests suddenly. You know, sir, till you came, patient was fine. And after you came, patient became bad. As if Anil Tendolkar is the risk factor for that patient's well-behavior. So you should be preemptive. You should detect the earliest sign of problem. In cardiac surgery, post-operative nursing care, remember Big B. Girls from the south, who is Big B? Girls from the south. Big B? Sorry? Very good, thank you. Amitabh Bachchan will be happy that his name is known in the south as well. In United States of Tamil Nadu, they don't know Amitabh Bachchan. Really. So remember, Big B for cardiac surgery is brain, bleeding, BP, breathing, blood gas, bladder, bowel, bed sore, and of course, the bill. So let us start monitoring. Simple TPR, BP, I am going to discuss because only 15 minutes are allotted to me. First we monitor is temperature. Simple question, why at all we monitor temperature? And for that, we must know how heat is generated in the body. Heat is generated by cellular metabolism, which actually actively takes place really in liver, heart, and muscle. Skeletal muscles, when we are just now sitting in static state or shivering, it generates heat 2 to 5 times the normal rate. The body from heat point of view has got 3 parts. The core, the middle part, and outside part. The core is the place where the heat is generated. The liver, the heart is the core. It generates heat. And this heat slowly goes to the periphery. Skin is exposed to your ICU temperature. Skin is exposed to the operation theater temperature. So skin constantly gives out heat. So if the blood distribution from core to skin is good, then the heat will be easily transmitted from the center to periphery. So please remember that skin temperature and the core temperature, that is rectal temperature difference, is an extremely important parameter. Doesn't require any special gadget for that. You just put one rectal thermometer, put one skin thermometer, temperature telethermometer, and the difference is less than 1 or 1. It indicates a good perfusion. But still the question remains, why at all we monitor temperature? And very commonly the girls answer infection, sir. That's a very common answer given. Remember, infection ICU on the first day is the last thing you should think of. I'm talking about post-operative cardiac patient. Temperature is required more than 35 for normal functioning of left ventricle. And vice versa. If left ventricle is functioning well, temperature will be normal. Temperature is required for spontaneous breathing, and temperature required in the post-operative ICU for normal blood clotting. That is the reason why we must establish a normal temperature. Now, what happens in the operation theater? Tomorrow I will be describing, but just now, from temperature point of view, you must know that during cardiac surgery, patient is cooled down to 28 degrees centigrade temperature. In a complex pediatric cases, which were just now described, hypoplastic left heart, patient may be cooled to 18 degrees centigrade. So patients are cooled down, and during the period, patients are re-warmed back. End of the operations, patients are re-warmed back. This rewarming may not be adequate and uniform by the perfusionist. Number two, patient in the operation theater temperature is 18 to 22 degrees centigrade. Chest is open, patient is paralyzed. So patient constantly loses heat. So if the operation is prolonged, patient you receive in the ICU will be cold. And of course, if patient is in cardiogenic shock, patient will be obviously cold. So this is what I was telling you. There are 4 possibilities of rectal temperature and skin temperature. Permutation and combination, and this is the treatment to be given. The best thing is to have rectal temperature and skin temperature difference less than 1. So by simple logic, which part of the skin of the body you will monitor? Great toe. Before you give wrong answer, let me tell you the correct answer. Great toe. Why great toe? If heart is Delhi, great toe is Kanyakumari, farthest away from the center. So if the heat generated by heart is reaching the great toe, that means the circulation is working perfectly. The nutrition, the perfusion is excellent. That is the reason we put the skin temperature on the great toe. Am I right or wrong? All of you are keeping a mask-like face. This is not operation theater. You can remove your mask. Okay? So this is what answer I just know. Sorry. Second monitoring is pulse. And this is how you monitor pulse. We quickly look at the scope and write down pulse rate of 79. But before writing down, please make sure every beat is counted by the machine. So with every QRS complex, every pressure trace, depending upon how it is sensing, you must hear one poop, 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 poop. That means the machine is counting correctly. If you miss one, machine will calculate almost 13 beats less. So that is the first thing before mechanically writing down that the rate is 79. Number 2, rate should be with respect to disease and age. Children have higher rate. Valvular heart disease always have a higher rate as compared to coronary artery disease. And this is thanks to one Dr. K.R. Balakrishnan, who was my colleague. He developed this sign. It might have been described by others, that in a patient, the value of the rate should be less than the value of the blood pressure. So if a patient has got 90 rate and 100 pressure, this patient is better than the other patient who has got a rate of 100 and BP of 90. Have you understood? Are ha na bolo na. Ladies take time to say, yes, I know that. But this is something you can quickly say, yes. Am I clear? So remember, just don't go by rate. Also relate it to the blood pressure. So rate of 70 and BP of 110, excellent. But suppose it is rate of 110 and BP of 70, then it is no good. Then these are the standard things about the rate, which unfortunately our nurses, all nurses, nothing wrong with you. The chart system is like that. You always write down rate, 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 and rate. But these are the things you must also note down, whether it's regular or irregular. And most important, if you are feeling the pulse, same rule of the great toe temperature, same rule. The real pulse you must feel is dorsalis pedis pulse, farthest away from the heart. This is the heart. This will be airport. If this is bus, this is what? Devanhalli. No, Devanhalli. Muddenhalli. If this is Muddenhalli, this is airport. Understand? So feeling this femoral pulse, carotid pulse is nothing. If you reach the southern end of Bangalore, Tumara Jaideva, then this heart is beating well. So remember that pulse ox ideally you must have on the great toe. Nothing wrong in putting on index finger or thumb, but farther away from the heart you put and you get a pulse, that is a good sign. Third aspect of monitoring is respiration. And again, all my girls spend time in rate. Correct? Because that is the chart. Am I right? Or yes or no? So that is the chart. But remember, this is also equally important. A patient's rate may be 16, but if the 16 is 3-4 breaths, then no breath, again 4-5 breaths, then again no breath, then this is not a good sign. The rhythm is important. Mechanics is important. We never use our accessory muscles during breathing. Patient should be never restless during breathing. Just now, are you restless? Maybe because of my talk, but otherwise you should not be. You are breathing normally. Patient should not be sweating. Look for forehead sweating. And all of us wrongly feel, AC band hai na, isliye sweating. No, always relate it to the heart and hold it responsible for that. And last sentence at the bottom is my very favorite sentence. Look at each other right now. Right now you look at each other. Can you, ayo, not the face, breathing. She's looking at her face. Do you see each other's breathing? Normal breathing, you have to really observe. You have to keep a hand to see whether the patient is breathing or not. In all our movies, if the heroine starts breathing like this, you know she has seen the hero. Abnormal. Understand? So remember, breathing seen, breathing is abnormal. Remember simple rule. This is clinical. The Pandits over here may challenge me and they will give me some reference, I am sure. But remember, a normal breathing is just not seen. Remember your lifetime. Now, off ventilator in children who are operated because of fracture of the sternum or fracture of the ribs, there is always some amount of blood in the pleura, giving rise to pleuritis. And of course, in children, smaller the baby, the ribs are already horizontal. Normal ribs, adult, are oblique, and they help in increasing the tidal volume. And again, what I spoke earlier, trend is important. I had given you example of respiration, other rates. So respiratory rate, the trend is important. How the trend is increasing, decreasing, or settling. Last is blood pressure. Simple question is why monitor pressure? Because the pressure is required for brain function, and most important, pressure is required for renal filtration. Unfortunately, we just write only the systolic pressure, or in pediatric cases, they write down the mean pressure. But according to me, simple pulse pressure gives you a very good idea about the perfusion. And pulse pressure is systolic pressure minus diastolic pressure. Oh, you know already? Nice, good. And you said yes also quickly. Normal pulse pressure is 40, and more near this 40 a pulse pressure goes, better is the patient. So if you have a patient, two patients, one patient with a BP of 100 by 80 and another patient is 90 by 58, I'll be far more confident about the patient with 90 by 58 because the pulse pressure is 32, while the other pulse pressure is just barely 20. And again, same thing, look at the trend. Patient is brought from the OR, operation theater, pulse pressure will be narrow, vasoconstriction, but as the patient settles down, 20 should become 24, 30, 32, and settle somewhere at 36 to 40. So remember, pulse pressure is important. Another thing, before recording the pressure, look at the tracing. That is the reason many of us, we used to say that if no tracing is seen, that pressure is not acceptable. See the quality of the tracing. See the upstroke. See how the blood pressure is going up? Almost 90 degrees? Yes or no? Cardiologists will immediately tell you dP by dt. We should not get deterred by the dP by dt. Upstroke, it should go quickly up. And see the peak. There is no rounding off effect. Goes up, spike. And while coming down, it gives you a small diacritic notch. So if you see this tracing, don't have to look at the value. If this is a tracing of a patient with a BP systolic of even 80, 90, I will not look at the patient again. So remember, don't just go by the value. Look at the tracing as well. And these are the things which tell you. So now coming back to this picture which I had taken you, I have shown you, this patient is good or bad? I have operated, so patient has to be good, very good. So why it is good? Rate is 79, but the BP is 120. So as per our rule, rate and BP reverse, lower rate and higher BP. See the pulse pressure, 120 minus 60. You can do this calculation without calculator. Huh? I can see her bringing out calculator. No, good. So pulse pressure of 60. So this all things should help you in telling that. And see the tracing quality? See the upstroke? See the peak? See a notch on the diastole? So all this indicate patient is good. Another thing, small things, remember a restless patient may be because of hypoxia as well. Always correlate it with the heart. Urine output more than 1 ml per hour in pediatric condition indicates patient is good perfusion. And another very, very important parameter we overlook, we constantly talk about arterial blood gas, is venous blood gas. Arterial blood gas is people going to movie. Venous blood gas, people coming back from the movie. Who will tell you the movie is good or bad? People coming back will tell you whether the movie is good or bad. So remember, venous saturation tells you how much the cells are consuming. Normally, nourished cell, if a cardiac output is good, just takes out 30 to 35% of oxygen. So another simple parameter, of course, this is not clinical. Immediately, my friend Prasanna Simha will jump on me and he'll say it is without using your sense organs. But same blood gas machine, where you constantly concentrate on arterial gas, venous gas will tell you. So remember, cardiac surgery, adequate whole body perfusion without any unnecessary demand on heart, and detect the deviation at the earliest. Thank you very much.
Dr. Tendolkar, thank you for that second masterclass. Does anybody have the guts to ask a question? Oh yeah, he knows.
I will hold the gun. Anybody has got any question? No.
Sir, I just wanted one point in that four thing which you had put. There, temperature up, rectal up, skin up. That one which is not possible. The only thing is that as far as nursing goes, an improper what do you call it?
Temperature probe.
No, not that thing. The light, the heater light. If the feedback system is wrong, you can end up with cooking the patient externally. So the nurses have to be careful when they see rectal down and skin up. We can burn the patient.
We are talking about good nurses, not at Medeva.
No, but the machine feedback may be wrong.
Good nurses at Madhusudan Sai Institute, they will not have. But what he said is perfect. If you keep your probe right under the heating light, the skin temperature will be much higher than the rectal temperature. My whole point was, instead of using some costly gadgets, standard temperature monitoring, temperature pulse rate, blood pressure monitoring, these are the extra things which will help you in making sure patient is well perfused. Okay.
Thank you. Thank you, sir.
Thank you, sir. This is absolute pearls of wisdom, which I think everybody will take home from here. Thank you very much.
We'll call on the next speaker, Dr. Prasanna Simha, for the topic on chest X-rays, a must-know for the nurses.
I just have a question. How many of the nurses are seeing the chest X-ray? Raise your hands. Raise your hand. How many of you are seeing the X-rays of your patient? Please raise your hand.
You can ask this question to doctors also.
Yeah, doctors are definitely. Prasanna Simha, chest X-ray for intensive care. No, it's very important because this is something which is not done by. See, many times X-rays are taken and not seen by anybody, and that's an ongoing problem that we have. Now, I want this interactive because it's no point in me. It's not me telling this thing. Can you all have a look at this X-ray? This is an X-ray. Can you see something? I want people to talk. What do you see in this X-ray? Over penetrated. Anything else? Heart is not seen. Anything else? See, this is very important. Lung shadow is not the same. Then clavicle is down. Okay. Then ribs are this thing. Okay. See, so we can go on and on and on, but I'd like you to see something on the top. Can you see there? No. The hand is crossed, but what is that there? Systematic viewing of X-rays. By the way, do you know who this is? This is Tutankhamun's X-ray. Tutankhamun is a mummy. This is the dead body. That is the X-ray of Tutankhamun. And that is, they used to break the hand to be able to keep the hands in position of the mummy. You can see there on the top the fracture. This is a mummified body. So the heart is eviscerated and this thing. So the thing here is why I show the fracture is everybody saw everything. They said there's no heart, heartless fellow like I am. But it's the importance is in systematic examination of the patient. You will miss things which is there. Now, coming to the nitty-gritty, chest X-ray, bone is white in the normal type of X-rays. Air is black. We can invert it in modern X-rays. Tissues are various shadows of intermediate density. So if you remember that bone is white, air is black, tissues of intermediate density. So what did I tell you? Follow a schema. And this is the schema. Everyone should develop a scheme of examining. See, for example, a nurse, when she comes to see a patient, she should have, in my mind, I'm going to do A, B, C, D. Similarly, a doctor must say A, B, B. Why? When you follow a protocol, you will not miss things. So this is my scheme, which I show to my students and my thing, and I tell them, look at it this way. And I will walk you through the logic of my process. My teacher goes through another way, but this is the one which I was doing. He also does it with this thing. So we will go back to this, and I will tell you what I will tell you this, but please remember, you can always, I will give you the lecture at the end of the day. Now, most of the ICU nurses get what is called as a portable X-ray. Now, all of you have seen YMCA, no? You've heard that song? No? Yes. Tell yes if you have not even heard it. So, now the normal X-ray, which is 6 feet away, you've learned in optics in PUC, if you remember your PUC, that you consider the lines of light as parallel if it is at least 6 feet away. But we don't take it in the X-ray suite, we can take it 6 feet away. But here you don't. So now what happens? The rays diverge like this. Now, if I'm standing here and the ray is diverging, she is being magnified. So remember, everything in the center is getting magnified. This becomes important because, and it is coming from anterior to posterior, whereas in the X-ray room, posterior to anterior. So heart looks bigger, the scapula comes into the field, and this is the commonest X-ray taken in the ICU. And unfortunately, all these are problems when you compare it with the previous pre-op X-ray. Remember, as sir was telling, trend. So even in X-rays, a trend. This X-ray, what was the pre-op X-ray, what is the current X-ray, and daily X-rays which are taken are to be seen. Now, what to look? The first thing that you have to see is there is a marker on the X-ray. Please see whether it is right or left. Today with digital X-rays, it's less often seen, but then people have put the X-ray in the wrong way. Remember, as I said, everything can go wrong in cardiac surgery, and you can have patients with dextrocardia. So very, very important. Then when you have to see whether, I'm sorry for the spelling mistake, but it's exposed well or not. Now, if normally see you have air, what did I say? Air is black. Now, and so if I have air in the trachea, the trachea is up to T4. So up to there, I can see air, and below that, nothing. There is a thing. So if I see bone through the heart, it's a hard plate. In cardiac X-rays, you may have a hard plate, but then ideally you should have the correct exposure. But so if you see whether it is overexposed, the lungs are not well seen. Because why? More is going in, so it looks more black, and the spine becomes more this thing. Now, the first step that I say is, my way of going about is place the organs in the right place. You've got an X-ray, place the organs here. So normally liver is on your right, and the stomach bubble is on the left. We'll go through this. And major part of the heart shadow is on the left. If the major part of the heart shadow is on the right, if the liver bubble is on the opposite side, if the structures are in their normal place, it is called as correct, situs solitus. And if it is inverted, it is called as inversus. So you can have situs inversus and this thing, see by the stomach bubble and the liver. And if the major part of the cardiac shadow is on the left or the right, dextrocardia, we can, if it is in the middle, mesocardia. So you place the viscera. Now you got an idea. The next thing that I say is, how big is the heart? Now, just remember that the heart should not be more than 50% of the chest. And the problem is, you can see here, one side can be big in one way, and the other side it's, I don't have a pointer here, but you can see that they need not be big at this same level. So you take the maximum on this side and maximum on that side. So what I do as this thing, I can't show it here, is I take the right side, whatever is there, and put my hand here. If my hand goes outside, the heart is big. It's more than 50%. Simple thing. Just take your hand and put it there. You don't have to put lines and centimeters and everything. What does a big heart mean? Big-hearted fellow is not actually a good-hearted fellow. So, what do you mean by the heart is big? What do you think if the heart is big? It's got more blood in it, right? It's got more blood in it. Why is it having more blood in it? Something is preventing blood from getting out of the heart and it's a backwashing. Something is happening here. So a big heart is abnormal. It's failing heart. Just remember that. And then a small heart can also be there. Now, if a small heart is there, and what is it? It is trying to pump, but like the blacksmith, we say, no, why is the blacksmith's right hand bigger than his left hand if he's right-handed? Because he's overworking that hand. So it becomes big, 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 but it becomes smaller and smaller and smaller. Where do you get such a heart? You all are cardiac nurses in? I couldn't hear you. Aortic stenosis. So you must think like that. So it's what's the problem? A small heart with cardiac disease is a heart which is difficult to fill. Now, all of you, I presume, are working in cardiac ICUs. If you have a patient with a ASD and you have a patient with tetralogy of Fallot, which is the one which will have a bigger heart? No, ASD is the one with bigger heart. And the tetralogy will be having relatively a smaller heart. Now, which is the one which is more difficult to fill? ASD, you know, Dr. Tendolkar used to tell us, if a ASD has a CVP of more than 4, you're in trouble. He used to tell that to us. Now, tetralogy, what is the CVP that you're running at? High CVP. Why? I have to stretch the ventricle, right? I have to really stretch. So, they need a higher filling. So a small heart will require a higher filling if it is a diseased heart. So remember that. So in your mind, you must think, when I see the X-ray, I have a big heart. Oh, I should not overload it more. It's already full. Whereas if it is a small heart, I may need a higher filling pressure. So that's why the tetralogy is run at 10, 15. If it go, what is my statement? I say if the nurse must call me even if the resident does not. If the CVP goes in a tetrad above 15, I should be informed. Don't bother about anybody else. Call me directly because now the filling pressures are rising. Trend again. So that's there. Remember, serial X-ray with increasing size of the heart. Think of a collection. Think of failing. Something is making the heart becoming bigger. It's not normal. The heart. The goal of cardiac surgery is to make the heart better, but if your heart is becoming bigger, and there are exceptions to this, but you are doing something is going wrong with this heart. You need to think more. So now the scheme, what did we say? Situs, we place our thing, then go to the size of the heart. Now next you follow a schema, and I always tell this. All of you have seen Kaveri. What is the depiction of Kaveri? She has the pot, and she is standing like this, no? Kaveri, this is everyone in Karnataka will know. What does she do? She has a pot like this. A very important thing to learn. You are sitting like this. She is sitting. Why? Because she is maintaining her center of balance with the weight. Now, just imagine I am standing like this and I turn like this. What will happen? These things become prominent. Those things become less prominent, right? Just imagine Kaveri. You know, she's the goddess who is holding the river and this thing. She's having the pot. Now I'm just going to imagine this is the pot and what is her. Now when I go like this, these things become prominent, all these things. So this is a very important thing that you will be seeing bumps and lumps around the heart. But the problem is the heart should be in the center. So when the X-ray, and many times in the ICU, the patient is sick, turned around in some way. So always try to see that you get your X-ray placed where the nurse and the anesthesiologist and the X-ray technician. I always say one of the most dangerous times in the post-operative period is when people try to take X-rays. That's the time when tube slips. That's the time when things go wrong. You lift up a patient who's hypertensive, BP crashes. So always be careful. The X-rays are very risky. So now, and you need to take a rational X-ray. There's no point, oh, it's a very bad X-ray. Let's do the whole exercise again. That's not our goal. We want to do this. So please take it as a very serious event. anything where you are shifting the baby, like for transporting from OT to this, anytime you are meddling around with the patient's position. See, remember, anesthesia has made the child dysautonomic. We have cut all the responses. So now when I lift up the head and I put up the leg and do all those nonsense, turn the thing, hemodynamic disturbance. And you remember, it's a small tube, the tube goes out. And then everybody starts the big rush at 5:30 in the morning when the X-ray, when the ET tube slips out. So now you're going to see the bumps and the lumps. Now, when you go around the heart, and I'm not going too much in detail for the lack of time, but then structures which are big means that more blood is going in that area. So if the aorta is big, what could be the possibilities? More blood flowing in the aorta. So if there's a leaking valve or a jet is hitting and making it big. So aortic stenosis, aortic regurgitation, big aorta. MPA big, pulmonary hypertension. MPA small, less blood flow like tetralogy of Fallot. LV becomes big, LV will become big, RV becomes big. So like that, you go around the heart and see the things. I will not be going through much of detail there. But what I want to say is that now you go back and then go around the heart. And then you see those bumps and lumps, and then you can make some informed guesses. See, if everyone thing could have been got on a chest X-ray, we would not need any other investigation. Then next, go back into the thing and see whether I see anything which is there. There can be tubes, there can be lines, there can be prosthesis. You will have to go through that. Then what I do is, after going in, go to the lung. And what I tell is go and see in rules of thirds. See medial third, middle third, lateral third, then go up, upper third, middle third, lower third. So now you cover everything there. Then you go to the bone. See all the bone, what they say. Then go to the soft tissue and then go outside, because there are sometimes information where you can get outside which can be seen. So if you follow any systematic way, you will not miss things. For example, you all didn't see the bone and there was a fracture right there on the top. Everyone was sober, concentrated on why the hell is there no heart in this pig. So that goes to show that systematic examination is very important. So check inside the heart. Then I said, go through lung, bone, and soft tissue. So now we could go around like this. Now I'd like a volunteer. What is the situs of this patient? Solitus. Now, is there a cardiac ratio of more than 50% or less than 50%? Huh? It's more. Let me go here. I can't do that from there. But if I were to take this, I put it, I'm not cheating. It's gone above 50%, no? Heart is big. So what is there? More water in the heart. And I can see the bumps and lumps well, so I don't think that the thing. Then next, what happens? Now, we decided that now let's take the first bump. The aorta looks normal, isn't it? It looks normal. Aorta looks fairly normal. Then the second bump which is there is that aorta knuckle there. Then the next one is MPA segment, MPA pulmonary artery. So there is more blood going into the pulmonary artery. We know that. But then suddenly when you go down, the third bump here is the left atrial appendage. LA is not big. Can you think of a lesion? Then we will go a little bit further. And the RV, you can see that this is the RV where I will not be going too much into the details of this. And you can see that the RA is enlarged. So I have a large RA, I have a large RV, but the LA is small. So blood is being, but the pulmonary artery is having more flow, but the aorta is being stolen. So I am having blood stolen from the LA to the RA. What lesion would it be where blood is stolen from the LA to the RA? ASD. You got. Now what has happened? I can see the lungs. The plethora, it is like milk splattered on the thing. There is more blood going into the lung. I don't see anything really this thing. And then for my MCH students, I tell if you are got cherry on the cake, the cherry on the cake in the exam is if you were to see the bone, you can see the ossification center of the humerus. That's not for you, but then just remember that this child is between 3 and 5 years of age. So that's where if you are really good. So here you can see the lungs are being over circulated. So this is the analysis of the same X-ray. So what I'm trying to say is see it and read it in a systematic manner in whichever way you want. Observations, conclusions. Observations, conclusions. You must do that. So we have gone around like this. So this is the example which I told you, the atrial septal behavior. That's how you see. Now, but you're not really going into the diagnosis in by the time you're this thing, it may be important because things can be missed but now what is in post-operative cases, what we have to see is check for your main objective as this thing is to see for proper placement of lines, tubes and devices. This is where the surgeon and anesthesiologist say, and the handover this thing. So now you check. Most neckline should not go below into the main cardiac. Why? Because you have got a potential to perforate, and if it goes into the ventricle, it can irritate. Where does the endotracheal tube, where should it be? If I take a line on the clavicle, it should always stay above, at or above it. Many times a tube can slip. See, there's many a slip between the cup and the lip is what they tell. But in a baby, it is so small that it can move back and forth. And all of you who have dealt it in nurses have seen endotracheal tube going in and then the airway pressure rises or the lung collapses. So always be watching that. Where is the pacemakers are there, chest tubes are there. And please remember another thing is the swab can be left inside. So be aware, this can be a big medical legal issue. Next is to detect complications. Why do we do the thing? We say, okay, things are where they are and let's follow where they are. We know where they're in the right place. Now, identify complications like a pneumothorax, an effusion, thing. We will come through these things. So many things. Basically, if things become too white or too white or too black, there's something going wrong there. Just remember that, and that should be your response. So what to look for? We have gone again, and ET tubes, CVC, chest tubes. Now, lung fields, opacity or density changes. It could be fluid, infection or consolidation, air leaks, pneumothorax or a subacute emphysema. So now, look at this. This is the X-ray. See, there's no point me just talking, but now we have got to have, what all do you see here? Dextrocardia. No, this is where I told you systemic examination. Where is the stomach bubble? Oh, it's all bloated here. It's well that there's no need of this thing. And the liver is on the right. The cardiac mass is actually on this thing. But if you carefully see now, what else is happening there? Let's not go to the bumps and the lumps. You go in a serial way. The heart looks this thing. If you see carefully, the border of the heart. And this looks like as if it is some cotton has been placed there, right? It's not a swab which is there. So now I see that the heart is operated. I see some things. I see it's a post-operative X-ray. I see this. But then I want you to see this. This nice triangle which you see here is that of a lung which has collapsed. So what is your response to this? The rib is this thing, not really. That is not a rib fracture. That's a chest tube which has been put there. That's a tube, ICD. That's an ICD there. So now I have this right lower lobe collapse. So this is something which I want you to, this is an X-ray of a right lower lobe collapse. So now this is a time when the nursing and the respiratory therapists have to work on this. This is the importance of seeing this. And if I see a right lower lobe collapse, what should you be doing with this patient? Your nursing plan? What has gone wrong in this patient? You have not actually been giving adequate physiotherapy or racing because secretions tend to, the right lower lobe is, right bronchus is more straight. So I have got secretions here. So I'm a very big fan of proning these patients. I just take the baby and prone and tap and start and play around with the baby. But what I'm trying to say is now, if you knew this, you'll change your nursing plan. You have to analyze why the child developed this problem, and the problem was inadequate respiratory care. So you have to think in your mind, I have to be more aggressive in my respiratory care. And then I have to see complications. Everybody has complications, but the key into getting out babies fast is to prevent complications. And when you get complications, recognize them fast and bring and treat it. It is preemptive things. And once you have a problem, salvage. It's very important to salvage, because if you do this, let's assume that this is a VSD and a child develops a collapse like this, what will happen to the pulmonary artery pressure? It will shoot up because the lung has collapsed. And then you get a pulmonary hypertensive crisis and you'll end up with a bigger problem in life. This child, will it go out of the ICU in this stage? No, because the saturation is low. Remember, another important thing which I always want to tell is the treatment of hypoxia is not, of a dropping saturation is not oxygen. It is treating the cause. it is a fatal assumption to think that dialing up oxygen. In fact, I think my nurses know the one thing that irritates me most is giving more oxygen. I say no. If you dial up oxygen, it will compensate up to a certain point, and then the baby or the adult also collapses. And you lost your warning sign. I would rather have everybody becoming hyper at 92, 94, 93, 94, and everyone jumping around and aggressively trying to treat the cause, rather than dialing up the oxygen 98, sir. And then always the patient was perfectly fine, but suddenly arrested. Isn't it? That's the one thing that can trigger my anger, isn't it? My nurses are there. Nobody dies suddenly unless they have. So you have to always think this. I'll start a countdown. 10, 9, 8, 7, 6. No, doctors, nurses. 5. What type of pneumothorax this is? 4. It's a tension pneumothorax. It has literally pushed the heart away. What?
They mean tension of your patient.
Yeah. Can you see? It has pushed the heart away. What's your response? What's your response? ICD. When is the ICD going to be placed? Now.
All the doctors are busy with conference in Madhusudan Sai, and you are the
only
nurse
person there
available. What will you do? Intercostal, needle size 26, 28. No. So who will give a complete answer? And short or long needle. So you will give a complete answer.
Yeah. And another thing is, see, the older treatment was in the second space in the mid, they saying, please do not do that because people have pithed the great arteries. So what I would say, now the current recommendation is in the fourth space mid axillary line. Remember, Parkas put, I know that people talk of ultrasound, ultrasound, everything. Many centers do not have easy access to that. And if it is the same fourth space mid axillary line, place the needle, call and get a chest tube placed urgently. This is not the time to act slowly.
But give oxygen in the meantime?
No, you can give oxygen, but oxygen is not the answer. Again, oxygen is not the answer. The answer is treating the cause. Oxygen is a temporizing measure. Things are going wrong. So now, we again said, again we'll go back to, I'm reiterating some of these points. Size, cardiac seal out and mediastinal widening is the other thing. What happens? Size, heart failure. But in a post-operative period, if the heart size becomes bigger, you don't really expect it to become. Please remember that there could be a collection. Then the shape may change again in tamponade. Remember, it may just be the change in the shape of the heart. And the mediastinal widening could be due to hemorrhage, or it could be dissection. It could be horrible things going wrong. Remember that if it's widening, if the mediastinal is widening, you better call the thing. But please also factor in that the beam is also wide. So compare it with the thing. So if you say, okay, then otherwise you'll get a call saying the preoperative X-ray was like this. Remember another thing. A ventilated patient will have relatively a smaller mediastinum than an extubated because the lung will be pushing and there because of PEEP. So practical tips that I say, use a systematic report. Always remove in a systematic way. Check each aspect from lines, tubes, lung field, heart, mediastinum, whatever method you want to use your schema. Compare with other X-rays. Communicate. If something looks off, talk, communicate with radiologists, surgeons, physicians, do anything, but you communicate. Most of the time, X-rays are taken and nobody sees them. Education, you need to be learning about these X-rays and what is the thing. The idea of you coming here is to see that these are the things. Please have a look. I asked my student to collect some bad X-rays yesterday night to put up. One is there is a pneumothorax. Yes. 2. What all are you seeing in this X-ray?
Sir, we need to finish.
Oh,
We
I
are
have to
running
finish
almost
it. Okay.
1 hour late.
We'll do that, these things. And so I've got some other X-rays here. But just quick, I will just say, what's wrong in this X-ray? I'll just give the answer here. Can you see the chest tube is so low? See, remember the X-ray line, the last hole, which should be just here. Somebody has pushed it really deep in. Okay, so that's there. And just what's there in this X-ray? There is a prosthesis here, but then what? You didn't follow a schema. There is a right lower lobe collapse. The CVP line is too much in. Huh? So it's important to be in a pharmacy. Thank you.
Thank you. Thank you, sir. I request the next speaker, Dr. B Vijayalakshmi, to speak on heart failure in pediatric management.
Can I? Sir elaborated very nicely. But one more thing, what we encountered frequently in practice and we should take care of the position of the NG, especially in the neonates and pediatric patients. We have practically faced this thing that's told that in the morning hours when the manipulation is more. So in extubated patient where we are little, you can say little, in that scenario, the NG disposition may be there. And we have seen practically the patient who aspirated due to that. And sometimes it may be vice versa as well, that NG is quite inside. Suppose it's across the transpyloric and the continuous drain is coming in the NG and we are saying, oh, the kid is not tolerating the feed, so we keep the baby NPO. That should not be done. So NG position is also very, very important, particularly in the neonatal infants. Thank you.
Good afternoon. Speaking after two masters, one was the Tendulkar and other one is a Virat Kohli. But then, for me it is easy because you have understood everything and then I can finish because you are all hungry. So I'll finish it fast. So the management of heart failure, a nurse plays a key role in managing the heart failure in children by providing education, monitoring, and support to the whole family. The nurses can help children and their families understand the importance of self-care and then lifestyle modification. These are very important. The next one is early recognition of heart failure in children is very important. Now or never, it's a life-saving. Then because prompt institution of appropriate surgical and non-surgical intervention therapy is often life-saving. I'll show you the example. Nursing care after intervention is equally important. The success of interventionist depends on how well the nurses take care. So what is heart failure? Heart failure is a clinical syndrome in which heart is unable to provide the cardiac output required to meet the metabolic demands of the body like oxygen and nutrition. So inability to dispose aortic or pulmonary flow adequately is heart failure. Otherwise, it's a combination of right ventricle, left ventricle, outflow, obstruction, thereby reducing the cardiac output. So the factors affecting the cardiac performance are cardiac output depends on the stroke volume, how well it is contracting, 60, 70 or 10, 15 ejection fraction. Then stroke volume depends on the preload, afterload and contractility. One is the contractility, the ejection fraction. Other one is the preload and other one is the afterload. So nurse should check the heart rate and the blood pressure. Apart from that, should know what is the preload, what is the afterload. Preload is the volume of the blood received to the right side of the heart. You can see that the heart blood coming into the right side of the heart, and that is the preload. Afterload is from the left ventricle, what is going into the systemic circulation. So this is how preload and afterload both can cause the heart failure. So preload is volume overload, such as in case of ventricular septal defect or the valvular regurgitation, there is a preload. The afterload is where there is a resistance to the blood going from the LV, and that happens whenever there is a systemic vascular resistance, as in case of aortic stenosis, pulmonary stenosis, or coarctation of aorta. The contractility depends, it is independent of preload or afterload. It has got nothing to do. Once the heart is gone into failure, the contractility comes down. So the volume overload is most common cause of the heart failure in children, like the VST, PDA, and those conditions. Now, compensatory mechanisms, what can occur in heart failure are cardiac compensations are increased heart rate. The moment the heart starts failing, the heart rate goes on increasing. So if there is no temperature, if there is no fever, but the heart rate has gone up, that is the early signal. Then cardiac dilatation, that's the Frank-Starling mechanism. As the heart starts failing, it becomes bigger, get the cardiomegaly. Then the systemic compensation is the increased blood volume, redistribution of the blood, and in the form of, the intravascular compartment to the extravascular compartment, and the edema occurs, and the systemic nervous system, renin-angiotensin system, and antidiuretic comes into action. So how the nurses have to educate? Nurses can teach the children and their families about the symptoms, the dietary restrictions. Already they have the bloated abdomen, the child cannot intake. So either if it is very sick, you put the Riles tube or give small quantity of SIMS. Then teach children and then their families how to monitor their weight and the symptoms. Educate the children and their families about importance of taking medications in time. See, they can't take the diuretic in the evening or the night. So you have to tell them when the things have to be given, and that is the important. Now, how do you monitor? Monitoring the children for complications. Monitor the children's weight is for the fluid intake is very important. In heart failure, if they overtake the fluid, they go into worse heart failure. So fluid restriction is very important, and promptly identify and address the relevant changes in the clinical status. So discharge planning also has to be done by the nurses. That is very important. So the nursing management, most important is the kindness, the kind words, comforting them. So the anxiety of the patient should be addressed by promptly answering the questions. They are worried. They are asking questions. The doctor is not there. You are the person to tell them. So don't worry. Things will be all right. You are in the right hand and everything will be fine. Ensure effective and consistent communication between the patient and the family and the multidisciplinary team. So we have to work as a team. Just pediatric cardiologist or the anesthetist, it is not that. We are one team and we have to work together to give the comfort to the patients. Now, how do you provide the support? Provide the support to the children and their families to help them to cope up with the anxiety. Heart failure in a child means the whole family is worried. They are all in panic. And that time you have to give them comfort and help the children and their families adhere to the lifestyle, that modification. Then coordination is very important. Work with the other healthcare professionals to coordinate and to ensure appropriate discharge planning. Provide advice and liaison between the healthcare team and other people. Now, what is important is, as a nurse, you have to make out whether there is a feeding difficulty. If there is a suck, rest, suck cycle, the child suckles the milk. That is an exercise to the child, but it is not able to suckle. It gets fatigued and stops suckling and goes to sleep. It is not that it is full, it is tired. So that is an exercise. So that indicates if there is a suck, rest, suck cycle, that means the child has got a heart failure. Tachypnea, more than 45. So Dr. Tendolkar told you the breathing. If the breathing is more, there is the allanasa moving, and then the child has got the heart, breathing more than 45, respiratory grunting is there, flaring of the allanasa, intercostal, subcostal retraction that I showed you in the morning. If they are there, that means the child is in failure. Then persistent tachycardia more than 120, hepatomegaly, and excessive perspiration, especially forehead. And mother would have covered with her pallu while feeding. So they'll say that it is summer. No, you have to see that if the child is having sweating on the forehead, it could be the LV failure. So here, how to recognize heart failure in the newborn? Persistent tachycardia of more than 160, tachypnea, then hepatomegaly, and the weight gain of more than 100 grams per day in the first few days is very important, because The water retention, salt and water retention will increase the weight. The child is not gaining the weight. The gaining the weight is due to the salt and water retention. And that's why recording the weight of the baby is very important. And that gives an idea for the treating cardiologist to change the drugs. So the signs and symptoms of heart failure in older children is almost like an adult, raised JVP, then breathlessness, and then edema, and also the crepitations in the lung, and that is very easy. So left-sided obstructive lesions like critical aortic stenosis, coarctation of aorta, duct-dependent system circulation, these are the causes. How to overcome? I'll show each example. Rapid decline in the pulmonary vascular resistance. Sometimes the conditions associated with the increased lung blood flow like truncus arteriosus, single ventricle, pulmonary stenosis, TGA, VST, these are all rapidly declining. Then the child can have arrhythmia. You can see in the monitor, there could be complete heart block. The heart rate has to be his thing. And that ECG has to be shown to the person. And then myocardial disorders, especially post-COVID, you have seen lots of myocarditis and metabolic disorders. All of them can cause the Kawasaki's disease. All of them can cause the myocarditis. So coming to the management of the heart failure, the first and foremost is the general stabilization. The measures are like giving diuretics, inotropes, vasodilators that the doctors would have written, so you have to submit. But what is important is treatment of the comorbid conditions. If the child has got anemia, you have to get the hemoglobin, blood grouping, cross-matching, and then how to give the blood transfusion. And then if there is infection, temperature is there, you have to see that the infection has to be treated. And then identification of the underlying heart disease and planning the definitive treatment, and that I'll show you the examples as I proceed. So relieving fluid overload symptoms, relieving symptoms of anxiety, then promoting the physical activity as the child improves. These are all very important, teaching the patients about the daily weight monitoring. Now, supportive management, the patient is breathless, not able to lie down. So you have to give the backrest. And not only the backrest, suppose the person is not able to take the backrest, suppose to bend forward. Don't be rude to the patient. Very gently put the pillows and ask them to bend forward and then take the support. And that's how, they'll feel much better. They'll have confidence in you. And if feeding is difficult, at that time, what happens when the breathlessness, tachypnea is there, the child cannot take breath. At that time, the child can go into aspiration and that dies suddenly. To prevent that, you have to put the rice tube and feed. And correcting the anemia, oral or parenteral iron. Apart from that, blood transfusion, packed cell volume has to be given. Then controlling the infection. Your part is the tepid sponging and the drugs that whatever the doctors have given, whether 4th hourly, 6th hourly, 8th hourly, very meticulously, the antibiotics have to. Signs of symptoms of heart failure, fatigue, always tired, dependent edema. And if the child is lying down, it is in the sacrum. You may not have the limb edema, it will be in the sacrum. And that has to be looked for. Then the distension of abdomen is other one. So how do you educate the patient? Teach the patients do's and don'ts, what to be done, what not to be done, and that has to be taught. Inform the patient to call the moment they have the breathlessness, wheezing, or dry cough, especially at night. That is called as the paroxysmal nocturnal dyspnea. When everybody is sleeping, the patient may not call you thinking why to disturb the doctors or nurses, but that is very important because the child has gone into the pulmonary edema. So you have to tell them to call you, and so that in turn you can call the doctor. Or more than 2.25 kgs per week weight gain, and this is abnormal. So more than 1.25 kgs per day gain is there. That means salt and water retention is there, edema fluid is there. You have to remember that. Then anxiety, I told you, reduce the anxiety by either giving tranquilizers or sleeping pills or the sedation, and more than that, comfort of the patient. And apart from that, you have to see that promote the activity, get the saturation regularly, avoid large meals and small quantity meals frequently to be advised so that they don't get the bloating sensation. Recording the history is very important. ECG, X-ray, brain, BNP, and thyroid profile, sugar profile, and nuclear test, MUGA, and if required, this MR also has to be done. Preparing the child and sending for the investigations and getting the investigations in time is important. One of my sisters, she was telling me, Madam, I still remember when I did like this, you told me not to delay getting the investigation. That is very important, you know. If the investigations come in time, the doctors can make the decision quicker and the faster. So preparing the child for catheterization, the groin preparation and cleaning is very important, and keeping the child nil orally is very important. Otherwise, they'll have aspiration. So I'll give you an example. The heart failure can occur in the newborn baby. This is the hydrops fetalis born with the pinpoint aortic stenosis on ventilator and now or never situation, and just 14-hour baby. The next day, the sisters prepared. The 30 sisters have come from Jaideva. I'm very proud of them, how they used to assist me, you know. And with the PTCA balloon we opened, within 24 hours, the child came out of the ventilator. And now when the child is running around, mother can't run behind. So this was certain death, hydrops fetalis, and we saved because we worked as a team. And that's how it is important. And look at the X-ray before and after, how the child has improved. The pinpoint aortic stenosis opened up and the LV function and ejection fraction improved, and that's how it is. And this child is 4 years old, was breathless on failure, non-compaction, pinpoint aortic stenosis. The moment we opened in the local only, we did without general anesthesia. And then on the table when he recovered, he said, up to my behtar hu. You know, the child had come from North India. So that is the improvement they see. And this is, oh, sorry, the videos are not playing. And the gradient comes down. And this is how the child improves. This is just a 15 days old baby, cyanotic, pinpoint pulmonary stenosis. You can see that that is the pinpoint pulmonary stenosis. Nothing is going into the lungs, no flow at all. And then immediately we took to the cath lab for the emergency. First opened with 1.5 balloon, then 2.5, and then 6 millimeter balloon, so that the lung flooding doesn't occur, and came out. So this is the teamwork of the nurses and the cardiologists. So my success rate used to be 99.9. That is because of the effort of the nurses. 99.9 success rate was because of the care taken by the nurses. And unless they are joining hands with us, we cannot, because just doing the intervention is not enough. So this is a 9-day-old baby in failure, 2.2 kgs, and then ejection fraction was only 38. We closed the PDA with the ADO2 device, and then ejection fraction improved from 35 to 58, and the child became all right, and the pacing was done later on. So
Madam,
this is
we
how
are
we know.
running
Yeah,
short of time.
I'll finish. This is the coarctation. It's very important. I tell the Be Indian, touch the feet, you'll never miss the diagnosis of coarctation, because the lower limb pulse will not be there. And that's how we know this patient was taken for the emergency balloon dilatation because in pulmonary edema, mitral stenosis. And then the moment I felt the pulse, I said, sir, it is coarctation. My professor said, if you can't puncture, come this side. So I said, it is coarctation. It turned out to be coarctation. This is how we can treat them. And this is the aortoarthritis in failure, almost came with the convulsions and the hypertensive crisis and recovered. And this is how I'll skip all of them. This is the Al-Kappa, where the LV function is reduced just 15%, and then sent for the surgery, surgical correction, patient made a complete recovery. And this is how the angiogram and the patient with the aortoarthritis treated. So I'll quickly finish. 1 second. This is Al-Kappa again. This was diagnosed as a rheumatic mitral stenosis with mitral regurgitation, and timely echo showed that it was the Al-Kappa, and again operated, and the patient made recovery. So this is the 1 second. This patient with 4 drugs in failure, BP was so high, the hardly functioning kidney was there. The right kidney was not functioning. Just put a coil, nephrectomy done, and the blood pressure came down. So discharge plan has to be done by the nurses, and the nurse should know when to seek the help. The moment there is something wrong, some parameter is wrong, ring the panic bell and call the person for the prompt treatment. So you are the captain of the patient, and that's how we know. Look at the tip of the iceberg, and then you can call in time and save. If you do not call, if you also sleep and we also sleep, and we cannot save the patient. So remember, heart failure in children can be acute and life-threatening. Margin of error is very narrow, and hence timely detection is very important. And if you don't take care, there can be a crash in the ward. And that's how we know. When I joined first time in Jaydeva, there was no lady cardiologist, and I lived all my time with the nurses. The first endotracheal tube I learned from Sarsu sister. The first DC shock I learned, and all the time, I learned everything and I rose. And today I've come back to teach the nurses so that the glorious, path of the nursing can be taken further, and hence keep your eyes open. ಅದಕ್ಕೆ ಕನ್ನಡದಲ್ಲಿ ಮೈಯೆಲ್ಲ ಕಣ್ಣಾಗಿರ್ಬೇಕು ಅಂತ. And the best part of the stethoscope is the bit between the 2 earpieces. And the best part of the machine, echo machine or whatever, is the person behind the machine. And the best part of the ICU is the nurse working in the ICU. And that's how we know you are the lifesavers. And thank you very much for your kind and patient hearing. If we save when we work as a team, and then if we should not be individually wise and collectively otherwise. In fact, we should be collectively wise, and then only we can save. Thank you very much. Sorry for the overstepping the time. Thank you.
Thank you. Thank you, madam. We are running short of time, almost more than an hour. I request all the speakers to kindly stick on to the time, please. Next, we move on to the next third session, gender principles in post-operative care in pediatric cardiac surgical cases. I invite our first speaker, Dr. Sanjiv Nichani, the chairman of Healing Hearts, to talk on hemodynamic monitoring. For these chairpersons, I would request Dr. Roman, Dr. Miha, Ms. Liva, and Mr. Anubhava Devaguru, Professor Shivanand, Ms. Grace, to come on stage, please.
30 minutes. Stay for a while and then
Okay. Okay. Divide 3+3. 3 speakers. The lunch hour was 1 hour, but seeing the amount of interest students have and even the teachers have for teaching, we'll cut down the lunch to 5 minutes late. Maybe 15 or 20 minutes we can plan lunch faster. So I will break for lunch after 3 sessions. The remaining sessions post lunch we'll have. And see that everybody comes back after lunch. Don't spend more time in lunch. Yeah, because you end up eating more, you'll come and sleep here. Yeah. Sure, sir. Please go ahead, sir.
I hope people are not too hypoglycemic. Will somebody give me a warning if I overstep? Yeah. My name is Sanjiv Nichani. I'm a pediatric intensivist, and I'm the founder of Healing Little Hearts. And I work in Children's Hospital in Leicester in the UK. Now, despite the presence of great cardiac surgeons, 4 generations, in fact, today amongst us, whether we like it or not, after cardiac surgery, the child and the child's heart is in the eye of a storm. And that's essentially, to put it, I don't think I can put this diplomatically, but the heart has been assaulted with the right reason, of course. So I want to share with you my top-to-toe approach as to how I manage these children. First of all, as has already been alluded to, intensive care is the interface between anatomy, and we had an amazing masterclass from Dr. Tendolkar, physiology, pharmacology is what helps me as an intensivist manage these patients, pathophysiology, so you know what happens in a disease state, and of course biochemistry, things we all learned, you learn in nursing school and we learned in the first and second MBBS. Why am I going the wrong way? Okay, so I run a head-to-toe professional treatment center. So what do I mean by that? Traditionally, people talk about ABC, airway, breathing, circulation. I actually start D, disability, or from the top. Whenever I'm rounding, I start from the top, i.e. pupils. Okay? If you take a survey of doctors, I can guarantee you at least 50% of doctors in the ICU never look at the pupils. And that is, my opinion, is poor care. Because if you don't know what the pupils are doing when the child comes back from theater, if the child has an event, remember the child has been through major cardiac surgery. If the child has a cerebral event in the ICU, you will have no idea whether these pupils were like this during theater, because the child was given adrenaline or atropine, whatever it might be, or something has happened post-op. Remember, these children are anticoagulated. So I start from the top. Intensivists have attention to detail. We obsess over little things. A lot of my nursing colleagues back in Leicester laugh when I say, what is the calcium? Because I obsess that the ionized calcium must be 1.2. And there's some reasons, very important physiological reasons, which I'll share with you. Similarly, I obsess that the magnesium should be 1.2 and so on. And the potassium should be 4.5 and the sodium should be normal, all with very good reason. Essentially, we obsess over these things to ensure that the internal milieu, i.e. the important electrolytes of the body that make the body function normally, are topped up and normalized after the surgical procedure that the child has been through. So yes, head to toe, check the pupils. Really, really important. Do all the nurses here check pupils? Right, that's a relief. I'm very impressed. I've already mentioned why. And just remember, if the ambient light is very bright, it might mislead your pupillary examination. Now, of course, part of what we do, cardiovascular system, is also to perfuse this complex arterial system of the brain. And that's part of our bread and butter in the ICU. So aim for a generous perfusion pressure of the brain, because the cardiopulmonary bypass also starts off an inflammatory process in the brain. And after an arrest, which does happen, after all, these are high-risk surgeries, remember not to be too exuberant with the oxygen that you're giving this child, because oxygen toxicity is a real thing and can lead to what we call superoxide radicals, which will in fact make the underlying brain injury worse. There are new modalities coming out to measure brain flow and blood flow to the brain, like transcranial Doppler. And one of the most important functions of the ICU team is to avoid secondary injuries, which I'll talk about. Now, after a child comes back from theater, at least for the first hour, 2 or 3, until you're happy with the bleeding, etc., this is the sort of state we want to initiate and encourage. And we do this by a combination of various sedatives, morphine, narcotics like morphine, fentanyl. Midazolam has gone out of fashion. It has now gone to number 3 on the list. So it's morphine, fentanyl, and you have alpha agonists like clonidine or dexmedetomidine. Now, whenever you use a drug, as I said, intensive care is about an interface between pharmacology, etc. You must know not just the effects, but the side effects. So if you're using morphine, for instance, one of the known side effects is bradycardia. If you're concomitantly using clonidine, you should also know that clonidine can cause bradycardia. But however, if the blood pressure is normal, as long as you know this could be, not necessarily is, but could be a result of the pharmacology you're using, you could be reassured that there's nothing amiss going on. We use a lot of nasogastric sedation. I think you have Pedichlor over here. We use a lot of chloral hydrate back in the UK, and also some sedating antihistamines. Now, Dr. Prasanna mentioned one of the most dangerous times in the ICU is during an X-ray. The ET tube should be as secure as this. There's nothing worse than the surgeon doing an amazing job in theater and the child comes back to the ICU. The child suddenly moves because the child is partially anesthetized, is in a confused state, and the ET tube falls out. It is your sworn duty as a PICU nurse and indeed as an intensivist to make sure the endotracheal tube is really, really secure. Because that's a morbidity or indeed a mortality that can be and must be avoided. And this is what you want to achieve in terms of opening the lungs. So what you have to remember is whilst the heart has been operated upon, the use of the bypass machine to facilitate cardiac surgery has actually engendered an inflammatory response in the whole body. The lungs are affected, the kidneys are affected, the brain can be affected, etc., etc. So we have to nurture and care for all these organs from top to toe systematically. And that's what pediatric intensivists do. So this is what you want to do. And how do you do that? And I know my colleague is going to talk about that shortly, but make sure things like the inspiratory time that is dialed in on the ventilator is age appropriate. There's no point having an inspiratory time of 0.2 seconds for a 10-kilo child. That is not going to open the airways. What you want after cardiac surgery is for the lungs to be open, for the blood to flow easily and smoothly into the lungs, for there to be no resistance. Otherwise, you're putting additional further strain on the heart. That must be avoided. I use a high PEEP of at least 6, depending on the underlying pathology, and sometimes more. As I said, keep the lung recruited. Remember, the lungs collapse, as has been shown in some X-ray, adds further strain to a heart that's already struggling. Sometimes in certain pathologies, the excessive PEEP can be counterproductive, like the BT shunts, like the Glens, as has already been mentioned. It's good to extubate as many of these kids as soon as possible. And whoever has been with us in the ICU would have noticed within 3 or 4 hours, the vast majority of children are extubated. And that is a sign of a good, functioning, modern, safe intensive care unit. That's what you should aim for. And there are various different types of ventilation, which I'm not going to go into. And I was delighted that Dr. Prasanna mentioned prone positioning, because I think that's one of the most useful, beneficial methods of opening up the lungs, draining secretions, and reducing collapse consolidation. If you have nitric oxide, that's got a place, and I'm sure many more centers in India are aspiring to and acquiring ECMO, and that will have a regular place in the modern care of the post-cardiac patient. Now, circulation, the bread and butter of what we do. We've already talked about preload, the amount of fluid that is required to make the heart contract, contractility, the efficiency of the muscle pump itself, the afterload, which is the resistance to the heart contraction, and the Frank-Starling curves, which brings everything together. Now, after theater, the child, as I said, has cardiac surgery. There's what we call an inflammatory response. The blood vessels become leaky. Normally, the blood vessels don't leak. But after this inflammatory response, which actually, as I said, affects the whole body, the blood vessels become leaky. And you have to open the tap. What do I mean by that? You have to give fluid. Now, there's a big debate amongst intensivists and most doctors as to which is the best fluid to use. I think the debate has not been settled yet. A lot of people use crystalloid. My own practice is to use crystalloid for the first, or balanced solutions like Plasma-Lite, Ringer's lactate for the first 10 to 20 mils per kilo. And I switched to a colloid purely because of the pharmacology, because I know theoretically colloids last longer in the circulation. So that's my own practice. There's not much science behind that, but there's not much science to tell us which type of fluid is better than the other. So I rely on my knowledge of pharmacology to direct my approach. I'm a very big fan of 20% albumin, so I think hypertonic solutions like 20% albumin have a role to play, as does hypertonic saline, and even maybe sodium bicarbonate, not to correct a base deficit, but to actually give a hypertonic solution. There's evidence hypertonic solution which drag fluid into the circulation are beneficial for cardiac function. And avoid starches because starches are known to be associated with kidney disease. So what's the key to managing this heart, which is injured heart? So you need to have a very good knowledge of inotropes and vasoactive drugs. You have to remember, soon after the child comes back from theater, there's often a honeymoon period. And then things start to drift 12 hours later, typically in the middle of the night, which is the most dangerous period. So judicious use of inotropes. And what I mean by that is aim for an age-appropriate blood pressure, ensure the child is warm, urinative, etc. Don't overdo it. Don't make the child tachycardic unnecessarily. If the child is warm, if the lactate's normal, then accept the blood pressure, which is age appropriate. And calcium. So essentially what I advocate is treating this heart very gently, not inducing pharmacological insults by making the child tachycardic and hypertensive. And there are many different catecholamines. My favorite ones are adrenaline and vasopressin for infants, as well as milrinone, as well as calcium. And for older children, I use adrenaline, noradrenaline, and calcium, and then vasopressin. And I do not use, because I hate dopamine. I think it's a horrible drug, and it should be confined to the museum. Vasopressin works on different receptors. It's great for vascular tone, so worth considering, particularly neonates are exquisitely sensitive to it. And in older children, if the noradrenaline doesn't work, I would highly recommend trying that. Calcium is the cation in the body that is responsible for every muscle contraction, particularly the heart. It's important for coagulation, for heart function, for any muscle function. It's really important. As I said, we optimize calcium very, very regularly. And as I said, there's no point having a hypertensive child. You're not doing this child any favors. It should be normotensive, age appropriate, as long as the child is passing urine. Watch the toe, core, peripheral gap, which has already been described. The liver size, central venous pressure is just a guide. And there's a variation. If the child is hypovolemic, you'll see a swing on the arterial trace, but you'll also see a swing on the pulse oximeter. Not many people know about this, but watch this. Next time you see a child with hypolipolemia, if the pulse oximeter is accurate, you'll see a swing on that as well. It's very, very useful. Lactate, we talked about that. I'm glad Dr. Tendolkar mentioned central venous saturations. I obsess over it. It's really, really useful. And you have other parameters you can follow. It's easy to get an echo, not just for cardiac function, but for filling, for IVC diameter, etc. And even in this day and age of artificial intelligence, basic clinical medicine, watching a child passing urine tells us this child is doing well, and there's nothing more reassuring than that. And the irony is, after you fill the child for the first 24, 48 hours, we suddenly decide, because of the morbidity associated with fluid overload, we're going to diurese the child. So what do? We use what I call vitamin A, which is aminophylline, and vitamin F, which is furosemide. It's really, really important to diurese these children. There's a lot of evidence. The puffier you are, the more swollen you are, the worse your outcomes. And that's why we are, once the acute phase, the inflammatory response is over, we start to diurese these children. Nutrition, really, really important, must not be neglected. Being a sick child does not mean you cannot feed. It's really, really important. And avoid secondary insults, hypothermia, etc. All of these things are bad. It is our duty to make sure these things do not happen. And if they do, they must be addressed promptly. And all I'm going to say, if we don't do this, we have failed as a team in the intensive care unit. And I'm going to end with a plea that I humbly suggest you avoid the base deficit. So if you get a gas and you see the base deficit is -10, do not give bicarb. That is not the answer. You need to understand why the base deficit is -10. Avoid the knee-jerk reaction. Look at the patient. Don't be a slave to technology, because I strive towards and like to think patients got better partly because of how we manage them rather than in spite of us. Thank you.
Thank you. Thank you very much, sir. Thank you for keeping up the timings. It was exactly 15 minutes.
Can I have a question?
Yeah.
As an intensivist, what do you think about extubation on the table? because it's more and more used. And, for surgeon is fine when you see it, but for intensivist, it's maybe different.
Well, it makes my job easier. I can just chill out in the ICU. If it's done safely, yeah, I welcome it. One of the things that we've started because of Healing Little Hearts is early extubation, and we've used that in the UK now more and more. I don't think a single center extubates on the table, but if it's safe, yeah, absolutely. Certain conditions, yeah, I think it's very safe.
One challenge with that is when we extubate the child, you have to be absolutely sure of your parameters that you're not going to, because there's nothing worse than a bleeding child who has to be reintubated for a re-exploration. So you've got, that's one of the things which we should, so it should be, and another problem is in high turnover center, the time between spent to extubate in the OR robs time for the next case. So what I feel is sometimes is you can shift it and you can extubate within an hour or two. Just check whether I think that would be a good middle ground than directly taking it.
I agree. I think there are only a limited number of conditions when it's safe to extubate in theatre. Yeah.
Thank you. Thank you, Dr. Sanjiv. I invite the next speaker, Dr. Petr Plasil, to speak on fluid therapy and electrolyte imbalance corrections.
Thank you. Hello, good day, everyone. Thanks for welcoming me all the way from Europe, from Czech Republic, which is a small country. I'm glad.
I request people to remain silent, please. Yeah, please go ahead, sir.
I'm glad to be here. I am an adult cardiac intensivist. I do it for a long time, long period. I know something about circulation. I don't know too much about kids, but I'll try to enlighten you slightly. Maintaining fluid balance and stability of homeostasis is the key part of any intensive care, adult and pediatric, and it's the mainstay on which you base your therapy in the intensive care. You need to be aware that the child is different from an adult, mainly because of percentage of water it contains. And the other problem with children is that the content of water is much higher in percentage, but much lower in a real volume. What we do not want is either fluid overload nor dehydration. And so being in the intensive care is walking on a knife edge, trying to not fall over to one or the other side. And of course, we know that fluid overload is bad. It comes to worse outcome, increased inotropic support, increased the period of time that the child stays in the ICU. So we don't want that. Fluid depletion is not good either. It leads to hypotension, hypoperfusion of the vital organs, and loss of function. And so we're trying to avoid that. We need to be aware in post-cardiac surgery care that there are some impacts that the surgical procedure and the cardiopulmonary bypass does to children. The cardiopulmonary bypass causes hemodilution, big fluid shifts, and starting of inflammatory response. And it can lead to capillary leak syndrome, leaking of fluid to third spaces, and hypoalbuminemia. It causes stress reaction as any stress to normal, to other surgery. So any surgery makes makes our child stressed. And the bigger the surgery is, the bigger the stress response is. And we need to have on mind that the pediatric population has a unique consideration. It has very small fluid reserves and it has higher metabolic rates. So we need to, the children are very safe, very sensitive to any imbalances. I'll briefly go through that. Any child has some basic fluid requirements, which are it's the guide to guide us how much fluid we should give approximately to a child, because any child, if either sedated or awake, have its metabolic needs. The holiday Sega rule is well known. It's been there for 70 years almost. And we need to know that the fluid requirements changes over time. So it's not something that is given, but we need to alter the amount of fluid we're giving depending on how the patient look like. Usually, child coming from the operating theater has some additional fluids added by the cardiopulmonary bypass, giving blood or platelets or other things. So they are increasing the volume, and on the zero operative day, we usually give 50% of the basic requirements, and we slowly increase it over time. And of course, we check on. You don't have. It's necessary to bear in mind that one child is completely different from another one. You have to know what the heart function looks like. What status did the child come in, whether he was dehydrated or in ventricular failure or heart failure. So you have to adapt the formulas that you know to the status of the child. And of course, as all the previous speakers said, the correction of the important ions are essential. So we have three components of the fluid therapy. The maintenance fluid I talked about, and we need to be aware of prior deficits, and we need to supplement the deficit over time. And the only thing I would stress here is that the maintenance fluid could be slightly isotonic, slowly, not slowly, but slightly hypotonic, but the fluid that compensates the deficit should be isotonic always. So bear in mind that we cannot use the maintenance fluid, which would be sometimes only dextrose, for supplementing the deficit. If the child is severely underperfused, we should use isotonic solutions or balanced solutions to replace it, or maybe even some colloids as well. And the child comes in and there are ongoing losses. We need to calculate that in our formula as well. We need to compensate for those ongoing losses. Could be bleeding, could be the nasogastric tube giving, it be urine passing at a very high number. So we need to think about that. Why do we think about fluids? The cardiac dysfunction after cardiopulmonary bypass is always a threat, and we need to be aware of the cardiac function, and we need not to overload the child. And we have several measures or several apparatus that can help us with that. The most basic one is just looking at the child, seeing how it looks like. The other one would be the intravenous pressure or pressure measurements, but we can use the echo to assess what the volume status is and what the heart function is. If the heart function is poor and the filling pressures are going up, we have to be very careful about not overloading the child. And it's good to know that when we're giving fluid to fill the child after the surgery, we should monitor the CVP as well. Because if we are not monitoring and we're giving a higher amount of fluid, it could easily switch from underloading to being pretty much overloaded. So, we don't have time? Sorry.
Please go ahead, sir.
I'll go briefly over it. So intake and output is what you should always monitor. And there are many things that a nurse has to monitor. And it's not only what we do as the basic infusion, it's all the inotropes and other drugs that we're giving. Output is not only urine passing, but other things. And we should see what the fever and ambient temperature is. And the most accurate thing usually is measuring the weight of the child. We have several important ions. I will go only briefly over it because most of it was said already. Neither hypokalemia nor hyperkalemia is good. You have to know that hyperkalemia is usually caused by what we do. It's not caused by how the child is sick. The only thing you have to bear in mind if we have renal function problem, if there is no urine passing, you have to check kalemia. It could be on the hyper side, but otherwise with our substitution we can overcorrect, and we need to be aware of that. And we also need to substitute for losses. Calcium is another very important ion. Almost all have been said. It's quite common, hypocalcemia in postoperative care. It has a great effect on contractility, and you need to know that when you're losing ionized calcium and the level is very low, the blood can clot, so you could add up to bleeding. Hyperkalemia is not too common, and I wouldn't stay on that, but the most important, one of the most important ions that you should bear in mind is the salt, the sodium, because either side of the normal can be quite dangerous, and the basic rule is when you're correcting hypo or hypernatremia, you should be slow. You should not rush anything, because if you rush the substitution or of water or sodium, you can get the child in a big trouble, mostly very serious neurologic consequences. So in treating hypo or hypernatremia, we should not exceed 0.5 millimole per hour or 12 millimoles per day. We should avoid hypotonic fluids when used for resuscitation, and we should be careful when using hypotonic fluids as a maintenance therapy. We should always check the sodium level. And any rapid correction could lead to acute pontine and extrapontine demyelinization, and that could kill the child. So we should be aware of that. So close monitoring of the serum sodium, urine output, and the neurologic status is essential. And my last slide is the osmolarity. You should be aware of what you're giving, to which catheter are you giving that, because peripheral vein cannot bear too much osmolarity. It can cause trouble. Okay, that's my last slide. Thank you very much.
Thank you, Peter, for finishing on time. Any questions? No questions. We'll go on to the next talk by Dr. Marek on current practices in infection control in pediatric cardiac ICU.
Havelka. Yeah, current practice. Yes. No.
Yeah.
Hello, my name is Marek Havelka, and I'm a doctor in faculty hospital in Motol in Prague. And my team is current practices in infection control in pediatric cardiac ICU. I work on Department of Pediatric Anesthesia and Department of Resuscitation Care in adults in our hospital. The first thing I would like to say that everything starts with hand hygiene. It's good to have a strict protocol for all healthcare providers, including proper hand washing, liquid soap with water, and using alcohol-based hand drops before and after the patient contact. It's good to have implementing structured hand hygiene protocols and performing audits regularly to ensure the compliance with the patient and with the infection. We should implement contact precautions and isolating protocols for the patients with infections, for example, respiratory infection, gastrointestinal infection, to prevent cross-contamination around the patients, around the ICU, and get together patients with similar infections to minimize risk to other patients. So maybe with patients with diarrhea caused by Clostridium difficile pathogen, we can put them on one box to prevent another complication with another patients. Ventilator-associated pneumonia prevention, because it's crucial, because every time every children is ventilated in ICU, pediatric cardiac ICU, so we should be very avoided about the infections on the ventilator. And we should regularly elevate the head and on the bed and 30 to 45 degrees, and perform oral care, preferably with chlorhexidine solutions. It's good to use cuffed endotracheal tubes to reduce the risk of silent aspiration and have the ventilator pneumonia, and derivate stomach secretion with a nasogastric tube. We should have implemented sedation protocols to minimize unnecessary intubation and sedation time. And then we should use sterile techniques during invasive procedures like catheter insertion or central venous access, and during the cardiac surgeries and interventions. Ensure that surgical instruments and drapes are sterile and prompt and appropriately handled. On next slide, I'd have central line associated bloodstream infections preventions, because central line we use every day for medications and fluid administration, and infection control measures for this central line associated infections preventions include aseptic technique during the insertion and maintenance of the central lines, and nurse should have used a cap and mask on the face when preparing the sterile table, routine monitoring and maintenance of the line, and prompt removal the central lines when no longer is needed, and daily inspection of insertion sites for signs of infection, and inform your doctor if there's any problem with central venous access. Here we can see some pictures about the peripheral lines and its complications on the right side. There can be a risk of decubitus and skin irritation if it's not fixed properly, the IV line. On the left arm, we can see that cannula insertion should be visible to check the site or infection, and do not bondage the limbs with the plaster like it's in the middle. If it's not needed, do not replace the patch unless there is a sign of infection, and changing the patch only if it's visibly dirty or wet or it's misfunctioning. So then you can change, but not change every day the patch of the peripheral lines. On the ICU, we should have antibiotic stewardship or a consultating antibiotic center, and the implementing of antibiotic stewardship program to prevent overuse of misuse of antibiotics, reducing the risk of the multi-drug resistance organisms, and the microbial culture should guide antibiotic selection, and broad spectrum antibiotics should be narrowed as soon as possible. And having a consultation with antibiotic center about new cultures, samples, new microbes, about the timing and the escalation of antibiotic therapy. And routinely in our ICU, we take it on Mondays, every Mondays and every Thursdays, take samples, sputum, urine, or swab from the tissue for the new cultivations and for good microbiological surveillance on microbes. The using of prophylactics of antibiotics. It's very necessary. It's essential part of the care about the for the baby. The prophylactic use is essential, and because pediatric patient giving cardiac surgery, they are in a high risk on infection in these complex surgeries, especially in pediatric patients. Antibiotics are typically used to prevent surgical sites infections, endocarditis, and other postoperative infections that can complicate the recovery of the patients. The primary goal of prophylactic antibiotics is to prevent infections in the immediate postoperative period. This includes preventing infections at surgical sites and bacteremia leading to endocarditis in patients with congenital heart defects. And the risk of infection are elevated because of the prolonged surgeries. We are using the prosthetic materials. There's cardiopulmonary bypass, and often the patients are immunocompromised. Yes. What I said, those children with congenital heart disease may have increased susceptibility to infections because of the cyanotic heart defects, which may alter the immune function, long-term use of invasive devices such as central venous lines, post-operative cardiopulmonary bypass exposure, which can increase the risk of the hospital-acquired infections, involvement of prosthetics materials like shunt, grafts, or valves, which can increase the risk of infection and endocarditis, and procedures with the open chest after the surgery to prevent cardiac failure and after the closing closing the chest. You can see a small baby with the open chest after the surgery to prevent the cardiac failure. And here we can see there is a membrane on the open chest. There is a retractor to having opening the chest, and too many drains which are possible way to give infection into the chest. So timing of administrating antibiotics is about 60 minutes before the surgery, and it's crucial to achieve this adequate tissue concentration at the time of the incision. And for the surgeries lasting more than 4 hours, if there's excessive blood loss, there's needed antibiotic redosing to maintain effective concentrations. And as I managed, neonates and infants undergoing congenital heart surgery may require different dosing regimens due to their immature metabolism. And a immunocompromised patient, such as Down syndrome or on immunosuppressive medication, may require border coverage and close monitoring for size of infections. Which antibiotics we use? It depends on the type of surgery, specific risk factors like allergies, resistant organism, and the most we use cefuroxime for the neonates, and for the infants and older children, amoxiclav, and it's commonly used to clean procedures for the at-risk Staphylococcus aureus and Streptococcus infections. For a patient with allergy, we use clindamycin or vancomycin to cover the gram-positive cocci like MRSA. And in high-risk cases of surgeries involving prosthetic material, we use gentamicin for the gram-negative organisms, and broad-spectrum antibiotics like piperacillin, tazobactam, like tazocin or meropenem. It should be considered if the surgical risk involves contaminations of multiple organisms in cases of infected prosthetic valve. And the last is the environmental cleaning, just frequent and frugal cleaning of the patient care areas, especially high-touch surface. Use disinfectants effective against a wide range of pathogens, including the MRSA and Clostridium difficile, and maybe vancomycin-resistant enterococcus, and have a multidisciplinary approach. And infection control in a cardiac ICU should be a team effort involving cardiologists, intensivist surgeons, nurses, and infection control specialists, and have a regular time meeting to discuss infection rates, reviews cases, and develop quality improvement initiatives. So that's all, and thank you for your attention.
Thank you, Mark. I think he finished on time. Any questions for him? Now we are running almost 1 hour 30 minutes late. We'll break for lunch now. It's a short lunch break of 15 minutes only. After that, I request all of you to assemble here. Otherwise, it's difficult to finish the sessions. Very important topics are there. 15 minutes downstairs is arranged.
ऐसा कुछ नहीं बोला ना, वो बहन का लोड़ा प्रद्युमन मेरे को बोल रहा है, तू काम नहीं करता ना, इसलिए वजह तेरे
What? Why are you saying like that?
What I told her.
For this, I can't see this. ల్యాప్టాప్ ఉందా సార్ ల్యాప్టాప్ పెట్టుకోవచ్చు ఇలా కెన్ యూస్ నేనే ప్రెజెంటర్ స్లైడ్ చేంజ్ కాదు
He came exactly on June 6th, 1975. That was a Friday. Saturday.
So you're next. It will not fall on. Good afternoon, everyone. So continuing with our session 3, I invite Dr. Vishwanath Kamoji, pediatric intensivist from the Sparsh Hospital, who works as honorary intensivist for us during the Healing Little Heart camps. Sir will be speaking on care of a ventilated child post cardiac surgery.
What about that? Good afternoon, everyone. I hope you are all rested after the lunch and you still have some blood flowing to the brain and it's not all accumulated in the abdomen itself. Dr. Vishwanath.
Kamoji, I request Dr. Prasanna Simha and Dr. Jagannath to chair the sessions, please, and Dr. Vijayalakshmi. Can you please chair the session? And even I will join. Come. Yes, please go ahead, please.
I'm Dr. Vishwanath. I come from Sparsh Hospital. I'm a pediatric and neonatal intensive care, and I'm coming here to help out the HLH team. I think it is apt to start with OM, at least for this session. Can we go back? Yeah. Now, Om is an ancient Sanskrit scripture which means breathe. And for us, it is what comes very naturally. It is the first thing we do when we come into this world and the last thing when we leave it. Now, what I'm going to talk in the next 15 minutes is what has been actually told and what will be again told in the next few hours. Basically, it's not moving. Slides are not moving. Basically, what I'll be talking about is changes with the normal breathing and ventilation, importance of pre-op assessment, post-op cardiopulmonary interaction, role of cardiopulmonary bypass in babies who get ventilated, and post-surgery ventilation, why it is needed, what are the interactions, modes in brief, though it has been done by Dr. Nichani as well, and extubation criteria, and I'll conclude my slide from that. Now, the cardiovascular physiology. In a resting state, what is happening is my diaphragm and the intercostal muscles are all relaxed, but the pleural pressure is still negative. And when I take a spontaneous normal breathing, the pleural pressure reduces even more. It causes two things. One is it improves the flow into, this is the resting state. And this is with the spontaneous respiration. What it does, it creates more negative pressure into the pleural space, and it does two things. One is it improves the blood supply to the right side of the heart because of increased negative pressure. And also with increased negative pressure, the LV pressure decreases and becomes slightly lower than the blood pressure, and hence creating a relatively increased higher load or SVR. So this is a normal physiology. Now, what happens when you are ventilated? When you're ventilated, you've got a tube in and the machine is giving the breath to you. In that case, all the pressures, the airway pressure, the alveolar pressure, and the pleural pressure are positive. And it creates a compression of right ventricle and pulmonary vessels. It reduces the venous return. It increases the RV afterload and reduces the left ventricular afterload by the baroreceptor reflex. This is a normal physiology. And with a bypass, with a child who has come with cardiac surgery, it all gets accentuated. When a child comes for the surgery, it is absolutely essential for us to diagnose what this condition is and how do we then manage him pre-op, intra-op, and post-op. So first is to have a proper diagnosis, and this helps us manage post-operative expectations, plans, and put in efforts to reduce whatever complications there might be. This pre-op evaluation is clearly influenced by age, which is either a baby born with a cardiac disease, or underlying physiology, which is, as we spoke about in the morning, increased pulmonary blood flow, reduced pulmonary blood flow, reduced systemic output, a parallel circulation, valvular lesions, or anything else which the echo might pick up and show as a catheter findings. There are a few must-know facts for all of us. First one is an oxygen. Now, oxygen is a very potent pulmonary vasodilator. Now, along with oxygen, there are many other things used to pulmonary vasodilate, but the most potent one remains as oxygen. It reduces pulmonary pressures and increases the flow to the lungs. The next is carbon dioxide. It is a pulmonary vasoconstrictor. It increases the pulmonary pressures and reduces the flow. So these are the two main oxygen and carbon dioxide interaction we must remember, which will be helped with ventilation as well. So let us see two examples of situations where there is a duct-dependent systemic circulation, where the blood is flowing from right to the left side. In such situations, in a baby who has come in, you need to keep the duct open by adding in prostaglandin E1 infusion. Also, if we had to augment the pulmonary to systolic to systemic flow, you had to somehow reduce the pulmonary flow and increase the PA pressures, maintain saturations around 80 to 85% as Dr. Jagannath has been talking about initially, reduce or avoid oxygen in such situations, avoid intubation, or if you end up intubation because of prostaglandin, you try to extubate as soon as possible. Aim for mild acidosis, mild increase in carbon dioxide. And also, you can reduce the systemic vascular resistance by using an iodinator or sodium nitroprusside. On the other hand, if there is a duct-dependent pulmonary circulation where the blood must flow to the lungs, you keep the PDA patent or you keep the ductus patent by giving the PG infusion. You maintain saturations of 80 to 85%. Give ad-lib oxygen because it's a pulmonary vasodilator. Mild CO2 washout and hyperventilation is going to be helpful. So is mild alkalosis. You can also help this baby by increasing the SVR by adding inotropes or giving more fluids. We are going to talk about cardiopulmonary bypass. You can see that there are a lot of cannulae, there are a lot of vents, as well as the aorta is cross-clamped, there are aortic cannulae, and also there is cardioplegia. Not just cardioplegia, the heart is also cooled for better effect on the heart. All this causes a lot of changes in the baby. But having said that, there's a lot of improvement in the bypass physiology, and now it is a very safe procedure. Understanding of this physiology and neurotechniques has enabled the surgeons to undertake very complex neonatal cardiac surgeries safely. Having said that, the bypass invariably and to varying degrees impairs the respiratory function, and it is dependent on many variables. The bypass circuit, the dilution of blood, the duration of cross-clamp, the hypothermia, whether it's 28 degrees or deep hypothermic arrest, ischemia perfusion ratio, it reduces and decreases surfactant. All this lead to changes in the pulmonary, the lung parenchyma and all of this. But also, more importantly, as we have been hearing, these all lead to systemic inflammatory response syndrome, which is a cytokine release all over the body. Now coming to the post-op ventilation. When the baby has, or the child has come to the unit, he is breathing by himself. He may not need any support. So he has got fairly stable lungs, unless of course he's got a viral infection in the viral period, or as madam was saying, Eisenmengerization. So that time we cannot do much about it. So what is the reason to ventilate? The reason to ventilate is to maintain adequate blood gas and to protect airway. And also we had to prevent the ventilator-induced lung injury. Now, the lung injury can be caused by biotrauma, which is increased release of interleukins or cytokines, atelectotrauma, barotrauma, and volutrauma. All this increase the RV distension, RV afterload, and can reduce the cardiac output. We had to reduce all this by lung protective ventilation. And as Dr. Sanjiv Nichani was talking, we optimize PEEP, we optimize the tidal volume, we optimize the pulmonary pressures to retain the compliance, and all this will improve the cardiac output. I have a video. I don't think it is playing at this moment. Yeah.
Shiva, can the video run?
Yeah, that's okay. That's okay. That's okay. So the post-op care requires a comprehensive, multidisciplinary, and a structured approach to handover and ongoing care. If you see this slide previously, it is taken from the same pit stop. Have you all seen any pit stop or racing cars stop in the pit? There are 20 people around. Each person has got one job to do. Each person will do that job and move out. And the specific thing about it is all coordinated. The person in the front, yeah. The person in the front is the main leader. And if he says go, the car goes. If he doesn't say go, then he may be rolled over by the car. So there are about 20 people surrounding that, and each one will have their own very specific role. And that is how the post-operative care of a post-cardiac patient is. We have seen from Ieva, the cardiac care to be handed over is exactly what I'm talking about. So when the handover is taken, there is a clear understanding of cardiovascular physiology in the presence of all the surgeons, anesthetists, the ODPs, taking handover from them to know what lesions were there, what was corrected, what happened in the intra-op period, what arrhythmias happened? Did they have to do something else other than what was actually noted in the pre-op period? This evaluation may require clearly bedside assessment, labs, echo, and very occasionally going back to the theater as well. A prompt evaluation is needed if the patient is not following the right path. If you're not following, we expect the child to come out, warm up, do everything as normal, and then be extubated. And if the child is not following that, we need to reassess that. Now, we have spoken about ventilation, brief ventilation, and Dr. I think you asked about post-op extubation, immediate post-op extubation. The early extubation after bypass has been shown to be the safest and best. It is now established world over by many studies that extubation fairly soon after the surgery is reasonable. Patients must be carefully selected to minimize the risk of reintubation, and those who actually need longer ventilation are those who are younger age, small babies, those who require longer bypass, cross-clamp time, increased inotropic support, arrhythmias, residual defects, developing low cardiac output syndrome, or other complications like bleeding. The advantages for early extubation include reduction in the need for post-op sedation, reduction in the length of ICU admission, reduction in the infection rate, improving the family and patient satisfaction, and above all, the economic burden to the family, and also optimal utilization of resources within that. We are all constrained by space. We are all constrained by number of beds we have. Unless those beds are vacated, going to the high dependency, the surgeons cannot take further surgeries. Now, once extubated, most patients require some kind of supplemental oxygen using a nasal cannula or face mask. Sometimes they may need some nebulized medicines also. And once extubated, some may need more support like high flow or non-invasive ventilation in form of PEEP. So this is some examples we had recently. And I think most of the nurses will be more aware of NIV and high flow nasal cannula nowadays. It is quite commonly used not just as a step down from ventilation, but in other conditions as well. High flow nasal cannula is quite commonly used because it is easy, it is giving humidified air or oxygen, and we can titrate both the oxygen as well as the flow to the baby. It is also reasonable for mother to actually breastfeed the baby without any interface being on the nose. While on the other hand, face mask NIV, you can set the PEEP from 5, 6, 7, 8. Though high flow does not give any PEEP, but if the cannulae are blocking the nose and they are fitting more than 50% of the nostril, they may produce some PEEP. So what is the extubation criteria for these babies who actually we are talking about? If we go by Dr. Nichani's, you go from head to toe, but I think for me, it is mainly starting from airway, breathing, circulation. Cardiovascular, they should have minimum inotropes. Echo should show no poor function. Ventilation should be minimal on minimal oxygen, good chest excursions. Gas is acceptable, having good PO2, low oxygen, no acidosis, warm child. We see babies coming out extremely cold. So we need to warm these babies up and have a more normal circulations, which have actually, Dr. Tendolkar has been speaking about it. Child is conscious, he's reaching out for the tube, he's not edematous, and there is no bleeding or effusions. And most importantly, when there is enough staff, we do that. So the post-op recovery, I'm taking a few cases. VSD cough is generally uneventful, and it should post-operative assessment should generally focus on presence of residual VSD and any conduction abnormalities, including heart blocks. Post-op LCOS must be anticipated and managed appropriately in that period. As we see, there might be a honeymoon period, but mostly these babies are extubated within 4 to 6 hours of time, and LCOS is extremely rare in VSD. They only require a brief period of ventilation and recover without any complications. The tetralogy of Fallot. A full repair is repair of the outlet, right ventricular outlet tract obstruction and a VSD closure. And again, most of them have reasonable post-op recovery, and you check for residual VSD or significant RVOT obstruction. And only if there is a chance anastomotic patch, there might be arrhythmias. And we're talking about the restrictive RV physiology causing LCOS. This is what we need to be very careful about in Fallot's tetralogy, which might restrict you from extubating. And when you extubate, ventilate with the lowest mean airway pressure. The TGA and atrial switch operations are slightly more complicated, where these surgeries are done within the first week of life, and the baby may not come out of ventilation because of prolonged surgery, because of so many other factors needing extremely long bypass time, extremely long cross clamp. The aortics, the coronary switches may not happen properly. So these babies may need slightly prolonged ventilation. And this is important to manage low cardiac output state in such babies. But these babies can also come out with an open chest, which needs ventilation for length of time before we take the baby back to theater to close the chest and extubate this baby. So this is one of the examples we had a couple of years back. And some of them will be having a SIRS response as in the first X-ray. And we are talking about effusions. Now, this is a chylous effusion. The chyle will only be evident when you start the milk feeds. Until that, it's just going to be pleural fluid and nothing else. Once you start to see a lot of fluid, chest drain bleeding, effusions being just continued, and you start the fluid, you start this chylous effusion, and it needs special treatment. It needs a special milk to reduce that chyle. In conclusion, the heart and lungs function as one unit most of the times. Each is dependent on each other. Cardiopulmonary bypass in babies is essential, but can cause issues. Post-surgery, both the carbon dioxide and oxygen play an important role in hemodynamics. Extubating a baby at the earliest, not knowing all other parameters being stable, is the best policy. Thank you.
Thank you, Dr. Vishwanath. Any questions for him? Yeah, please go ahead.
Yeah, that was a very nice presentation. And thank you for starting with the Om. So I don't know how many of you know that the Om is the first sound that came when the universe was formed. And apart from that, in NIMHANS, they have done the study and shown when Om system is reduced, they have demonstrated by the CT scan. And what happens is all their negative thoughts, the anger, fluctuation of moods, and their anxiety, depression, everything comes down considerably when Om is chanted. And that's how we know the JAC has produced the paper where they have shown that this divine intervention can have a better outcome on the heart attack patients and also for the heart failure. And that's why when I gave the oration in Lucknow, the chairperson, after I finished, he called me back to demonstrate how the Om is chanted. And that's what the doctors are also, cardiologists are interested. And Om, increases your lung capacity and also the pumping of the heart, because the negative, the systemic, that what to say, like the surge of catecholamines will come down by chanting the Om. So it has got a very positive effect.
Thank you.
I'm sure we have a lot of things to learn from this as well. Thank you, madam.
Thank you. We call on the next speaker, Dr. Sai Sree Ranjani, on to talk on physiotherapy care post congenital heart surgery cases.
Very good afternoon, one and all. Very good afternoon. I would like to thank all the delegates for giving me this opportunity today to present on the role of physiotherapy in the post-operative pediatric congenital heart diseases. I'll straight move to the topic. CHD encompasses a range of structural heart anomalies, as we all know, present from birth, affecting normal cardiac function. Many children with CHD undergo corrective or palliative surgeries to improve heart function and overall health. In pediatric patients with CHD, post-cardiac surgical morbidity and mortality have decreased over the past decades. However, a growing body of research has found that some pediatric patients with CHD experience long-term functional impairments and some degree of disability following surgery, particularly concerning functional outcomes, neurodevelopment, and exercise capacity. Critically ill patients frequently suffer long-term physical and psychological conditions. The amount or type of physical activity a child can do depends on the type of congenital heart defect, the medicines they may be taking, and the devices that may be implanted. There is an emerging need to focus that children and adolescents with CHD should be encouraged to adopt physically active lifestyle. Research shows that patients with CHD has reduced physical activity due to a high number of physician-recommended physical activity restrictions. Children with complex CHD or other risk factors, for example, pacemakers, cardiovertebral defibrillators, channelopathies, frequently need specific mild physical activity rehab protocol. Some children with complex congenital heart defects may need to avoid competitive sports. However, current sport recommendations for majority of the patients with simple to moderate CHD include participation in competitive sports, leisure sports, and unrestricted physical activity following the WHO recommendations for healthy children. That is, daily participation of 60 minutes in mild to moderate or up to vigorous physical activity, depending, we individually program and give the exercise prescription for the patient. Most people with CHD can participate in recreational sports, physical education classes, or other general physical activity. They can go to school like a normal school-going children. As sedentary lifestyle may have negative implications on cardiovascular risk profile and prognosis, effort should be directed towards facilitating the access to physical activity for all the CHD patients. So we look for the challenges. What are our challenges? Post-surgical risks include atelectasis, pneumonia, and retention of secretions that can impede recovery. Long-term mechanical ventilation will result in significant muscle weakness, and physiotherapists have to work on the atrophy. Motor developmental delays are also expected in most of the patients, especially when they are clubbed with some other comorbidity exists along with it. Postoperative discomforts and fear is another reason that may decrease a child's willingness to engage in physical activities and thereby affecting overall fitness. We look for contraindications. So patients with unstable cardiac conditions such as acute heart failure, cardiac tamponade, or severe arrhythmia should not undergo physiotherapy until their condition is stabilized, as we may exacerbate the underlying cardiac condition leading to further instability. Patients with severe respiratory distress, such as acute respiratory failure, should not undergo physiotherapy until the respiratory status is stabilized, or else there may be increased oxygen demand and worsen the respiratory distress. Again, patients with active bleeding or hemorrhage should not undergo physiotherapy until the bleeding is controlled, as we may dislodge the clot and worsen the bleeding. Other contraindications like active infection, flail chest, and pulmonary embolism, we closely monitor it. So what we do is we try to modify, either we just teach breathing exercise in most of the cases, because that is primary for most of the patients. And we give limb physiotherapy to minimize atrophy. And we closely monitor the vital signs, heart rate, blood pressure, oxygen saturation, everything, during and after and before the physiotherapy session. Our goals are to improve respiratory function, reduce risk of pulmonary complications, maintain joint flexibility, and prevent stiffness by giving them range of motion exercises and teaching breathing exercises to improve thoracic mobility. And we also drain the lymphatic fluid if it's accumulated in ankle and hands. And all our treatments are directed towards reducing the hospital stay by facilitating faster recovery and reducing complications. Physiotherapy can help shorten the duration of hospital stay for most of the CHD patients. Physiotherapists also helps patients regain their independence in daily activities such as bathing, dressing, and walking. So our long-term goals are to bring the patient back to the near normal life. They start with simple activities like walking and gradually progressing to more challenging exercises like cycling or swimming to increase the cardiovascular endurance. Focus on strengthening the muscles used for daily activities tailored individually is to strengthen the muscles. And our other goal is to improve the quality of the life of patient by providing supervised cardiac rehabilitation programs that helps patients improve their overall cardiac fitness and endurance. So, the importance of postoperative care is particularly beyond surgical correction. Comprehensive postoperative care, including physiotherapy, is crucial for optimal recovery and development. An exercise training program is part of multi-aspect management for postoperative patients with CHD and is recommended by American Heart Association and European Society of Cardiology. Being physically active means improving the fitness and lowering the risk factors of developing heart diseases, including high blood pressure. All the lovely nurses are always with the patients. So it is very good idea for the nurses to educate patients on heart healthy eating, which is consuming plenty of vegetables, fruits, and whole grains and reducing the risk of high blood pressure and obesity. Children and adults with congenital heart diseases are at risk of obesity, which can lead to high blood pressure and other conditions that can increase the risk of heart problems. On the other spectrum, they are at the risk of malnutrition and they are very lean. So a heart healthy diet is very important. The specific exercises and their intensity are tailored to each patient's individual needs, medical conditions, and recovery progress. Physiotherapists closely monitor patients' progress and adjust the exercise program accordingly. We physiotherapists provide patients with clear instructions on how to perform exercises correctly and safely at home. By incorporating these exercises into the recovery plan, cardiac surgery patients can significantly improve their overall health, reduce complications, and return to more active lifestyle. So what treatments we give is deep breathing exercises and active cycle of breathing techniques. These help expand the lungs, improve oxygen intake, and mobilize the secretions. Incentive spirometry is used to encourage deep breaths and prevent the lung collapse. Expiratory techniques like paper blowing and or blowing a candle are very effective in increasing the threshold of the lung. And techniques like percussions and vibrations and cupping help loosen and clear mucus from the airway, and it can be done with or without nebulization and suction, depending on the severity of the condition. We also encourage patients to walk, to get out of the bed and start walking as soon as it is safe, which helps prevent complications like blood clots and pneumonia and improve circulation and speeds up the recovery process. Techniques like soft tissue mobilization and gentle stretching can help alleviate pain and discomfort associated with surgery and recovery. We also give massage therapy to alleviate the pain and muscle soreness, and also we use massage therapy technique to drain the lymphatic fluid. Other treatment protocol which we follow is positioning and postural drainage. Patients are tilted or propped at an angle required, and chest percussion is performed to loosen the secretions. Frames, tilt tables, and pillows may be used to support these positions. In general, the upper lobe segments have the advantage of gravity drainage, so postural drainage can be facilitated in sitting posture. Middle and lower lobes do not have the advantage of gravity drainage, so a tilt table or propping up on a pillow is essential at a particular angle to drain the fluid. In critical care patients, including those on mechanical ventilation, postural drainage should be performed every 4 to 6 hours as indicated. These are certain postural drainage positions, and these are the references. Thank you.
Thank you, Dr. Sai Sree, finishing on time. Yeah, please.
Thank you very much for your nice presentation. You rightly pointed about the diet and the vegetables. The vegetable contains the fibers and the micronutrients and the what to say, like the folic acid and everything. So that's how in adult, heart attack has incidence is less by 28% if 2 to 3 vegetables are taken. Similarly, the fruits you did not mention. The fruits, especially banana, can prevent constipation, and also potassium and other nutrients can be given. And it contains serotonin, it's an antidepressant. So the children feel better. And it is shown in the adults that by taking 3 to 4 fruits every day, more antioxidants are given, and the oxygen-free radicals are removed like scavengers, and the endothelial damage is also prevented. And heart attack is prevented by 32%. And that's why, any diet, you should have vegetables and the fruits. And that's how we know the junk food should be cut down and this should be added. Thank you very much.
Thank you, madam. I invite the next speaker, Ms. Cecilia from All Institute of Medical Sciences, New Delhi. Her topic is on initial management of children with life-threatening illness, nursing perspective. Please, sir, give the mic to him, please.
Hello. So one important aspect of the physiotherapy is the suctioning. And you nursing officers are the very, very crucial element of that. So when the suctioning should be done and what sort of the precaution we should be done, we have discussed in the previous chapter, in previous talks, that how important it is to do the to take all the aseptic precautions. But simultaneously, we have to keep one thing in mind, that the pressure, the suction pressure, especially in the fragile neonates and infants, that also depends on the need of the patient. Suppose our target is to keep the 80 mm of axial pressure in the maximum pressure indicated, but in few kids, it may that, okay, the airway have more chances to bleed, so lower pressure may act. So all the time, not so. So the adjustment of the pressure and all those things that are done by the nursing officers only. So at that time also, we should be very cautious. And second thing, at the time of the sampling, that is also that also most of the time done by you people only. If physiotherapist is not available, then you people also, some kids are there who require frequent cleaning of the airway. So this is very, very important aspect. Second thing, early involvement of the parents. As madam told, that the limb movement and all those things, these are really, really helpful things which help in the, you can say, increased cardiac output or the early healing of the kid. So involvement of the mother to teach him how to massage, that is also our responsibility, because at the time the mother came in the morning or in the evening hours, you people are sole in charge of the patient. So this is my point. Thank you.
Thanks. Go to Dr. Cecilia MS. Please go ahead.
Slide.
Can Shiva somebody help madam
Yeah.
for the slides? Yeah,
Yeah,
please. Yeah.
Yeah,
Good afternoon, all of you. First of all, I would like to appreciate all of you for your attentive listening throughout the lectures, okay? Though it is overwhelming, like being a faculty, being a teacher, I was sitting here like when the nature's call, when hunger was there, it was like I became a little apprehensive, okay? But I could see all of you very much interested and listening and learning a lot, okay? So here, I'm just going to rush. I think we'll have more of an interaction rather than of a lecture type, because I think you are all you are having hands-on experience with managing critically ill children in your own areas. Like to build a base for that, I would like to highlight the under 5 mortality rate of children in India. It has drastically improved. Like the rate has come down, and that shows the improvement in the care that we provide for the kids who come to our hospitals. I was surfing through net and also through books to find out what does critically ill child means. Okay, anything that compromises the airway, breathing and circulation. This airway, breathing and circulation is the fundamental thing in which determines the criticality of illness in the children. And when we compare children and adults, there are many anatomical and physiological changes that are different in children. So children crash down and also recover at a faster pace compared to that of adults. Okay, these are normal values, and I think all of us are aware of, and it is different across the lifespan. At different point of time or the age of it varies according to the age of the child. And it is always all our measures, nursing measures or medical measures are all depending on this. And it is ideal to display them at prominent places in our ICU or in the emergency so that we are able to have an idea about it. It is good to know, and it is essential. Coming to the rapid assessment system, though in our emergencies and ICUs, it is the physicians or the treating consultants who are going to assess or direct the treatment. It is always good, as being partners in the healthcare. It is good to know how to assess the child, observe the child, and always notify if there are any changes in the child or anything abnormal that we can find and inform. Okay, for that, when we go, this is the rapid assessment format that we always use. That is appearance, work of breathing, circulation. Appearance, here we look for tone of the child, whether the child is flaccid or active. Interactiveness, whether the child is interacting with the parent or not, or with the caregiver or not. Consolability, is the child irritably crying, or is the child being pacified when the mother holds or the caregiver holds the baby? What is the look of the child? Whether the child is staring might be a seizure or anything. And the speech of the child. I think work of breathing was detailedly explained in the previous lectures, so I'm not going to talk anything about it. So we have to always also observe for any nasal flaring or any apnea, gasping, all that also. And circulation is important. Either all of us are aware of, I think all of you have seen children with mottling, cyanosis. So it is essential that we observe. Even when the assessment is going on and the treatment is being decided, you can also put across your opinion that this is what I observe in the child. Okay, it is always good to address the concerns and your observations to the person concerned who is concerned with the treatment and who is going to prescribe the treatment. And this pediatric early warning score, this is the early warning score which is being used in AIMS Rishikesh by one of the nursing student, and she found that it was useful, and there are many studies related to it also. So this is easy to assess, and we assess the CRT, capillary refill time, respirations, behavior, and you have 0, 1, 2, and 3, and also the retractions are scored, and based on when the score is 6+, then the child needs attention. Okay, in these cases, there are several cases reported that children who have this PICU score of 6+ are transferred to ICUs. So this recognition should be there and it can be done on a daily basis. So what is our role as nurse? It is early recognition. Okay, early recognition. We are there with the patient almost in every shift. Okay, and the number of patients that we take care of, we are aware of the patient when we take over and also before handing over. The entire time period we are there with them. So it is very essential that we recognize the symptoms and report. Okay, when we predict any cardiopulmonary arrest, okay, it is important. Any tachypnea or tachycardia, it is, we have to. And this early recognition will help in preventing death of the children. And also, in certain cases, it is also appropriate, like to identify, not all children need CPR. So when it is not needed, that also can be identified. See, nursing preparedness as such comes with this mnemonic wet flag. What does this wet flag mean? Wet flag is W, stands for weight of the child. This weight of the child is essential for calculating the medications. Okay, this weight of the child can be done with this formula, or also you have Broslow's tape, which is available in the emergencies, which is helpful in predicting. And then the energy, it is for the defibrillation. What energy we require for defibrillating the child. So it is 4 into weight. And the tube size, okay, the tube size, ET tube size can be predicted, and it is age by 4 into 4. Then fluids, usually fluids, it is 20 ml NS, okay, per kg. Loraziform is dose is 0.1 ml per kg. Adrenaline, 10 micrograms. I think all of you agree with all these, okay? And glucose, it is 2 ml per kg. Okay, so these are preparedness things which a nurse can keep in prepared when you anticipate, or even when the child is like critically ill. Okay, the ideal part we were seeing in the morning, treat the cause. Treating the cause is important. Okay, the causes might be either respiratory or circulatory. Whatever might be the cause has to be treated, and that is only going to make prognosis in the child. So nursing perspective as such to all these illnesses, what we see is, first is anticipation and preparedness. To anticipate, actually, when we work in ICUs or wherever we are, even in the emergency, it is always, we have to be prepared for anything, prepare for the worst case scenario, and then anything comes, we'll be able to meet it. Okay, so ideally, when a patient is in ventilator, we always keep everything ready. And even in the wards, the emergency cards are ready. These emergency cards are used, and it is also mandatory in hospitals to check it periodically so that we have appropriate drugs which are kept in the emergency card. Preparedness, yeah, I'll just go. Preparedness is training and skill. I'm so happy to see all of you. Many of you are practicing nurses in different hospitals, government and private, who have come here for this work conference. This preparedness is very important. Like preparedness, updating our knowledge, and also BLS training, NRP training, all these enhances your skills and helps to deliver better patient care. Okay, you have to have knowledge. It is not that I'm a nurse, I need not know this. No, it is not that way. You have to be having enough knowledge so that you are able to provide appropriate care. And the codes like code blue or code red or code pink, so all these codes, whichever code is applicable in the hospital, and what is the protocol that is followed, and how to alert these systems. We should be well prepared, and even a new person who is joining should be oriented and made aware of all these codes which are functional and should be activated in case of need. Okay, the emergency cart and equipments, definitely all these has to be kept ready so that we are at ease to meet any emergency situation. Essential items, yeah, I think all of you are aware of, so we'll not go with this. Okay, and essential drugs, the emergency card, all these drugs, it is essential that we check for the expiry date, everything, and it is in place and it is appropriate. And it is ideal and important that every one of us will know what is the dose that has to be given and what is the route of administration. Okay, in case of adrenaline, we can give you what is the method of administration? Adrenaline. IV, endotracheally. Okay, yeah. So we should be aware of all these so that we are able to give. So immediate action. Whenever there's a critical emergency or critical illness that is being reported, then what is the first step? We go with ABC, secure the airway, and then oxygen administration. As we had discussion in the previous lectures, oxygen is also a drug and it has to be used judicially. Okay, as per the need. Then secure IV line. Securing IV line is important. Okay, if we are not able to secure IV line, what will we do? You find intraosseous. In case of babies, it is even UVC can be used in case of neonates. Okay, pulse oximetry and cables has to be connected so that we are able to monitor the child. Drug administration should be done in the correct route. Okay, so all the emergency drugs, all working in the unit should be well versed so that they are able to administer appropriately at the required time. Then fluid administration, I think it was deliberated in the previous session. Holiday-Sager's formula is the one which we use for maintenance fluid, and that we have to be aware of so that we are able to administer the appropriate. Always, if there's a doubt, it's better to cross-verify and cross-check. Have a closed-loop communication rather than taking assumptions. If we are not clear, if we don't understand the prescription or orders, it is better to cross-verify, to ask, and then administer what is appropriate and correct rather than taking assumptions. Collection of samples while inserting IV lines, it is essential. It is better to collect samples. And also infection prevention measures. These are very important. We had a detailed deliberation on that. But even during the process of CPR or emergency management of these illnesses, it is important. And as nurses, we play a vital role in preventing infection. Okay, we have to spearhead. If someone has not done hand wash or not wearing gloves, it is okay to say, please wear your gloves and come. Rather than keeping quiet, thinking that the other person will shout. But the consequences, if they are not using it, if the person gets pricked, it is dangerous for them and for the patient also. So it is better to act proactively in all such situations. Body temperature maintenance, again, we had a detailed deliberations. Universal precautions, always for nurses and all medical professionals, of course, treat all patients as with the standard precautions, universal precautions. Okay, it is your safety. If you are safe enough, you will be able to protect the other persons. Like in the aircraft, they announce, right? First use your mask and then the other person mask. Same principle. First take care of yourself and then the... So, yeah, coming to the optimal, like ongoing care. You have revived and the patient has been... So what are we going to do next? How are we going to proceed? It is important that we should have an optimal airway. Optimal airway doesn't mean only ventilator. Okay, there are HFNC which are frequently used these days. Even children survive with nasal cannulas and according to the availability of the system also. And in the areas, in the ICUs, it is important that we do pain assessment for the kids. Okay, certain children, you can see raising heart rate because of pain too. Okay, all these are alarms. So pain assessment can be done and it can be reported so that pain medications also can be started for the child and the child is at ease. Intake output charting, it is important. Okay, we were discussing, we had a detailed deliberation on fluid and electrolyte management and all that. So it is important that we note the intake output charting, nutrition support, of course. Okay, depending on the child's condition, whatever is it, we have to maintain, and that has to be even charted. Patient safety. See, now you have a lot of look-alike medicine and sound-alike medicines which are there. So it is very essential that we follow medication safety procedures. Okay, verify, use all the checks, and then administer. And also, patient safety when we are handling patients, how safe are we? What are the procedures and protocols? There are a lot of procedures and protocols that are in place. So we are supposed to utilize and use evidence-based practice. A lot of nursing research has been done and a lot is being practiced in the field. Okay, so why not adapt all those practices and follow the best practices so that we are able to provide optimal care to our patient? Then care of catheters and tubes. I think there was a deliberation on Corti bundle, VAP bundle, there are CLEPSI bundle, there are so many bundles and protocols. Okay, all these bundles and protocols also needs to be used. Okay, these are based on evidence. Already a lot of research has gone into it, and there is an evidence showing that this utilization of these bundles has provided prevented infection or has promoted the health of the patient. So these can be utilized, and documentation is an important part. Whatever you do, whatever is your work or whatever is assigned, what medicine you give, or what is the signs and symptoms. You saw mottling in a baby, right? Document. At this point of time, I saw mottling and I have reported. Okay, whatever you do, it has to be documented. Okay, document is not only for your satisfaction or for your reference, it is also a legal document which is going to protect you and also the healthcare facility. Okay, so concentrate on documentation. Then therapeutic communication. This is also an important aspect, like communication with our own healthcare team. How are we communicating? See, we should be first knowledgeable so that we are able to identify and we are able to address, and also communicate in an effective way. Then when it comes to the patient and the patient care attendants, it is the therapeutic communication that we are going to have. Therapeutic communication means what? We are, if according to your hospital protocol, if you are entitled to inform the condition of the patient, inform them actually what is it. Okay, you will not give false reassurances saying that the child will get well. It is okay, I have seen this type of children getting well. No, this will create a conflict when some adverse. See, if everything goes on well, okay, we are all doing and working only for the welfare of the child, and we want the child to be hale and healthy and come out. That is what is all our intention. As healthcare professionals, we all intend to do that. But something is not in our hands. When something wrong happens, it is not in our hands. So never give false reassurances to the patient, and always explain. If you are in a position to explain, then only. Otherwise, follow your hospital protocol. Whether if you have to explain, then say what is the actual condition in the actual manner, so that the parents are well aware of what the condition of the child. Okay, so take home message. I think I made it short. We have to be prepared. Okay, prepared always. Prepare for the worst case scenario so that we are able to handle our patients effectively. And quick action is very essential. Quick action is possible because we are there with the patient for a long time and we observe our patients. So we know the changes and differences. Once, see, increase in heart rate, when we note it and we inform and action is taken, that is quick, and monitor continuously. That is important to our patients. Actions, safe life. These are my references. Yeah.
Good. Good. Any questions for Cecilia?
One of the comments, one of the points which I was actually telling Hiremath is that you touched on pain management. And I think that is the most neglected part in management of children. In fact, if you go to a veterinary hospital, they talk so much about stress and how it can harm a baby. But somehow for human, they take more care on a cat and a dog. But as humans, we don't take care of our babies. I mean, I'm very sorry to say, but we as human treating doctors and nurses, we neglect pain and forget the amount of stress. In fact, that's the one thing I tell my nurses. I don't want to see any of my children cry. No child should be crying in front of me. And they pay so much of attention to a cat and a dog, and it has been shown to kill. Stress is shown to kill. And when we talk of all this, I mean, I think we have to pay more attention to pain and in fact, I will still remember Dr. Tendolkar telling that in Auckland, I think, they even note down what is the thumb in which the child sucks. And I still remember as a student, I had a child who he had done a TAPVC. He says he doesn't do it, but he was doing. And it was an infant. And that child was getting violent and, can go into pH crisis. The only thing that that child wanted to do was suck on that thumb where they think. And he told, see, this is what they note. So these are minor things which nursing can be much more effective. Just imagine the child quietened down after on being given the sucking thumb where an IV line was put. It was removed and it stopped having pH crisis.
On the next speaker.
Yeah.
Thanks.
I would like to invite, thank you, Cecilia. I would like to invite Dr. Parimala. She was in the operation theater helping us to close the chest which was kept open yesterday. So we missed her talk in the morning. She'll be speaking on acid, base and electrolyte balance, basics of it.
Yeah, by the time Parimala comes, no, I have to thank you. It was okay. Because 51 times you said okay in your talk. The okay, do you know what is the meaning of okay? All is well. And that is a Greek word, olakalla. And that means everything is fine. So thank you very much, Parimala.
Good afternoon. Yeah. Good afternoon. I thank Dr. Hiremath for inviting me here. We'll discuss basics of acid-base management. So normal blood pH is slightly alkaline from 7.35 to 7.45. And regular metabolism produces acidic waste. And body's pH is always threatened by acidity. And regulators are lungs for carbon dioxide and kidney for metabolic acids. So we have various indications for blood gas to know the ventilatory status, oxygenation, acid base, and also response to any therapy. We also do blood gas with arterial as well as venous sample. There are minor differences. Mainly, you should note that the saturation in venous blood is around 75%. And PCO2 is slightly higher. So the mixed venous oxygen saturation is useful to understand and treat hypoxia, low cardiac output, and resuscitate patients using treatment protocols in sepsis. And if patients are at weaning failure risk, and also to calculate shunt fraction. So there are limitations for pulse oximetry, which cannot tell us about PCO2 or acid base status. And it becomes unreliable below 70% of saturation, and there are technical errors. So oxygen dissociation curve helps us to know that the partial pressure of oxygen is the driving force for saturating hemoglobin with oxygen. So most of 99% of the oxygen is carried by hemoglobin, and the binding of this can be loose or tight. So if it is loose, that means it is shifted to right, which happens with acidosis, fever, hypercarbia. And these conditions will help in tissue delivery of oxygen. And you should know about PF ratio, because you see here a patient on room air has a PO2 of 60, where he is receiving 21% oxygen. And if it is 90 at 50% oxygen, the PF ratio shows that it is less with 50% compared to room air. So PO2 of 90 is not happy for 50% of oxygen. So we'll go to blood gas acid-base analysis. Normal pH is 7.35 and up to 7.45, and PCO2 45, and if it goes beyond, it is acidosis. less than 35 alkalosis. Similarly, 22 to 26 for bicarbonate. We'll see differences in metabolic, respiratory parameter derangements as well as compensations. Normal blood pH of 7.4 is a balance between PCO2 and HCO3. And acidosis happens when pH is less than 7.35. It can happen because of increase in the carbon dioxide content or decrease in bicarbonate. And respiratory acidosis is when lungs cannot wash out the PCO2. pH starts dropping and PCO2 is increasing. Causes are respiratory center depression with narcotics or other hypnotics, or inadequate alveolar ventilation, or increased carbon dioxide production. Here there are some ABGs showing acidosis. The first one shows that the PCO2 is high, so it's respiratory acidosis. In the second ABG, you see that PCO2 is in the normal range, but there is metabolic acidosis. And third one, you see combined acidosis. So now metabolic acidosis can be discussed with the different techniques. The Boston technique or Henderson-Hasselbalch equation is used, where the carbon dioxide produced mixes with oxygen, water to form carbonic acid, and which now dissociates to hydrogen ion and bicarbonate. Then there is anion gap measurement, and the third one is Stewart-Fensel equation based on electrochemical neutrality. There are various causes. We divide them as high anion gap or normal anion gap. Sorry. So then there is compensation of acidosis by respiratory alkalosis. Now, alkalosis is pH of more than 7.5, which is because of loss of carbon dioxide or increase in the bicarbonate content. And you can see here that it can be fully compensated, partially compensated, or uncompensated. So you see that the pH is in the alkaline range, and PCO2 is normal in the uncompensated, whereas with compensation, PCO2 starts going towards acidosis to bring the balance, and in fully compensated, the pH becomes normal. So we can always analyze the ABG by looking at the pH first. If pH is less than 7.35, it's acidosis. Then you look at PCO2. PCO2 is more than 40, it is respiratory acidosis. Or bicarbonate less than 22 is metabolic acidosis. Similarly, alkalosis based on the parameters. The metabolic alkalosis can be divided as chloride responsive due to volume depletion, or chloride resistant, or potassium depletion. And most commonly we see with excessive soda bicarb administration. So always keep a watch on the amount of soda bicarb that is given, especially when there is cardiac arrest or very low cardiac output. Even blood products like platelets, plasma will cause metabolic alkalosis. Now, respiratory alkalosis is actually iatrogenic in the ventilated patient, and it is the most frequent encountered acid-base abnormality. It can be as a compensation to metabolic acidosis. And prevention of respiratory alkalosis maintains better cerebral perfusion, especially when we have prolonged ventilation with open heart surgery. And peripheral and CNS effects of hypocapnia appear when PCO2 goes below 20. There are multiple mixed acid-base disorders. Few points to remember: single disorder does not lead to normal pH, and a normal pH with abnormal PCO2 or HCO3 may suggest 2 or more disorders. Now, a few points about lactate in the ABG. Lactate is produced in the muscle or blood, and it is carried into the liver to be metabolized. And It is elevated in different conditions. Type A is usually due to tissue hypoxia and anaerobic metabolism. Type B is non-hypoxic origin, and it is called hyperlactatemia. It's due to drugs like adrenaline, hepatic disorders, or inherited diseases. So when adrenaline is given, it helps in entry of glucose to cell. Excessive entry of glucose in the cell will help the load, the tissue, the mitochondria cannot take this load of pyruvate. So it goes into anaerobic metabolism, and so lactate is excessively produced. Now, anion gap. So this is the normal positive and negative charged ions in our blood. Sodium is main blood positive cation, and then there is potassium. So the difference between the addition of sodium and potassium and bicarbonate and chloride, we will give a range of around 3 to 12, and it more than 12, we say that anion gap is high. And this is to determine whether a base deficit is caused by addition of acid or loss of bicarbonate. And base deficit with elevated anion gap is usually ketoacidosis, as in renal tubular acidosis or diarrhea, it's normal anion gap acidosis. This is a newer concept. So the balance is not just between the PCO2 and bicarbonate, it is now with a strong ion difference. So you know that the electrolytes also affect our acid-base balance, albumin and other unmeasured ions in the blood will contribute to plasma electroneutrality. One point to remember here is when we give excessive sodium chloride to a patient, the chloride hyperchloremic acidosis will result, and this also confuses whether patient has tissue hypoxia and low cardiac output. So keep in mind that don't give excessive soda bica. So treatment is mainly volume infusion, correction of the control, and giving soda bica when pH is less than 7.4, PCO2 less than 30, and base excess more than -2 millicoulombs. And the dose is 0.3 into body weight into base excess. Give half of it. Maybe you give larger doses in cardiac arrest situation. ABG also gives us idea about glucose and electrolytes. And in open heart surgery, due to CPB and hypothermia, giving steroids or adrenaline, all these may affect the glucose levels. And insulin may also affect our glucose. If excess is given, then hypoglycemia can occur. So target is 110 to 180. And defer surgery if glucose is more than 400. So bolus infusion, if you have to give 0.03 units per kg, and infusion at dose of units per hour as random blood sugar divided by 100. If blood glucose is more than 400 or infusion requirement is in excess of 30 units per hour, inform the intensivist. And hypoglycemia is when glucose is less than 60. Give 50% of 50 ml of dextrose in an adult. Then check sugar every 30 minutes. And for next 3 consecutive levels, it should be more than 80. In children, mild hypoglycemia is 50 to 59, and in the neonate, it's less than 30. Few points about internal potassium balance. Whenever there is acidosis, in exchange for hydrogen ions, the potassium is excreted from the cell. This results in increase in the potassium. And with a pH decline of 0.1, the potassium rises by 0.4 in acidosis. With accumulation of organic acids, the effect is negligible. But if alkalosis and normal potassium is present, risk of overdose is high if we correct with potassium. Hyperkalemia treatment should be carefully done when the concentration is more than 6 milligallons per liter. And if ECG changes are there, give calcium, soda bicarb, insulin with glucose, diuretics. And point about low cardiac output and potassium balance. So if there is oliguria with rising potassium, that is more than 5 milligallons in 4 hours, and other signs of low cardiac output are there. You should suspect that patient is not doing well because hypotension, acidosis, these appear late in children. This is one ABG of a TIPC child. See, immediately after shifting, the potassium is 2.6. There was no excessive potassium given. And next, the patient, even though the lactate was normal, the potassium started rising. And this was a sign of low cardiac output. Now, management of hypokalemia and potassium between 3 to 3.7, you can add it to the fluid. And if serum potassium is less than 3 milligallon per liter, then infusion is given at 0.5 milligallon per kg per hour. So the ABG has some limitation. It may be insensitive or non-specific. And there are multiple causes for one disorder. And the hyperventilation situation, metabolic acidosis may be masked with metabolic alkalosis. Hypercapnia is rarely seen in chronic hypoperfusion with metabolic acidosis. Tissue acidosis continues, but ABG may show correction. Thank you.
Thank you, madam. Any questions to Dr. Parimala? I think with this, we'll end the session. Dr. Ani?
Thank you, Chairpersons. We begin with session 4. It is on identification and management of the post-operative complications in the pediatric cardiac ICU. Our first speaker is Dr. B. R. Jagannath, who will be talking about the low cardiac output state post-cardiac surgery. And the chairpersons for the session would be Ms. Cecilia MS, Dr. Hooley, Dr. Parimala Simha, and Dr. Anil Tendolkar. Dr. Umid Singh.
I already feel tall, standing on the stool over there. While we are waiting to get my slides fixed up, can somebody tell me who is the lady with the lamp? Wow, I have woken you up. Yes, you did. You made them come awake much more better than anybody else did. Low cardiac output. Okay, other than being recognized as the lady with the lamp, can somebody tell me something more about her?
Okay. I will give you a pie if you.
No. It is open to.
I said I will give them a pie if they tell it.
Oh, fine. That's right. So now you have another incentive. Right.
Yeah.
No. Sorry, I couldn't get it. Okay. Yeah. Can you tell me something more? Correct. Okay. Okay. But how is it related to your nursing profession? What I'm asking you is related very much to your nursing profession.
And the clue is I will give you a pie if you tell me the answer.
Come on.
She emphasized on hand washing. She she em
No. That is Ignatius Semmelweis.
emphasized on
Second World War. No, sorry. Crimean War. Crimean War. Okay, come on.
during the Crimean War. She was very
That's
cautious
done.
that she was doing hand washing as a basic protocol,
Done.
which
Oh, yes,
resists the
that's a
infection.
good point. Yes, I agree with you. Come on. After she came back, I'll give you one more clue. After she came back from Crimean War, she started nursing. Yes, that's fine. But then, how many of you know that she became a member of the parliament? She became member of the parliament, and in the parliament, she actually presented data from the Crimean War. If you look at her paper, which she presented in the parliament, it's surprising. Beautiful colored not pie charts. They were a different kind of a chart which showed how you can improve the nursing cadre. That is point number 2. And point number 3 is that she maintained meticulous records. On top of that, she had very astute observational capacity. Why am I telling all these things? To recognize low cardiac output, you are our eyes, hands, ears, nose, and mouth. Means you will be at the forefront. You will be the flag bearers. And which means that you should develop astute observations. It is no rocket science. During the time of Nightingale, Florence Nightingale, there was no ICU, there was no monitors, there was no newfangled pumps, infusion pumps, etc. All she had was pair of ears, pair of eyes, pair of hands, and she delivered excellent care. And that is the reason why we need to go back to basics. And today, I'm not going to go into great details about how it is. We will look at basic things which is the okay. We'll look at basic things, right? So now let's look at what is low cardiac output. It is not a disease. It is not a single entity, but rather it is a combination or a well-recognized collection of physiologic and hemodynamic disturbances which prevents the circulatory system from providing adequate oxygen and tissue to meet the metabolic demand. That is, in short, what is LCOMS. It is a state. It is not a diagnosis, right? The next thing what we need to understand is it is not a single event or a single thing. Rather, it is a conglomeration of events. And you also have, please don't keep writing it down or clicking, basically because I will go through this list again. Right. So now, when 2 or more of these criteria are present, then it is called as low cardiac output state. Right. So now why are we so worried about this low cardiac output state? What happens is when there is low cardiac output, you will have end organ damage, which means kidney, liver, brain, skin, name it, and that can be damaged because its metabolic needs are not met. As a consequence of this, you will have increased mortality. It also increases the ICU stay, it increases the hospital stay. All of it translates to increase in the cost, both to the patient, patient's attenders, and to the service provider being the nursing and the medical staff. Right. Can we predict this low cardiac output? From morning, we have been having quite a lot of lectures which actually told you, yes, these are the things. I think Madam Cecil said that, look, there are a lot of things which contribute to producing a low cardiac output state. So this was a paper which was from Frontiers in Pediatrics, and when they analyzed 250 odd patients, for those who had low cardiac output in the post-op ICU and those who did not have, they found that neonatal age, weight which is less than 3.5 kilograms, RAC score. How many of you are aware of RAC score? It was developed by Boston Children's Hospital, developed by the nursing people over there. It is called Risk Assessment Score for Congenital Heart Surgery. All the congenital heart surgeries have been classified, and they range from 1 to 6, depending upon the complexity, depending upon the time it takes for the operation. So RAC score greater than 4, and yes, these are the main factors which can predict the possibility of a low cardiac output state occurring in this one. So now we will look at how we can gather data. Monitor the charts. They are your best guides. So first, let's look at the monitor. In the monitor, what is the first channel that you will see? ECG. Is it basically because I have written ECG over there? Or how many of you work in the ICU? All work in the ICU. How many work in the theater? Okay, Mukunda, correct. Right. Few of them are there, right. Good. So now when you have ECG as your first, this one, can somebody tell me what you notice in that ECG that I have put up over there? Rate, fantastic. So what is it's a little bit complicated, but remember that if it is less than one small box between two it is very high rate. What else do you notice over there? Regular rhythm. So you have tachycardia, you have regular rhythm. Both these two indicate that it is abnormal. Now, the abnormality usually is in the form of junctional ectopic tachycardia or supraventricular tachycardia. And if both these two are present, chances of going or slipping into low cardiac output is very high. So when you look at the monitor, you will suddenly see from nice sinus rhythm, it goes into something like that, what is seen over there. So rising rate, regular or irregular rhythm. In addition to that, if you have this situation prolonging over a period of time, it is what can lead to low cardiac output state if it is not recognized in time. So what is the next channel that you will get over there? Arterial blood pressure. Okay, fine. So what you're seeing over there is a normal arterial trace. If you see, the arterial trace goes up like that, there is a small plateau, and then it dips down. The downslope is not as vertical as the upslope. Going up, it was vertical, but going down, it is not as vertical. It goes down like going down a hillock. And then there is a small rise, and then it goes down to the baseline. This is a typical normal arterial trace. When you find that there is difference in this, either this vertical becomes more slanting, there is a sharp peak instead of being a round curve, or that the dichrotic notch, what we call, is absent, then this is a nice predictor to say that your patient's cardiac output is not adequate. That is when you should start thinking. Again, we already talked about it. Tachycardia and heart rate is very important. If the tachycardia is more than what is expected for the 95th percentile, that means if you have a 3-kilogram child, the 95th percentile would be somewhere around about 110. If the rate is much more than this, then you should be very cautious. Right? That is when you should get them to talk to you. Temperature. I think it has been emphasized by Cecil, by almost all the other speakers. When the patient comes to you from the OR, you will find that the patient is slightly cool in the peripheries, and over the next 4 to 6 hours, the temperature goes back, comes to normal, which is 37. Now, when I talk about temperature, how many kinds of temperature do you know about? Huh? Core temperature, peripheral temperature. So core, where is the core? Nasogastric, rectal. What is peripheral? Right. So what is the difference between the peripheral temperature and the core temperature normally? One. Okay. So I presume you understood this point. Now, if the temperature difference between the core and the periphery is 7 degrees centigrade or more, then you will find that it is an indication for low cardiac output. Some people say 5 degrees is enough. If there is such difference, it becomes. One thing you must understand, rampant use of warmers in the ICU prevents actual detection of low cardiac output because it artificially keeps the temperature warm. So please be aware of that. Saturation monitor, blood gas. Parimala madam has already told you about this particular thing. One thing you must understand, saturation probes are temperature dependent. They work best between the ranges of 70 to 95. Anything beyond this, the saturation probe actually is not consistent. Arterial blood gas showing low saturations, venous blood gas showing high saturations, or a very low difference in saturation, all of this indicate low cardiac output. We will not go into the nitty-gritty of why because of the lack of time. Anybody needs to know, you can come back. The most important thing is how you define cardiac index. So anybody has any idea what is cardiac index? It is cardiac output divided by the body surface area. And if that cardiac output divided by body surface area is less than 2 liters per minute per meter square, it indicates low cardiac output. And the best way to know it is capillary refill time. I think it was already alluded to in one of the previous speakers. Do you want me to go into a little detail, or shall we take it as read?
No, it's a time we have to plan.
Okay, we'll go to the next. Normal CVP, 6 to 8. Post-operative period, it can go up to 12. Anything over this can lead to low cardiac output syndrome. Left atrial pressures generally are not measured in most units, but I think it's different in All India Institute and a few other places where you do take left atrial pressures. And this left atrial pressure, again, the acceptable limit is 12. Anything above that, the patient can go into low cardiac output very easily. PA pressures, 25 by 12. Have a look at the lower figure. The diastolic 12 indicates the left atrial pressure. If it is high, cardiac output is going to be hampered. Charts. Urine output. Normally, in post-operative period, it should be about 2 mils per kg per hour or anything more than that. Anything below 1 milliliter per kg per hour should raise a flag. Anything below 0.5 is highly suggestive of low cardiac output. So the idea is, please don't just keep writing numbers into your this chart. Please think. And that is where Nightingale exceeded her capacity. And she was very brilliant in noticing these things. Persistent anuria, the main thing is rule out obstructive causes. The catheter kinking, catheter not in the urethra, but probably outside somewhere. These are the more common causes than low cardiac output in a child who is screaming and in good with anuria. Now, in your charts, you have inotropes. There is a calculated value which is called vaso-inotropic score. We will not go into the great details of it. I have put it on the slide over here. Understand that if the patient is on multiple inotropes, the chances of going into low cardiac output are much, much higher. We already went through this. These are some of the figures which Dr. Parimala has already pointed out, and how to interpret. We have seen through this. Blood lactate, again, Dr. Parimala has told you, whenever there is low cardiac output state, the lactate level tends to go up. Normal expected values is less than 2 millimoles per liter. Post-op, it can go to any levels. Understand one thing over here, that either a rising trend or a falling trend. A rising trend means that low cardiac output is worsening. A falling trend means that the low cardiac output is getting better. A single value carries no meaning. One should always call for chest X-ray, echocardiography. We will not go into the details. So this is a risk scoring system which is more applicable to the adult population rather than to the pediatric population. I just put it in to this one. So in conclusion, remember that LCOS is not a disease, it's not a diagnosis. It's a combination of various parameters. Its early detection and prevention is extremely important. And early treatment results in prevention of progressing to a shock state. Reversing from a shock state is extremely, extremely difficult. Thank you.
Thank you, sir. I think we'll move on with the next talk, sir. Dr. Devaguru on arrhythmias. He's online from Delhi.
Good evening. Can you hear me?
Yes, sir. Yes, sir. Please go ahead, sir. Welcome, sir. Dr. Guru, welcome.
One minute, sir. Good afternoon, everyone. I apologize, I am not there personally. Just now, Dr. Jagannath sir has completed on low cardiac output. We'll continue with the postoperative complications. One of them is arrhythmia. Arrhythmia is quite common in post-op care, both in adult and pediatric. We look at what is how common it is, what are the risk factors, and how can it be managed, how it can be diagnosed, and how it can be managed. Arrhythmias postoperatively in children can range anywhere between 7 to 50% depending on the series quoted. Most often it is due to the complexity of the surgery, or it also depends on how much time you take to do the surgery, how complex it is, how much time you have taken in the theater, and whether the cross clamp time was more, or whether you have handled the myocardium, or have you gone very near the conduction bundle. These are the factors which are likely to affect the post-op arrhythmia incidence. In addition, we'll have to take care of the acidosis, and in fact, if any low cardiac output is there, it can also precipitate arrhythmia. And any change in the electrolytes, hypokalemia, hypomagnesemia, and hypocalcemia, all of them can precipitate any rhythm abnormality. There are things which we can control, and there are things which are not possible to control. So we'll look at things which are controllable. To understand, we can divide the arrhythmias which occur postoperatively into two types, tachyarrhythmia and bradyarrhythmia. In that, tachyarrhythmia we can divide into which occurs in the atrium, that is, which have a narrow QRS complex, and which is due possibly of ventricular origin, that is the broad QRS complex. Then bradyarrhythmia is when we have a rate lower than 60. Again, it can be sinus bradyarrhythmia or sinus dysfunction, or it can be heart block, or it can be ventricular asystole. We will see one by one. The most common arrhythmia which happens in postoperatively is the jet, which Dr. Jagannath had previously said. So we have this told, no, it can be either narrow QRS complex or broad QRS complex. In the narrow QRS complex, we have different sets of arrhythmias which can happen. Sinus tachycardia, per se, it is not an arrhythmia, but it's a high heart rate, which may lead to low output. Then we have the junctional ectopic tachycardia, which is the most common. And we have the atrial flutter and fibrillation, which more often happens in adult patients, especially valvular disease, or rheumatic heart disease, or coronary artery disease. Though atrial flutter and fibrillation are not common, we should know to diagnose as and when it happens in a pediatric population. Of course, broad QRS complex, we have the ventricular arrhythmias and supraventricular arrhythmias and ventricular blocks. One second. My screen. Okay. As you said, junctional ectopic cardia is the most common, and if you know to diagnose it as and when it happens, you'll be able to take precautionary steps. Usually the rate is from very high. It can range from 150 to 250 with a narrow QRS complex. That is how we can diagnose. Sometimes it may be confusing with the supraventricular tachycardia. The only way we can know is the SVT usually responds to adenosine or a cardioversion. JET is refractory to these measures. And the definitive way of knowing is if you have a pacing wire, atrial wire, then we connect it and take a ECG, you'll be able to diagnose a atrial origin. What are the causes of JET? One is it can be low cardiac output, that we have to know, or it can be drug induced, like dopamine causes high rate and it can be there, or it can be because of the prolonged surgery. As I already said, the cross clamp time, CPV time, all matter in the post-op incidence of arrhythmias. If the core temperature, because of it can be double edged, if the core temperature is raised because of low cardiac output, again it may precipitate arrhythmia. Of course, you'll have to take care of electrolyte imbalance, and also we have to see if any arrhythmogenic drug is going on. How do we treat junction ectopic tachycardia? Once we diagnose it as junction ectopic, then we'll have to see how it can be treated. First, we'll have to address the cause, whether it's because of temperature induced, whether it's because of low cardiac output, or is some inotrope like dopamine is causing it, or is just part of a surgery because we have if you are doing a tetralogy, we are stretching the atrium, or if you have a myocardial incision, all this can produce it. Or when you have worked around the bundle, that is conditions like tetralogy of Fallot, VSD, AV canal, all these are prone for high incidence of junctional ectopic tachycardia. Usually what we do is look at the causes for low cardiac output, try to manage it. If we have a 4 pacing wires, then we'll be able to do AV sequential pacing, or at least do a overdrive pacing with the atrial wires. Then we'll be able to revert it back. If there is inadequate response, then we can go for routine like Cordron, or if you want to further, you can, of late we have started using Ivabradine, or you can have beta blocker like Sotalol. These are some of the measures we take, but in addition, we'll have to make sure that we are not losing any other cause. Sometimes tamponade can produce. All this, we have to look at the CVP, we have to look at the other parameters. Maybe you'll have to, once you're settling, you'll be able to see the echo if there is any other problem is there. As I said, atrial flutter and fibrillation are not so common in a child. It's more common in adults. But how do we manage them? If there's atrial flutter, we can see a sawtooth appearance of the ECG. Most often happen in adults. What we do is it requires, because it is going to produce a hemodynamic instability, what it requires is cardioversion. That is must. If there is atrial fibrillation, if there is hemodynamic instability, then we'll have to at least control the rate of the rhythm. For rate control, several measures are there. We can start with simple digoxin, Dilzem, beta blockers. If you want to control the rhythm, then we have to use Cordron, Amiodarone. That is the best treatment. So if it is a recent onset, we like it to come back to atrial normal sinus rhythm, because if it doesn't come back to rhythm, then we'll have to add blood thinners to prevent left atrial clots. For that reason, atrial fibrillation, rhythm control is important if it is recent onset. Sometimes if it is been there for long, like a valvular heart disease, rheumatic heart disease, then we may not be able to get back the rhythm. Then we may have to take care of the rate alone. This I said atrial fibrillation, the absence of P waves. That's how it's irregular rhythm, absence of P waves. Once we know that we are not able to control the rhythm by amiodarone, then we may have to go back to rate control to improve the hemodynamics. In addition, if it sustains, then we may have to continue anticoagulants. Of course, ventricular tachycardia we can easily make out by the broad QRS complexes. Of course, then it will often produce hemodynamic instability. The first thing to do is cardiovert the patient. DC shock should be given. Same is true for supraventricular tachycardia. We'll have to first diagnose, but it's simpler diagnosis is when you give adenosine, it's usually often reversed. That is, it'll help in the management and also for the diagnosis supraventricular tachycardia. When you have ventricular fibrillation, that is what we call complete arrest. When the hemodynamic instability is there, we call code blue. Then we'll have to start CPR. And when we are resuscitating, we should think in terms of defibrillating. Of course, we'll have to look at the electrolyte. When the resuscitation is going on, we'll have to look at the ventilator parameters, whether it was due to hypoxic arrest, or it was due to electrolyte imbalance, or it is tamponade. All this, once you start resuscitating one by one, we'll have to look after to see what is the cause which precipitated the ventricular fibrillation. Sinus bradycardia is when the rate is very low. Any rate below 60 is bradycardia, any rate above 100 is tachycardia. But in children, usually, depending on the age, rates may be higher, 120, also may be normal in a neonate. But sinus bradycardia is when the rate is below 60. First, you will have to see whether it is normal or abnormal. If slow rate, first you will have to look at medication, whether the patient is on digoxin, high dose, or the codron which you have started is more, or if there is hypothermia. The commonest cause, what we get in pediatric population post-op for low heart rate is sedation or hypothermia. Deep sedation also produce low heart rate. Then we have the sick sinus syndrome. The most often these are reversible. If they don't reverse, then we will have to look at the possibility of a pacemaker. These are not so common in pediatric population. The next to jet, the most common problem we handle is either the patient comes with a heart block from the theater, or it may develop over time. Most often the patient develops intraoperatively when we are handling the bundle area like VSD or tetralogy or heavy canal. In addition, there are several other conditions, surgeries where we are near the bundle, which can produce blocks, like even tricuspid mitral valve can produce blocks. These are the incidents of the blocks. In pediatric population, the most common is VSD, AV canal defect, and tetralogy. These are the common where we get the blocks. And when we get a block postoperatively, the maximum time you can wait is up to 7 days. By 7 days, you will know whether the rhythm is going to come back or not. If it doesn't come back in 7 days, probably you'll require a pacemaker. There are other conditions where postoperatively, the patient must have come in sinus, they must have developed a heart block much later or a bifascicular block. These are some of the indications where you will require a pacemaker. So whenever the patient is in block, it's ideal to have all the 4 pacing wires placed, both 2 atrial and 2 ventricular. And ideally, you should make sure that you're taking a action by 7 days because your temporary pacing wires may not work beyond a particular time. So it's ideal once you're confirmed, or if you're not able to confirm, you can have a Holter in the post-op period to confirm a block, and then we'll have to insert a pacemaker. So post-operatively, arrhythmias are common in post-operative setup. Especially there are 2 arrhythmias, jet and heart block are common, which are the commonest we usually anticipate. Once you recognize early and take preventive measures or a prompt management, the outcomes are good. Of course, you'll have to engage with your cardiologist, intensivist, and optimize the treatment. Especially when the newer drugs are Ieva are all coming, then it's better to involve the pediatric cardiologist and the intensivist to take a decision on the management. Thank you.
Over, question answer. All of you on the practical suggestions, moment you see an ectopic, there should be a corresponding change in the arterial trace and pulse ox trace. Simple cause of it, arrhythmias post-op are the leads loose. This according to me is the most common cause. So first check whether corresponding arterial and pulse ox tracing have changed or not. Number 2, does your monitor have a facility of recording that event? Just make sure your monitor has. Some monitors have even on a paper, it can eject out a recording of only one lead, common lead. So you must be familiar, because simple question, the cardiologist or any intensivist is going to ask, what is the proof? What was it exactly like? So just make sure that you are conversant with that mechanism of recording the arrhythmia. So that also you be sure. Or some scopes, any event can be stored and you know exactly what time it occurred. So you should be conversant with your monitor from arrhythmia point of view. Sinus bradycardia, what first thing you will check as an ICU nurse? I'm waiting for the next speaker. Sarah, I'm waiting for the next speaker.
Dr.
Sinus
Peter,
bradycardia, what is the first thing comes to your mind as an ICU nurse? Cardiac ICU nurse. Hypothermia. Third day, second day, patient well, blanket on.
Yes. Yes.
Cause of hyperkalemia, cause of sinus bradycardia is hyperkalemia. Look whether your potassium drip by accident going fast. Just make sure.
we have the next speaker
Sorry.
to speak on pulmonary hypertensive crisis, Dr. Marek. Please go ahead, sir.
Yeah. Hello. So now we have a team pulmonary hypertension crisis. So what's the pulmonary hypertension crisis? It's an acute worsening of symptoms in pulmonary hypertensive crisis patients, for example, with severe shortness of breath, hypotension, and they can...
Excuse me, can we have little... Thank you. Sorry.
No. For example, severe shortness of breath, hypertension, or they can have rapid heart rate and can be triggered by various factors like infections, dehydration, and non-compliance with medication or surgical procedures. Here we have a definition of pulmonary hypertension, and we can see that pulmonary hypertension is defined that medial pulmonary artery pressure is more than 20 millimeters of Hg. It's full clinical. It's all typical. It's typical for all group of pulmonary hypertension, and we can divide it into precapillary hypertension, combined precapillary and postcapillary hypertension, and then isolated postcapillary hypertension. It's there is a difference in precapillary hypertension. We have medial pulmonary artery pressure more than 20, and it can be attributable to lung disease or chronic thromboembolism, pulmonary hypertension, and there is a lesser the pulmonary artery wedge pressure, which is less than or similarly less than 15. The combined precapillary and postcapillary has the medial pulmonary artery pressure more than 20, and pulmonary artery wedge pressure is more than 15, and it's caused where there is a left heart disease or left heart and lung disease overlap. And where there is only postcapillary pulmonary hypertension, there is a medial pulmonary artery pressure is more than 20, and it's caused by left heart disease. So here I have some etiologies from pulmonary artery hypertension, and it can be idiopathic, heritable, drug and toxin induced pulmonary artery hypertension, and associated with something and with some another diseases like connective tissue, HIV, portal hypertension, congenital heart disease, or schistosomiasis, and it can have a patient with long-term responders to calcium channel blockers, pulmonary artery hypertension with overt features of venous capillaries involvement, and persistent pulmonary hypertension of the newborn. Patients with pulmonary hypertension, then they can have left heart disease with preserved or with reduced left ventricular ejection fraction, and with valvular heart disease and congenital cardiovascular conditions leading to postcapillary hypertension. And others are the hypertension can be due to lung diseases or hypoxia, with obstructive or restrictive lung disease, with mixed of both, hypoxia without any lung disease, and developmental lung disorders. And in the fourth, pulmonary hypertension can be caused by pulmonary artery obstructions, with chronic thromboembolic pulmonary hypertension, then any others like sarcoma, malignant tumors in mediastinum, carcinomas of uterine, renal carcinoma, and non-malignant tumors like leiomyoma, and congenital pulmonary artery stenosis, and it can caused by parasites like hydatidiasis. And the last one, with unclear on multifactorial mechanisms like hematologic disorders, systemic disorders, and metabolic disorders like Langerhans's histiocytosis, Gaucher disease, glycogen storage disease, neurofibromatosis or sarcoidosis, and chronic renal failure and fibrosing mediastinitis, and any other complexes of congenital heart diseases. Here I have a pathophysiology of pulmonary hypertensive crisis. It develops by increased vascular resistance in the pulmonary circulation. Then it tends to right ventricular failure because of, and then there are more increasing right ventricular and diastolic volume. It tends to right ventricular wall stress. Then it tends to right to left septal shift, which leads to left ventricular performance decreased, and it decreased left ventricular stroke volume, and the cardiac output is decreased like medial arterial pressure, and it tends to coronary perfusion, and it's I would say a devil circle. So a crisis when occur when the body is unable to compensate for the increased pressure and hypoxemia. Which are common triggers? It can be acute infections like pneumonia, patients with non-compliance with medications. It can cause after surgery or anesthesia, during the anesthesia, where there is emotional stress and physical exertion, in pregnancy and changes in estrogen levels, and with a severe of hypoxemia as or embolism. The triggering stimuli for perioperative pulmonary hypertension crisis is during the anesthesia. We should avoid hypoxia, acidosis, hypocarbia, and the noxious stimuli like pain, tracheal sectioning, agitation of the patient, and hypotension. It also can tend to pulmonary hypertension crisis. The clinical signs with the patient with is not incautious. There is severe dyspnea, shortness of breath, chest pain. They can have syncope, fainting. They are cyanotic, they bluish skin. They have a tachycardia and like rapid heart rate, and they are hypotension with low blood pressure. And which diagnostic tools we have? The first, if we have to make an echocardiogram to measure the right ventricular pressure and gradient between the ventricle and pulmonary artery, the right heart catheterization that can confirm pulmonary hypertension diagnosis and measure the pulmonary pressures. Then can we do for there is can be thromboembolism. Then can be a CT pulmonary angiography. And then we can do some blood tests for markers of inflammations and organ dysfunctions, and maybe X-ray for excluding the inflammation of the lungs, and some exercise tests to evaluate functional capacity of the patient. Which is acute management of pulmonary hypertension crisis. It's oxygen therapy to improve the oxygenation. We can use vasodilators like nitric oxide and prostacyclin analogs to reduce pulmonary artery pressure. We can put some intravenous fluids to manage the hypotension, and then maybe we can use mechanical ventilation if it's required, and then at least right heart support, for example, some inotropes in several cases, or we can use ECMO. This is the treatment, as I said on the last. What's necessary to know that administration of oxygen that increased alveolar oxygen and partial arterial oxygen can decrease the pulmonary vascular resistance, and hyperventilation decrease the pulmonary resistance as well. We should exclude any other ventilation complications like pneumothorax. We should optimize the ventilation, like decrease mean airway pressure, and we should be avoid to more pressure in alveolars than in arterial pressure in the lungs, and we should correct metabolic acidosis, because the pulmonary vascular resistance is directly related to H+ level and decreased pH. We can administer some pulmonary vasodilators like inhalation nitrous oxide, and we should, of course, support the cardiac output to adequate preload and inotropic support, and then maybe ECMO if it's still resistant. We should support coronary perfusion to maintain SVR with epinephrine or vasopressin, and of course we can't forget for analgesia, which decrease the sensory sympathetic mediated increased pulmonary vascular resistance. So this was the short-term management, and this is the long-term management. It's a targeted therapy of using of medications like endothelin receptor antagonist, phosphodiesterase inhibitors, or prostacyclin analogs. We can use anticoagulation, especially in the chronic thromboembolism pulmonary hypertension. And at least we have a lung transplant for very, very severe cases. So to preventing crisis is regular follow-ups and monitoring on pulmonary pressures, adherence to prescribed medication and lifestyle modifications. And it's very, very good to vaccinations the patient against the flu, pneumococcus pneumonia, to prevent the infections of the lower respiratory tract, and educate the patients. They should be avoiding triggers like stress, physical overexertion, and infections, and important of medications adherence. Just key to take away that pulmonary hypertension crisis is life-threatening event that requires urgent management. Early diagnosis and appropriate treatment and close monitoring can improve outcomes, and ongoing research into better therapies is essential for improving patient care. So from my side, that's all, and thank you.
Anybody wants to ask? Dr. Jagannath? The picture of pulmonary hypertensive crisis and cardiogenic shock, low cardiac output, is almost the same.
Yes. I
So
would-
are there any diagnostic blood gas analysis of pulmonary hypertensive crisis?
Maybe decrease of oxygen in pulmonary artery. We can, if we can use it in OR from the pulmonary artery ABG.
Pulmonary arterial ABG. For
Yeah.
that will require a
And
catheter
then
in
we
the
can
pulmonary
pressure. Then we can pressure in OR. We can.
If you have got pressure in pulmonary artery,
Yeah.
there is no, but otherwise standard, do we have a catheter in pulmonary artery, Dr. Jagan? Not routinely. So from arterial blood gas drawn from radial or femoral, is there any diagnostic to say this is pulmonary hypertensive crisis?
I wouldn't say so.
Because
Just
static
echo.
also gives rise to
Yeah.
low pressure, tachycardia,
Yeah.
tachypnea,
Maybe echo we can do.
echo.
Echo.
Okay. Anybody? Airway pressure going. So provided the patient is on ventilator. Then
going up.
oxygen level normal and
Going up. And your air pressure going up is usually the first sign of.
and remember there are certain conditions like TAPVC where a surgeon may open up the vertical vein. Am I right, sir? So you will do it in ICU or take to OT as an emergency. OT operation. Not recommended. Other. Okay. Thank you very much.
So meanwhile, next speaker comes. I have something to add with this PH crisis thing. We routinely face this entity in our ICU. And first of, we should know what are the risk factors. The patient who preoperatively have high PA pressures like left to right sent most of time, and the patient operated for the truncus arteriosus or as sir told the TAPVC, they have more chance to have hypertensive crisis in the post-operative period. So as a routine, what we do in open sternum, most of time we put a PA line, and by the time sternum get closed, we have PA pressure monitoring. So in that scenario, we easily can identify or diagnose and manage. But when the crisis situation happen, what we notice most commonly, it is the PCO2 high. This is the increased PCO2 level over the permissive level. That is more than 65, as well as hypoxia, systemic pressure is low. So in that scenario, what is the most critical or significant role is we have to start back ventilation as early as we can, and simultaneously we raise the call for help because it's a crisis situation. We may lose the patient in couple of minutes, you can say.
Yeah, thank you, Umedan. There's a small change in the plan. We are having inauguration right now. After the inauguration, we'll be continuing the remaining sessions. After inauguration, high tea is arranged. Have high tea, come for the next sessions. We have another 3 sessions left. So Sadhguru Madhusan Sai will be coming online. So we would need to have inauguration. I request all the delegates to be seated, please. I request all to maintain silence. Please, sir. We actually planned it at 5 sharp, sir. Over to Sai Lakshmi, please.
You can call Dr. Anupa.
ಆ ಚೇರ್ ಬರ್ತದೆ ಬೇರೆ.
ಯಾವುದು?
Come on.
ಇರ್ಲಿ ಸರ್.
Maybe you break his back. Poor guy.
No, they have stacked it.
Come. They are meant only for that. Take it. Hey, take your this back.
ನಾಲ್ಕಲ್ಲ. Water. Water bottles. Water bottles. Yeah, but he has to leave by 5:30. We will start on. It will take 10 minutes. He's coming only for Dr. Nichani's. Water bottle. Once we start, we'll live that.
Start ಮಾಡಿದ್ರೆ ready.
ಅಲ್ಲ ಅದು ಲೈವ್ ಆಗುತ್ತೆ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ಮೇಲೆ. Water bottles. I'm just waiting for water bottles. I asked that boy, are they bringing? Hello and good evening, everyone. Offering our salutations to our founder, Sadhguru Sri Madhusudan Sai, who will be joining us virtually in a few minutes. Eminent cardiac surgeons, intensivists, and cardiologists, our honorable guests, Ms. Anuba Devagoru, Assistant Professor, All India Institute of Medical Sciences, New Delhi, Dr. Sanjiv Nichani from the United Kingdom, esteemed faculty present here, and all those joining us online, nurses and conference delegates, good evening and welcome to the inaugural session of this international conference on pediatric cardiac intensive care here at Sathya Sai Grama in collaboration with the AIIMS. We will commence the proceedings with auspicious lamp lighting. We request our dignitaries on the dais to please come forward and light the lamp.
Asato ma satgamaya tamaso ma jyotirgamaya mrityorma amritam gamaya. Shanti, Shanti, Shanti.
Thank you. Students of the nursing program will chant the Meda Suktam as part of the invocation.
Shri Gurubhyo Namaha Harihi Om Medha Devi Jushamana Na Aga Dvishwachi Bhadra Sumanasyamana Tvaya Jushta Nudamana Duruktan Bruhadvadema Vidate Suviraha Tvaya Jushta Rishir Bhavati Devi Tvaya Brahma Gata Shrirutattvaya Tvaya Jushta Chitram Vindate Vasusano Jushasvadravino Namedhe मेधामयीन्द्रो दधातु मेधां देवी सरस्वती मेधा मे अश्विना उभावा दत्तां पुष्करस्रजा अप्सरासु च या मेधा गन्धर्वेषु च यन्मनः दैवी मेधा सरस्वती सामां मेधा सुरभिर्जुषतागुः स्वाहा आमां मेधा सुरभिर्विश्वरूपा हिरण्यवर्णा जगति जगम्या ऊर्जस्वती पयसा पिन्वमाना सामां मेधा सुप्रतीकाजुषन्ताम् मयि मेधां मयि प्रजां मय्यग्निस्तेजो दधातु मयि मेधां मयि प्रजां मयीन्द्र इन्द्रियं ददातु मयि मेधां मयि प्रजां मयि सूर्यो भ्राजो दधातु हंस हंसाय विद्महे परमहंसाय धीमहि तन्नो हंसः प्रचोदयात् ॐ शान्ति शान्ति शान्तिः हरिः ॐ तत्सत् श्री साईश्वरार्पणमस्तु।
Prior to the pandemic, the global shortage of nurses was estimated to be around 6 million, and by 2030, nearly 13 million is the projection required to bridge the gap. As an institution, we believe that access to quality healthcare is a fundamental right of every human being. Shri Madhusudan Sai Institute of Medical Sciences and Research is a testament to this idea, wherein medical education is provided alongside medical facilities and both with zero charge to patients and students. Today, with our expanding presence in over 80 countries, this has been a key step towards capacity building and upskilling of healthcare professionals. We will now have a brief video that will give a snapshot of our healthcare mission. Can we have the video, please?
One world, one family. Vasudhaiva Kutumbakam is the guiding principle of the Sri Madhusudan Sai Global Humanitarian Mission. Founded by Sri Madhusudan Sai, a young humanitarian and visionary, the mission has established institutions in healthcare, education, and nutrition across 80 countries over the past 13 years. All services are provided free of charge, silently transforming millions of lives worldwide through the power of compassion. The vision of accessible medical education was realized with the inauguration of the Sri Madhusudan Sai Institute of Medical Sciences and Research by Prime Minister Sri Narendra Modi. Offering free medical education with a commitment to serve rural communities, the institute is bridging the healthcare gap between the urban and rural areas. On the healthcare front, the mission has established the world's largest network of free pediatric cardiac hospitals in India, Fiji, and Sri Lanka. Since 2012, over 34,000 life-saving procedures have been performed at these hospitals, all at no charge. Additionally, 5 mother and child hospitals, primary care wellness centers, mobile hospitals, 3 multi-specialty hospitals in India, and 2 hospitals in Nigeria have together provided consultations to more than 3.1 million patients. Through a meaningful collaboration with Rotary Club, multiple projects have been supported, including medical equipment, an operation theatre, a mobile blood bank, and most importantly, heart surgeries for deserving children. This partnership has significantly enhanced our capabilities, enabling us to serve even more people in need. Looking ahead, the mission's next milestone is a 600-bed state-of-the-art hospital in Muddanahalli, set to be the world's largest fully free hospital. Scheduled for inauguration in November 2025, it will be the second teaching hospital for the medical college. This facility will provide world-class healthcare to everyone removing financial barriers and ensuring equitable access to high-quality care. The vision for the future is bold and transformative: to establish 600 schools all over India and 6,000 wellness centers, one in every taluk. When individuals prosper, society prospers. When society prospers, the nation prospers. And when nations prosper, the world prospers. Together, we are one world, one family.
Collaborative partnerships have accelerated and enhanced our efforts in scaling our services for a wider reach. Once again, we are very grateful to Dr. Sanjiv Nichani and the entire team from Healing Little Hearts Foundation from so many different countries, including Latvia and Slovenia, who are here for the 5th consecutive camp, performing complex surgeries, saving countless lives and families. Thank you, all of you. I request Dr. C.S. Hiremath, Director, Heart Valve Bank and Academic CTVS, and our Chief Cardiac Surgeon, to give the opening remarks.
Sai Ram, offering my reverential pranams at the divine lotus feet of Bhagwan Sri Sathya Sai Baba and our master Sadhguru Sri Madhusun Sai, dignitaries on the dais, Dr. Sanjiv Nichani, Senior Pediatric Intensivist, Chairman, Healing Little Hearts Foundation, United Kingdom, Srimati Anubha Devaguru, Assistant Professor, All India Institute of Medical Science, New Delhi, Honorary Senior Consultant, Dr. B.R. Jagannath, dignitaries of the dais. We are assembled here to conduct the first international nursing conference in pediatric cardiac intensive care. This thought came into me 6 months back, wherein we happened to do pediatric camps in a rural setup like ours. Dr. Sanjiv Nichani was kind enough. We have been working together for the last 10 years. And when I discussed with him, we joined back again, having a collaboration. And this is the 5th camp which was going. Last entire week, we have been operating close to around 35 cases. The entire team from United Kingdom, Czech Republic, and other countries are here. In the last 5 camps, more than I think 22 countries plus people have come around here to our institute, been operating cases. And we can see the response. For this conference, we have crossed close to 526 registrations. That's a huge number. In fact, we had to filter them who is going to sit in this hall. That was the homework done by our team members, and rest of them have joined online. Not only this, we have been operating simple, complex, very complex congenital cases, totally free of charge to these patients. That does make an impact on the life of the child, the family, the society, and the nation, and indirectly the entire world. Our mission, vision of Sadhguru is a concept of one world and one family. We have various senior faculty, cardiac surgeons, cardiologists across the country who are here with us. We have our opening batsman, what we call him as Dr. Anil Tendolkar. He is the master of masters in cardiac surgeons across the country, very senior professor from Mumbai, who has taken his 2 days apart, and he's with us. We have our other teachers, Dr. Prasanna Simha, Dr. Prasanna Simha himself. We have Lesley, who is the trustee, Miss Lesley, who is the trustee of Healing Little Hearts Foundation. Dr. Umed Singh, who is a pediatric intensivist from All India Institute of Medical Science, New Delhi. Actually, he was supposed to be online. Seeing the program charts and the discussion, what's happening, he told, I would like to come here and see this place. Thank you, sir, for coming here. Our nursing team members are here, Dr. Shivanand and Dr. Huli, and all the deputy nursing superintendents who have played an active role to make this conference happen a reality. We have Dr. Vishwanath Kamoji, who spent 15 years in the United Kingdom. He's a senior consultant at Manipal and Sparsh Hospitals with us. We have Assistant Professor, Mrs. Cecilia, who from All India Institute of Medical Sciences, who has joined. We have a collaboration with All India Institute of Medical Sciences, New Delhi, and that takes us forward. All of them have joined online, and they were kind enough to send 3 of them over here. Actually, the conference chief guest was Dr. K.M. Cherian, who is considered as father of cardiac surgery in India. He has trained a number of cardiac surgeons, my teachers, in fact me, and his last conference which conducted was in this institute. We had conducted an international conference on pediatric heart valve repairs, one of its kind in the world, which we had conducted where dignitaries across the globe had come down. He was the chief guest, and he spent almost 3 days with us here. And that was his last journey to this institute and his last journey on this earth. He has left a big lacune, and he was supposed to be chief guest for this conference also. Unfortunately, God's plan was different, and he's no more with us. Recently, just 4 days back, he passed away. I would request a video to be played on his recent visit to our institute.
He came exactly on June 6th, 1975. That was a Friday. Saturday, Sunday, Monday. Monday, I had the opportunity to do a open heart. And subsequently, the 4th case which I did was the bypass surgery. I never knew that I was doing the first bypass surgery in the country. And that was a Friday. Monday, in the newspaper only, I came to know that we did the first bypass surgery in railway hospital. You should have a research institute, everything. But because you are all well known, people respect you for what you are doing. So that is why I said, looking at this hall, this is made by God. This is a gold medal, which I am going to present it to respected and revered Sadhguru, to be given for the best outgoing cardiac science student. Cardiology, surgery, anesthesia, perfusion, whatever it is.
His mortal remains were kept for 3 days for the entire nation and people across the globe. They came down to pay their last respects. Today at 11 a.m. in the morning, he was cremated. I request everyone to stand up for 1 minute silence so that his soul rests in peace as a mark of respect. I request all to be seated, please. We have the intensive care nurses from different places across the country, whether it is Bangalore, Vijayawada, Coimbatore, Delhi, Mumbai, Thane, Pune, Bhubaneswar. In fact, I went to the list. So definitely it shall help people to improve in their knowledge with what we have been sharing today and tomorrow. Once again, I welcome all the international faculty, national faculty, delegates, and the nurses who have shown interest to come down over here. Tomorrow, we'll be releasing a feedback form. You need to fill it so that these conferences can be conducted more, so that to educate more to all of you subsequently every year. Thank you.
Dr. Sanjiv Nichani, founder of the Healing Little Hearts Foundation, has been a pillar of support ever since our collaboration. A highly experienced consultant, Dr. Nichani specializes in several areas of pediatrics, and we now invite him to share a few words, please.
Sai Ram. Thank you very much for the introduction. And Dr. Hiremath, your energy never seems to amaze and tire us. You've organized an incredible conference. I had no idea that people from around the country have come here, so congratulations and well done. That's a huge compliment for your ability to persuade and to see things through. As he mentioned, this is our 5th mission here, my 4th personal in the mission in the last 7 months. And it took a bit of convincing from Dr. Hiremath to come here and understand this incredible vision to create a multi-specialty hospital in a rural setting like this. However, as soon as I stepped foot into this campus, into this ashram, I fell in love with it. It's green, it's clean, it's serene. It's one of the best places I have visited in my life. With our charity, Healing Little Hearts, that Lesley and I run, we have been to 23 countries around the world and conducted 250 missions. So you can imagine we are very widely traveled. And I can tell you hand on heart and sincerely that seriously, this is the best place and has got incredible potential. Starting with the legendary, inspirational Sadhguru, Sri Madhusudan Sai. But equally, everybody in this institution at every level shares that vision, that passion, that compassion, that humanity, that care. And that is very rare. Take it from somebody, again, who's traveled the world. We've signed a memorandum of understanding. We're now friends. We're friends, we're colleagues, we know each other really well. We're going to come, this is our first trip this year. We're going to come another 5 times. We'll have 6 trips in 2025, and so on. And we are delighted to play a part in creating an incredible free pediatric cardiac surgical service for children. This model, again, because of my experience, trust me, this model of free pediatric cardiac surgery is outstanding, it's sensational, it's incredible. So thank you very much, and I'm delighted to meet all of you. I hope you aren't too brain dead from all the information you've been given. I hope you found it useful. And I hope you take home some key messages. Thank you, and hopefully see you again. God bless.
Thank you very much once again, sir. We are certain that through this partnership of knowledge and skill sharing, we will surely create a much more lasting impact for many more years to come. Our founder, Sadhguru Sri Madhusudan Sai, has graciously joined us virtually. And now on behalf of all of us, we pray to Sadhguru to bless us with his divine message for this conference.
Namaskaram and welcome everyone to this conference on nursing. I would like to congratulate Dr. Hiremath for putting it all together along with his team, and special greetings to Dr. Sanjiv Nichani and the team from Healing Little Hearts from the UK, who have become our partners in providing care to the most underserved and underprivileged children in India and around, including Fiji Islands. And I look forward to you working with us in other countries as well, like Sri Lanka and so on. Thank you for your kind words, Dr. Sanjiv. And we are very happy to have you here. This is your home away from home, as I always say. And also, I would like to extend my warmest greetings to all the faculty from AIIMS, New Delhi, as well as from around the country and the world who have gathered over here for deliberating on this idea of improving nursing care, especially in pediatric ICU. We have been running hospitals which are in pediatric heart care, as well as these multi-specialty hospitals. And we have realized that the most important person after the patient and the doctor is the nurse. While the patient and doctors come together in a hospital environment for the sake of healing, but the healing touch after the treatment is given by the nurses. So it's only extremely relevant that a conference of this nature is being observed over here. In our institute, we have also made a point that students who are learning healthcare sciences, be it the MBBS students, the postgraduate students, the nurses and the paramedics, they all work together in one environment. They share their hostels also at times. They share their work at times. And they also share their play, in the sense they play together. And that way they build a bonding between each other so that tomorrow, when they become teams, they would know how to work with each other. I always say that one's mother is the first nurse, and the nurse is the second mother, because it is the motherly care that the nurses provide that helps the patients heal. And understanding their role and empowering them to do their job better is the collective responsibility of everyone. And this is an ongoing education, ongoing learning. As technologies change, protocols change, new ways of doing things are emerging. Every field of education must continue to learn new things, and nursing included. Nursing is extremely important from my point of view, because after the doctor has done his job, it is the nurses who have to care for the patients, and they spend the maximum time with the patients. So to comfort them, to make them feel at home, to make them feel cared for, it is the job of the nurses most of the times. I would like to share a story of what happens in our hospital. A lady, Asha by name, a laborer, a worker who was 7 months pregnant, was brought to the hospital in a difficult situation with comorbidities. A cesarean section was performed in the middle of a rainy night. A baby was delivered preterm in the 7th month. And then through the NICU care, the baby was nurtured back to life with the care of the nurses. And when this grateful mother was leaving after 41 days of NICU care for her newborn daughter, she went and pledged that she would like her daughter to become a nurse. And someone surprised asked her, why not a doctor? Why a nurse? And she said, because I'm inspired by the motherly care that the nurses of these hospitals have provided me. And therefore, I would like my daughter to grow into a nurse. That is the kind of inspiration nursing leaves behind. We are very grateful to all the nurses in and around who give themselves tirelessly to the welfare of the patients. They assist the doctors in their own way and help them achieve the right kind of outcomes. So we are grateful to all of them. And in our hospital, there is also an effort to bring a course on upskilling nursing care by certifications, diplomas, and further continuous education programs, which will help all of these nurses to upskill themselves into specialty and tertiary care departments, including pediatric ICU. I look forward to these programs so that our nurses can continue to learn and grow and support the entire ecosystem. I also would like to fondly remember Dr. Charian, as was mentioned by Dr. Hiremath a while ago. He came here with great enthusiasm and vision. He shared many of his thoughts with us. And many of his students or disciples or mentees have been a part of our institution even now. And we are grateful to him for all that he has done in terms of sharing the wealth of his knowledge with the next generation. He had the desire to build a state-of-the-art system where much research can happen and new ways of doing things can be discovered. In his name, I had already submitted that we are opening perhaps world's first free of charge heart valve bank in our own institute. In a short while, the equipments would arrive, and then this center will be ready in the name of Dr. K.M. Cherian. Also, as you had seen in the video, he presented a gold medal to be given to the best cardiac sciences student, outgoing student. And whenever we are done with our cardiac sciences courses, when it is instituted and people graduate, we will always have a medal installed for the best performing outgoing student of cardiac sciences. Lives of great men all remind us we can make our lives sublime, and departing leave behind us footprints on the sands of time. This is what H.W. Longfellow said. Time is a fleeting thing. It is limited. It is finite for all of us. But what we can do in that limited and finite time can be infinite and eternal. And that is the legacy that we must all leave behind as we pass on. A legacy of love, of sharing, of caring, of giving ourselves and our everything for the betterment of those who need us. And that is the lasting legacy that we can leave behind as footprints on the sands of time, so that somebody else who needs that inspiration can walk and find his way to the shore after a shipwreck. I look forward to the success of this conference and all the efforts that everyone is putting. I'm sure it will find meaningful purpose and outcomes. And I again request everyone that nursing or paramedic or MBBS, whatever be the degree, we must all learn to live together hand in hand, respect each other, and accommodate each other in this ecosystem of healthcare, because a healthcare system should be patient-centric and not a doctor-centric healthcare, nurse-centric healthcare, or management-centric healthcare. It is to be patient-centric healthcare. And that is what Dr. Cherian said in his last talk, that patient is the king, patient is God. And it's for that patient's sake that we must all work, the most important person. So I think we all agree with that, and we would build a system through all these collective collaborations and deliberations of such conferences to a high quality health ecosystem where nursing finds its rightful respect and place amidst all other things. So once again, wishing everybody all the very best and apologizing for not being there in person due to prior appointments. I'm in Hyderabad at this point in time, and from here I convey my best regards and best wishes to everybody who's a part of this conference. And once again, I would like to wish Dr. Hiremath and team the very best for this conference and all the future endeavors. Thank you very much. Namaste.
Thank you, Sadhguru. Once again, we offer our gratitude for taking the time out of your busy schedule and addressing all of us this evening. Thank you. We would now like to extend a token of our appreciation to our guests and faculty speakers. As I read out the names, I request you to come forward, please. First, to our honorable guests, Dr. Sanjiv Nichani, Ms. Anuba Devagoru from AIIMS, New Delhi, I'll read out the names. If you're here, please come forward. Dr. Ivars, is he here? Dr. Peter, Dr. Peter. Dr. Petr Plasil is an intensivist from the Czech Republic. Dr. Marek here. Dr. Miha. Okay. Dr. Jerneja. Miss Lesley Mistry. We have Miss Lesley here. She's a lead nurse and part of the Healing Little Hearts Foundation. Do we have Ms. Leeva? Ms. Katrina, okay. Dr. B.R. Jagannath? Dr. Anil Tendolkar ji, who's come all the way from Mumbai. Dr. Prasanna Simha is here. Dr. Vijayalakshmi? Do we have Dr. Vijayalakshmi? Dr. Vishwanath? Dr. Vishwanath Kamoji from Bangalore. Dr. Umeed Singh. Do we have Dr. Umeed? Dr. Umeed Singh, also from the All India Institute of Medical Sciences, New Delhi. Ms. Cecilia MS. Ms. Cecilia, also from AIMS, New Delhi. Next, do we have Ms. Usha? Ms. Usha Nambiar. Ms. Uma Nambiar. Dr. Mohammed Adil. Dr. Vivek Ranjani, okay. From the Department of Nursing, I request Dr. Ramachandra Huli, please. Next, I invite Professor Shivanand, the Principal of the Nursing College. Next, Ms. Shirley Lucas, Nursing Superintendent. Ms. Mary Rodriguez, DNS. Ms. Vasanta Vinodini, DNS. Ms. Grace Suja, DNS. Ms. Deepa, DNS. Ms. Usha Shetty. Usha Shetty, the CTVS in charge. Dr. Annie Arvind, Pediatric Cardiac Surgeon. And lastly, Dr. Madhumati. Do we have Dr. Madhumati here? Okay. With this, we conclude. Thank you all for your patience and participation and wish you all the best. Hope you have more fruitful and very engaging sessions after this session and tomorrow as well. Thank you all.
Thank you. I hope you are not tired. We have got 3 more talks. Are you tired? If it is yes, then you will be the losers. Tendolkar is not tired. You are missing one from who has come all the down from UK and from Delhi. We'll finish these talks. Tomorrow they are not there, sir. Tomorrow this team is not there. Tomorrow a team of artificial intelligence. We have panel discussions. How AI can be utilized in cardiac surgeries. That's there. How come you will be tired, ICU cardiac nurses? We have important talks. Madam, what time tomorrow flight? 8 a.m. They have come all the way from Delhi. It won't be proper. We need to finish talks. Then IT will be there. Afterwards, you can disperse. Is it okay? Thank you so much. I think I request now Dr. Sanjiv Nichani talk on sepsis. Come.
Yeah, exactly. I see.
You want high tea right now or have tea and come back or go at a time? Because I have a doubt if you go down, you will escape from here.
Tea.
Hey, no. Please. We'll finish. I'll time myself. We'll cut down the talks to minimum and we'll see. We'll try to finish at earliest. Or Anupa, can you give your talk? Yeah, please come. I will ask Dr. Anupa to give her talk, sir. We will sit as chairing. You can sit.
You can switch this.
No, not this one.
You can use this. This or this.
Good evening, everyone. I know it's getting late. I'm sorry about it. Can't help it. Honestly telling, if you pay attention, I'll finish everything in 15 minutes maximum. If you cooperate, I'll finish in 12 minutes. Okay, so that's a deal. What am I talking about? It's there in the slide. What is it? Acute kidney injury. Acute within a short period. How do we define it? We have a very good kidney disease, KDIGO, Kidney Disease Improvement Global Outcomes, which defines that there are 3 criteria, and if a patient meets any of these 3 criteria, we say that the patient is in AKI. And why am I talking about it? Because most of our ICU patients, somewhere or the other, suffer from AKI. And it is, if they suffer, so what happens? Of course, there will be more morbidity, mortality. At the same time, they'll affect the prognosis. Along with that, the patient is predisposed to develop CKD, which is more harmful. So on the other hand, the circle goes round and centers and stops on the cost of living, cost of care, and quality of life is compromised. So AKI is nothing but a heterogeneous syndrome. And I said there are 3 criteria. So any one of the patient gets it, like if there is increase in serum creatinine by 0.3 mg per deciliter from the baseline. Baseline can be any recent or within 365 days or whenever the patient has reported. Or if there is increase in serum creatinine to 1.5 times or more than from the baseline in last 7 days. Or the third thing, the urine volume or the urine output has decreased or less than 0.5 ml per kg per hour for at least 6 hours. So we know if any of these things are there, we can say a patient is going into AKI. So if it is going into AKI, there has to be a staging. So Raphael criteria takes 2 parameters into consideration, GFR, glomerular filtration rate, and urine output to stage AKI into 5 categories: risk, injury, failure, loss, and end-stage kidney disease. That is your CKD. I'll not go into detail. Everybody is hungry and there's output pending inside us also. So there's a window period. Immediately, we cannot say that patient has gone into AKI. We need to have a window period of at least 48 to 168 hours to wait and see that patient is actually developing AKI, or we need to rule out whether it is because of hypovolemia or excessive use of vasopressors or what is it. And the incidence reported by several studies that Approximately 50% of ICU patients undergo AKI. The overall incidence of AKI was around 53.5% during the ICU stay itself. And even after post-op, the patients are shifted to ICU because they have developed AKI. Trust me, you take any system, if they have stayed in the hospital, they may have developed, they may not have been diagnosed, or if it is diagnosed, the patient gets shifted to ICU also. And stage 1 accounts for the maximum incidence, that is 26.2, and AQI frequently is found to occur within first 48 hours post-operatively, and 7.3% of the patients actually end up receiving renal replacement therapy. RRT, I'll talk later. Most commonly, the leading cause of AKI is acute tubular necrosis, that is 45%, followed by pre-renal disease that I'll explain in short, not in detail. So the causes for AKI divided into pre-renal. What do we understand by pre-renal? Anything before the kidneys, which is like your hypovolemia, there is low cardiac output syndrome has already been discussed. Hypovolemia fluid management has already been discussed, not going into detail. So anything which causes decreased blood flow to the kidneys. So poor nephrons, they don't get nutrition. What will they do? They cannot function. So renal system starts shutting down. Intrarenal causes or intrinsic renal failure. When the system problem occurs within the kidneys, the nephrons are injured because of maybe nephrotoxic agents, there is cellular lysis or acute glomerulonephritis or any infection, any injury, there is AKI which results in. Post-renal causes, that is something beyond the kidneys, which is considered as part of urology system, and most likely it is because of any obstruction. Kidneys are functioning well, urine is getting made, but it is not coming out. So there's obstruction, and because of the retrograde flow back into the kidneys are, getting overfilled. We have seen that the lungs get overfilled because of the failure in the heart. Here, there is backflow of the urine, so the kidneys get overfilled and they get damaged. And of course, if there is any calculi in any part of the kidney, ureter bladder, or in the ureter vesico-vaginal junction, there is obstruction and the urine flow doesn't take place. Other prominent causes that can lead to AKI are, of course, the use of nephrotoxic drugs, particularly the contrast medium. So what do? We flush the contrast, I'll tell you in management. Antifungals, antiviral, chemotherapy, we need to take care because a lot of our patients get chemotherapy and we don't take care of their renal health. Sepsis in ICUs is the leading cause, and other causes are hypoperfusion. Hypoperfusion may take place, maybe patient is hypovolemic, maybe hypovolemia may develop as a result of cardiogenic shock or any major surgery like your cardiac surgery. The cross clamp time is more. I think all of you can relate. Any surgery in the abdomen, in the thorax, or in the renal arteries, which actually deprives the renal tissues or cells from good adequate blood supply. So any hypovolemia, any decreased blood supply, part of your pre-renal causes can dispose a patient to develop AKI. Other contributing factors are like if the patient already has comorbidity with hepatitis or any form of liver disease, age, of course, more than diabetes. Our red flag should be if a patient reports us with a history of hypertension and diabetes. They are the highest contributing risk factors to develop AKI and consequently CKD. How do we diagnose it? Very importantly, as a nurse, get up and tell me. Partially it is there, but something I've left for you to tell me. How do we know patient is going into AKI? One, urine output. Urine output is falling down. How do you say urine output is falling down? Because you are you're maintaining an IO chart. And you find that the patient was making good amount of urine, like 200 ml, 150 ml, and gradually it's coming down the trend. You see it's going downwards, right? Definitely something's wrong. You are hydrating, things are not, and you are till 50 ml, you're fine, 40 ml, you're fine. Should you be fine when it is again falling down, say 25 to 30? No.
you should be on alert. Another thing, color of the urine. It is getting concentrated. That should alert you. Creatinine levels. 0.1 increase, you're okay. 0.2 increase, you're fine. 0.3, no. Then that time you should remember me. I told you KDIGO guideline. 0.3 ml increase, 0.3 mg increase from the baseline. You need to be on a alert. Of course, we have other tests like EGFR calculation, then checking creatinine clearance and renal clearance with the help of ioxyl. There are biomarkers also available, but it is not yet confirmed that the increase in level of these biomarkers and tubular markers is a good indication, or you can say definitely that the patient has got AKI. So we as nurses, we have an upper hand. We pick up, urine output is getting down, specific gravity is going up, urine color is getting concentrated, serum creatinine is going up, patient is going into positive balance. There are chances patient is post-operative, patient has a history of sepsis. Yes, there is a risk. We need to worry. So need to inform the physician. Role of kidney biopsy is well established, but by the time we get the articles ready, we get the results done, it's already late, and we need to manage, because the sooner you manage AKI, the better is the prognosis. How do we prevent it? The major goal of prevention is to correct hypovolemia, hypotension, discontinue and try to avoid the use of any nephrotoxic agents, and of course correction of hyperglycemia, because diabetic nephropathy add to it. If the patient is in sepsis, the conditions will get complicated. Hyperglycemia is no good. Take that from today. Maintain a good kidney perfusion pressure. How much? The numbers sir has already mentioned. It may differ from patient to patient. Whatever makes your patient hemodynamically stable, take that into account. Pay more attention into maintaining a good renal perfusion pressure. MAPS and CVP, one has to look what is good for your patient. If it is a pediatric, lower values. If an adult, higher values. If the patient is on vasopressors, you may get a higher values. And again, but if the patient is not responding with fluid therapy, there is low output, one should think about starting off vasopressors. The impact of different vasoactive or inotropic medications on kidney function varies and may depend upon underlying conditions. Let me tell you, every patient is unique. You cannot generalize. As nurses in ICU, we have like 1:1 or 1:2, and sometimes 1:3. We may miss out. But if you understand three important things: urine output, creatinine, urine color, you will pick up AKI. A meta-analysis showed that vasopressin reduced the requirement for CRRT. It is definitely better. And a post hoc analysis of this trial also showed that in subgroup of patients on RRT, the duration of renal replacement therapy was shorter, and there was better survival in patients who received angiotensin II as compared to norepinephrine. Now, what do we use mostly in ICUs? Norepi or Levofed. But again, it varies from setup to setup. To further, for prevention, make sure that the drugs that you administer should favor the kidneys. It should not go into a higher dose. Certain drugs, they have nephrotoxic range, they have the dosage that you can always adjust. The role of biomarkers need to be determined in future studies. And even if you say that the biomarkers were raised, there is no good evidence or established result that would say that the initiation of RRT or the outcome was better because you found the biomarkers were elevated in few patients. This is the guideline to approach for oliguria. If your patient is oliguric, you have to see whether there is any obstruction or not. Any obstruction, the obstruction needs to be removed by flushing and urology consultation. If not, if there is no obstruction, how hemodynamically stable the patient is. If the patient is hemodynamically stable, unstable, we have the guidelines. I leave it with you. Then when we come to management for AKI, there is no established drug management. There is no specific drug. Many studies, they demonstrate that human recombinant alkaline phosphatase did not significantly improve the creatinine clearance. The creatinine clearance or the renal function did not improve in 7 days, but when this drug was used for continuous 28 days, the mortality was reduced. So you may want to wait and watch. There are new compounds that have come up, like cell-based therapies targeting a variety of pathways, including mitochondrial stress, cell metabolism, which may affect, but their use is not yet well established. They are still under research. Drug consideration, again, I said, if your patient is going into AKI, the first thing that we want to give is a Lasix challenge and fluid challenge. As a nephrology nurse, if patient is hemodynamically stable, you want to give a Lasix challenge, 20, 40 mg, OD or BD. Patient makes urine, it's fine. You may say that, yes, the renal output is, urine output is there. And at the same time, you want to maintain a good IO. Also, monitor dietary ingestion of potassium and phosphorus, because at no point of time your potassium level should go up. In management, one important thing, you need to differentiate between pre-renal and acute tubular necrosis. How do you differentiate? You give fluid challenge. If the patient responds, it is pre-renal, but if the patient doesn't respond to fluid challenge, how much fluid challenge do you want to give? Any answer? Any volunteer? 1 liter, fine. 1 liter over 1 hour. It depends the type of patient. Okay, if the patient is already fully overloaded, like when the patient comes from OT, they already have a lot of positive balance. You don't want to stress the heart. You don't want to you don't want to fill the lungs with more fluid. Okay, so you will have to decide with the physician how much fluid you want to give and over how much time. So that's one fluid challenge you have to take care. And if the renal function improves with fluid challenge Lasix, it indicates pre-renal. Otherwise, one has to look for ATN, which can be diagnosed with the help of kidney biopsy. Initiation of RRT, renal replacement therapy, 4 forms, HD, PD, any other? CRRT and SLED. Slow efficiency, low efficiency dialysis. So HD-PD, we are all aware. These are intermittent. Even PD can be done continuous. They are more feasible. I have slides which I will just show you that what is the advantage of each. CRRT is like continuous. SLED is also continuous, but it is slower than CRRT. And CRRT and SLED is beneficial in patients who are hemodynamically unstable. Our patients are usually unstable. They are already on vasopressors. So should we opt for SLED? Should we opt for CRRT? In our setup, when we lack good manpower, resources, technical support, we would think twice, okay, because of the cost difference and the support. And to start which type of RRT, the clinician has or the physician has to focus upon correction of hyperkalemia, acidosis, uremia, and there are so many things that's going around. So KDIGO in 2012 states that continuous use of RRT and intermittent RRT can be used in complementary. Okay, they can be in conjunction with each other. There is no definite guideline that one should use CRRT, one should use only HD, or one should use only SLED. It has to be in conjunction, whatever suits for the patient. But it has to be started on time. The indications for RRT is severe and non-responsive hyperkalemia, unemic pericarditis, and pulmonary edema. And it is assumed that continuous therapies like HD, PD are better tolerated by patients who are hemodynamically stable. But at the same time, HD and PD also predisposes the patient with raised ICP and liver failure. So if your patients come up with any sort of cerebral edema, think twice before starting HD or PD, because it's further going to aggravate the ICP pressures. Life-threatening complications, of course, with RRT, you have life-threatening complications. Any therapy, it will have its side effects. Like there will be thrombosis, infection. When we use HD, PD, and CRRT, we end up using a lot of heparin or other forms of anticoagulants that predisposes the patient to develop DIC. So one has to select the modality of RRT that saves lives before prolonging AKI. So the principle of primum non nocere should be applied and considered. KDIGO guidelines suggest using CRRT rather than standard intermittent RRT, and for RR to be safe and effective, a minimal infrastructure has to be available with full support, commitment, viable finances, skilled staff and equipment. Make sure that you have all these. They are good therapies, but they are still expensive. This I've already told. There are the different types of RRT. RRT in children, renal replacement therapy. The Indian Society of Nephrology 2019 draft guidelines recommends to provide RRT to critically ill children. And the guideline says that if the child weighs less than 10 kg, they may be frequently managed with PD. But if there is availability of good extracorporeal or good ultrafiltration control and pediatric software, SLED and CRRT may also be useful. So the different types that are available as of now are FX PED dialyzer, AV PED filters, and but at the same time they need a skilled manpower. These are the few advantages and disadvantages of various renal replacement therapy modalities. In intermittent hemodialysis or HD, there is reduced exposure to anticoagulants, but at the same time, patient lose a lot of blood. Whereas in CRRT, there is continuous removal of fluid and toxins. It is better tolerated by hemodynamically unstable patients, and they are at the same time patient mobile. But the major disadvantage of putting patient on CRRT and SLED, patient will be confined to bed. There is no mobility. So if you are planning to mobilize your patient, if the patient is progressive towards rehabilitation, one should think about shifting the patient from CRRT and SLED towards IHD or PD. So to conclude, patients in ICU frequently develop AKI, may receive multiple extracorporeal supports, including membrane oxygenation, and because of the continuous nature of CRRT and to a lesser extent SLED, these therapies are preferred for coupling with other extracorporeal supports. So my take-home message, strict intake output, watch in urine output, color, density, creatinine. Thank you.
Thank you. Thank you for your time. I request Dr. Peter to deliver his talk, please. I am cancelling one talk. Yeah, thank you, madam. Thank you so much. After this, we have one more 10 minutes. Just bear with this. He is there online from Delhi. Is he there? Dr. Rajsekhar is there? Yeah, call him.
Sir, I am there, sir. Good evening, sir.
Online, yours will be the last talk.
Before we move on to the next session, sorry, earlier I forgot, we acknowledged everybody, we thanked everybody except the man behind this conference. So I'd like to felicitate and thank Dr. C.S. Hiremath, the organizing secretary of this conference, and I request Dr. Jagannath, Dr. Annie, please come onto the stage, and all the nursing team as well. Please come onto the stage. You can join us. Please join. He is the man behind the magic or the madness, whichever you call it. And his drive and enthusiasm never seems to cease, never stops to amaze all of us. A big round of applause to Dr. C.S. Hiremath, please. Join. One second. Thank you. Thank you.
Thank you. Thank you. Thank you so much. Yeah, Peter, please go ahead.
Hello,
They're all leaving tonight. They're flying back to UK, Czech Republic. So all these talks are there. They've put so much efforts. You need to listen. Nothing happens. Even if you fast today, nothing happens. Why you're so hungry, is it? Yeah, Peter, please go ahead.
I know everybody's impatient and hungry. I'll make it simple. The topic of my talk is postoperative bleeding. There are defined risk factors in pediatric cardiac surgery that predispose to bleeding, which is the age of less than a year, hypothermia on cardiopulmonary bypass, expected duration of the bypass more than 90 minutes, resternotomy or redo procedures, and extensive aortic suture lines. We usually divide postoperative bleeding on surgical and non-surgical, but if you have a severe bleeding, either of surgical or non-surgical origin, it usually gets worse, and the surgical comes to non-surgical because you have added coagulopathy. How do we recognize these two groups? The surgical bleeding is often with higher drain losses, with pale red blood, and with some reported problem at the OR. Sometimes it can be hidden, it can bleed into the abdominal cavity or pleural cavity. Non-surgical, or sometimes called anesthesiological bleeding, is with longer pump runs, perioperative and postoperative hypothermia, hemodilution, hypocalcemia, and some lung manipulations with hyperfibrinolysis. You can see bleeding from sites that should not bleed, like mucus or around catheters. So that's when you should suspect that there is some problem with coagulation. What are the basic general measures that we should do if anyone after cardiac surgery bleeds? We should keep him warm, at least more than 35 degrees. We should prevent and treat acidosis. We should keep him normocalcemic, and we should keep the hemoglobin levels at more than 8 grams per deciliter. And this is the basic one. Another very important thing is to keep the patient after surgery sedated if there is bleeding. Any movement, any waking up, sitting up potentiates the bleeding, and it's something that we don't want. We should prevent and treat hypertension, even sometimes inducing permissive hypotension like on purpose, so the bleeding can abate. And one of the most important things that nurses should take care about or know about is that the drain patency is of utmost important thing. It has to be functional, that the suction has to be functional. There should be no kinking, no drapes around the drains, and we should use gentle milking if if the drain is full of blood. We should gently milk it to keep it patent. And of course, the other important thing is to correct any coagulopathy. What if we cannot manage? If the bleeding is too excessive, how do we know? The excessive bleeding is defined as a bleeding of more than 7 milliliters per kilo per hour for more than two or more consecutive hours in the first 12 hours, or 10 milliliters per kilo per hour in any hour, or bleeding above 100 milliliters per hour in any kind of weight. Of course, also very important thing when your patient is bleeding is to remember that the bleeding can stop, but it can accumulate inside the thorax, and it can cause tamponade. So if the circulation is starting to deteriorate, you should always think of tamponade. And you should look for it with echocardiography in advance, not wait till the blood pressure is really low and we are in shock state. And any severe hemodynamic instability, which is severe enough and we don't know what the origin is another indication for re-exploration. How do we recognize coagulopathy? We have several measures. We can perform the ACT, which is done often at the OR, which is very non-specific and we don't know why it's elevated. So we usually skip at our institution this test. We can do the regular blood tests like CBC, like platelet counts, PTT, fibrinogen, etc. But most often now we take the viscoelastic method to work for us because it's fast and it tells you what you should do. You could do some specific tests, but it's not very useful in bleeding. So I was talking about the viscoelastic method. One of the apparatus is called ROTEM, as rotational thromboelastography. Why we should do it? It tests the physical properties of the clot. It doesn't work like normal usual coagulation parameters, but it takes the blood, let it clot, and tries to hold on the strength or test the strength and stability of the clot. It is fast. It is available at bedside, and you can, after 5 or 10 minutes, tell whether there is some problem with coagulation and what the problem is. So it enables you targeted treatment. It can tell you that there is residual heparin in the patient, whether there is hypofibrinogenemia, hyperfibrinolysis, or platelet or coagulation factor deficit. This is how it looks like, the curves. There's the white of the graph. And the starting point tells you that the blood is starting to clot, and the wider the curve is, it means that the coagulum, that the clot is more stronger. If it abates, like in the first one on the left side, it means that there is fibrinolysis and the clot is starting to deteriorate. If there are specific algorithms and specific tests for each and every part in the blood of the clotting system. So you can say there is low fibrinogen, there are low platelets, or there is residual heparin. So how should we treat coagulopathy? We should keep the hemoglobin level high, at least above 80. We should transfuse platelets if there are under 50, and we should target the therapy according to ROTEM. And if there's problem, we can give PCC concentrate or fibrinogen, or if fibrinogen is not available, then cryoprecipitate. We can give tranexamic acid in hyperfibrinolysis and other coagulation factors concentrates. At our institution, if we don't know what to do and the patient is still bleeding, we, of course, with cooperation with surgeons, which are the most important coagulation factor, sometimes use recombinant factor A, 7A, which is off-label, but sometimes very often used therapy in low doses. It's very effective. It stops almost all bleeding. And with that, I'm going to finish the talk and hope your patient won't bleed.
Thanks, Peter. Over to Rajshekhar, please, online. Rajshekhar from Delhi online. Actually, one more talk was there, sir. The speaker only disappeared now. Come, Rashekar, you are there, sir. Quickly
I'm
come,
just
sir.
sharing.
Yeah. Yeah, thank you so much. She's asking a question. Stand up. I appreciate your interest now. I can call back the other speaker also if you are ready.
Is that the question?
She has a question. Yeah, please go ahead. Take the mic. Take the mic. You are online. Please take the mic. Yeah.
Hello.
Yeah.
I'm not supposed to sedate the patient, no, sir, during bleeding time.
If your patient up,
BP will fall down. We don't know whether BP is falling because of the bleeding or because of the sedation, no, sir.
of course it's a problem. But if you have also filled the patient, you cannot just look at the bleeding. You have to use what you're using normally: fresh frozen plasma, erythrocytes. Fill the patient, keep him filled. If the problem is in bleeding, when you substitute enough, you won't get any severe hypotension. But if the patient will keep waking up and sitting upright,
Permissive hypotension also.
you have to treat both at the same time and use your brain to guide the therapy. So it means not over sedate, but sedate slowly and keep on resuscitating the circulation as well. So do both things together. Sometimes it's difficult, but it's the only way how to do it. And nobody will stop bleeding if he's trying to get out of the bed.
Thanks.
Any other protocols for giving blood transfusion, sir? That blood products, anything like platelet, FFP, PRBCs, cryo, like any standard protocol is there in.
We have a protocol of tech. If you have a thromboelastogram in your unit, when you feed blood to that thromboelastogram, it will guide us. Tech. That will guide us.
TEM, same, sir. ROTEM and TEG, same, sir.
Excuse
Peter,
About ROTEM.
talk little slowly. He's from Czech Republic. English. You talk, sir. She's asking is tech and the one we talked about ROTM. Is it same? She's asking.
And TEG is same, I'm asking, sir. No, sir. TEG is thromboelastograph. That is different, sir. ROTEM is what, sir?
ROTM. You mentioned in your talk.
Same or different, I'm asking.
You mean the normal coagulation tests?
No.
Like APTT or INR you meant. They are of course of value. Before ROTEM, before the viscoelastic methods, we use them a lot. But the problem with the normal coagulation test is that it sometimes takes quite a long time before you get the answer. And because the patient is bleeding, the coagulation status changes. As you substitute the patient, as is bleeding, if you are bleeding severely, the coagulation gets worse and worse. So if you're waiting for the coagulation test to react, you're reacting to something that happened 45 minutes ago. And that's the problem. So time is very relevant here. And the viscoelastic methods are really useful in that setting. But if you don't have them, then you have to do whatever you think is best for the patient.
Thank you. Hello, just 1 minute. You can discuss during the high tea. I will give you 2 samosas because you have taken interest to ask a question. Thank you so much. Please sit. Come, sir. Can we go ahead with Rajshekar? Rajshekar is there?
Yes, sir.
Really appreciate. What's your name? Sister, what's your name? From which place? Jipmar, Pondicherry. Give her a big hand. Everybody who has wanted to eat, go run away.
Tamil Kari, Ada Appadi patient.
At least my struggle,
Tamil,
at least
Tamil.
somebody got activated. That's enough. Thanks. I appreciate your interest. We will definitely continue the discussion during the high tea time. Please sit, sir. Yeah, go to Dr. Rajshekar. He's a senior professor at All India Institute of Medical Sciences. Postoperative chylothorax is an important problem which we find commonly in cardiothoracic surgeries. Go to Dr. Rajshekar, please. Can you hear us?
Yes, sir.
Please go ahead, sir. Sorry, we got late. Sorry. Please go ahead, sir.
Okay. Good evening, everyone. And thank you, Hiremath sir and our organizers for giving me this opportunity. And pardon me, physically I'm not available there, but I'm not going to take much time. Already, because of time, I cut shorted my presentation. And this is the most common and the most disastrous complication we regularly come across in the pediatric population. My slides are not moving.
Shivkiran, just see. Can you check why slides are not moving?
Can you give me the control?
Shiva, make him the co-host, no? Make Rashikar the co-host, I think that. Can you check, Shiva?
Sir, you go to that presentation and click one, sir, then it will start. Rashekar, sir. Yeah, no.
It is not getting highlighted actually. Okay.
Yeah, please go ahead, sir. Thanks.
Activated.
Yeah.
So why it is important? Because the lymphatic system has three cardinal functions, which one is the maintenance of interstitial fluid balance and immune surveillance and absorption of fat. So retention of the plasma in the interstitial space is a safety valve to the circulation. It defends or protects the failing heart from the volume overload. Whenever the lymphatic pressure increases, the system safety function is activated and the system responds by increasing the amount of lymphatic drainage contained within it and it transports. So this system functions as a reservoir protecting the failing heart from the volume overload. This is nothing but a Starling resistor effect. So what is chylothorax? It is nothing, generally refers to the effusions which are high output failure from the chest tube that persists longer than 1 week. So it can occur up to 15% patients following superior KO pulmonary connection like bidirectional Glenn, or 25% of the patients following the Fontan procedure. But it accumulates to 0.85 to 6.6 of all complex congenital heart procedures. So this is not a rare thing. It is a most frequent complication which can occur after any pediatric cardiac surgery. So what are the lymphatic vessels? They coalesce to form thoracic duct and carry lymph toward the central venous system in the thorax. So they drain by the thoracic duct. The lymphatic system is a complex network of channels that transports lymphatic fluid and plays a key role in immunity, active absorption, and transport of cells, dietary fatty acids, proteins, and macromolecules. This, as I said earlier, this system is vital for circulatory system where it returns excess interstitial fluid from the tissues to the venous system. So what it contains? It contains fat, lymphocytes, immunoglobulins, and coagulation factors. So by increased drainage, it is clinically present as a respiratory distress when it compromises the expansion of the lung. As fat, lymphocytes, immunoglobulins are losing, nutritional deficiency can occur, and weakened immunoresponse, which ultimately results in the extended stay in our ICUs. So what is the pathophysiological mechanism involved? Most commonly, it is maybe because of unintentional thoracic duct injury while doing the surgical procedure, or pulmonary lymphatic perfusion syndrome, where retrograde flow occurs from the thoracic duct to the lung or mediastinum, or sometimes a central lymphatic flow disorder, either genetic or congenital absence of central lymphatic flow, like we can see in the Noonan syndrome, Down syndrome, or Turner syndrome, or hypoplastic left heart syndrome with the intact interatrial septum, or sometimes rarely with transposition of great arteries and complete AV canal defects also. So this is what happens. In a normal lung, both pulmonary arterial pressure and pulmonary capillary wedge pressure are higher than the central venous pressure. Resulting in the normal reabsorption of the fluid. But when it comes to the single ventricle physiology, like in Glenn and Fontaine, there is a paradox. The lymph produced from the lung is required to drain at higher pressure than it is created. That's how the effusion occurs. So what are the high-risk surgical procedures where the association with chylothorax is noted? So wherever there is aortic arch reconstruction or surgeries nearby the aortic arch, like PDA ligation, coarctation of aorta repair, even during the Blalock dissection, Thomas shunt on the left side, or sometimes double aortic arch repair when we are doing on the left side, and Norwood procedure also. And coming to the single palliative procedure for single ventricle, as I told you earlier, bidirectional BD Glenn or Fontaine procedure has resulted in persistent chylous effusions. So how can you prevent it? Intraoperatively, once you identify the thoracic duct, avoid injury. If it gets inadvertently injured, you can clip it. Or sometimes lymphatic sparing techniques like use minimal invasive procedures or thoracoscopic robotic procedures so that you won't damage too many structures. Where it may be deemed necessary, you can use a perioperative lymphoscintigraphy or intraoperative lymphoangiography can also be utilized to image the course of the lymphatic vessels. In some cases, perioperative prophylaxis for wherever there is high chance of pulmonary arterial pressures are there, we can consider administering somatostatin analogs such as octreotide, and we decrease the morbidity and mortality. Sometimes you can use a vasopressin also selectively while rewarming in case of single ventricle physiologists to decrease the postoperative chylous leak. So clinical detection becomes a prime the objective. Always early detection takes the first place in the postoperative phase. Like whenever one come across as a respiratory distress or tachypnea, reduced breath sounds, these are all initial warning signs. They should get an X-ray done, check for the pleural effusion, and get an ultrasound, which also localizes and quantizes the fluid. If required, go ahead for the CT imaging. In specific situations, you can use the dynamic contrast MR lymphangiography. It is though costly and it is not available everywhere. In specific cases, we can use this test. But basic test is the thoracocentesis, where you can do the aspiration of the fluid and can send for the analysis. One should be aware that what are the differential diagnoses for whatever pleural effusions we come across. That can be transduct effusion, it may be because of failure, or hemothorax, it may be collection of the blood. Pleural emphysema, it may be because of bacterial infection, or it may be lymphoma, but in lymphoma, it won't be the milky fluid. And key differentiator is the presence of triglyceride levels more than 110 milligrams per deciliter, which is grossly appear whitish in color. So diagnostic criteria: lymphocytes more than 80% of absolute cell count, triglycerides more than 110 milligrams per deciliter, and WBC more than 1000 microliters, and total protein content is 2 to 6 gram per deciliter. Why it is required? What will be the long-term fate if your child has a persistent pleural chylothorax? It can cause nutritional deficiency because of ongoing loss, may cause the protein calorie malnutrition, and it can be prone for risk infections. Recurrent effusions may cause the persistent chylothorax, multiple thoracocentesis, and leading to long-term respiratory issues. Respiratory function: untreated chronic pleural effusion can result in hypoxemia, atelectasis, and hindered lung development. What are our goals of the management? Relief of respiratory symptoms, prevention of the recurrence, prevent or treatment of coexisting malnutrition and immunodeficiency. So it is better to avoid the complication. So one should prevent it. Surgical precision: always utilize careful dissection methods while being mindful of thoracic duct anatomy. When dealing with high-risk cases, consider employing the lymphangiography as needed. Early detection and post-operative monitoring. Consistent post-operative chest imaging such as X-rays and ultrasounds are vital. Timely recognition and drainage of pleural effusion can avoid the development of severe chylothorax. Always multidisciplinary approach brings the better outcome. Multidisciplinary team in this case includes cardiac surgeons, intensivists, dietitians, and nursing personnel. And it is important to implement nutritional strategies as early as possible. So what are the conservative managements we can have? Drainage. Whenever you notice a persistent child in respiratory distress and he had a major X-ray shows the massive effusion, immediately put a large bore chest tube and drain it out. Medium chain triglyceride diet is important. And the child who cannot take these diets, better to switch over to the total parental nutrition as early as possible. And meticulous fluid balance to be maintained and electrolyte imbalance should be prevented. Coming to the pharmacological management, octreotide, then somatostatin analog should be initiated when conservative measures fail to address the issue. Octreotide acts by inhibiting secretion of lymphatic fluid, thereby improving the rates of resolution. Sometimes the diuretics like potassium-sparing diuretics, aldactone can be used to decrease the pleural effusion. And surgical intervention, it can be done by thoracic duct ligation via thoracoscopy or thoracotomy, or pleurodesis, infiltrating thoracic cavity with talc, chylous pericardial patching or sclerotherapy, or vascular pediculated flap, and sometimes in rare and last choice can be utilized as a diaphragmatic fenestration with a PTFE patch. It is nothing but a pleuroperitoneal shunt. Whatever drain is there, it is drained into the abdominal cavity. From there, it can be reabsorbed. So recent advances in surgical technique for management of chylothorax is microsurgical thoracic duct ligation, lymphatic embolization, and video-assisted thoracic surgery. But all these facilities may not be available across the country. Wherever it is available, we can use them. And special care precautions with respect to the single ventricle patients are, first step is to, whenever you come across a single ventricle physiology and with a massive effusion or recurrent effusions, you should check further to is there any obstruction in the Glenn circuit or to the Fontan circuit. So to rule out any thrombus in the SVC or alternate sources of pulmonary blood flow like MAPCAS, or rule out any direct injury to thoracic duct, or is there any AV valve regurgitation is there. So rule out one by one, keep a checklist, rule out one by one, treat accordingly. And in sometimes there may be increased PA pressures are the reason for the persistent effusion. In those cases, you can use inhaled nitric oxide or sildenafil. So always remember to replace the chest tube output with the FFP or 5% albumin. Half of the drainage has to be replaced with the chest, either FFP or with the 5% albumin. And anticoagulation with unfractionated heparin or low molecular weight heparin may be limiting the thrombotic complications due to chylothorax. So always share the positive outcomes with the patients and their family. So as a nurse colleagues, you play the major role in this aspect. Educational approach, define the condition, explain what is chylothorax is and underlying causes for its occurrence, and investigate the treatment methods, review the options for conservative management as well as the possible surgical procedures. And check to the nutritional aspects, educate the parents on significance of MCT diet in managing chylothorax, avoid all milk and milk products, and address feeding challenges, monitor growth, and provide long-term nutritional advice. Offer reassurance, highlighting many children can recover completely with the appropriate care, and provide psychosocial counseling for parents to assist them in navigating an emotional and financial difficulties. So to summarize, whenever you come across an chylothorax, first treatment comes about the medical management. You should address the dietary aspect. If dietary aspect is not achieved, then go ahead for the TPN. When TPN also fails, you can add the drugs, either somatostatin or octreotide. If all these things fail, then go ahead for the echo evaluation to consider for the, look for any correctable causes there, and then consider for therapeutic strategies like Fontan pathway obstruction, or as I told you, MAPCAS for extra pulmonary blood flow. How is the ventricular function? AV valve regurgitation, or is there any pulmonary venous obstruction, or presence of any hemodynamic implications? All should be ruled out. If it persists after 2 to 4 weeks of medical management, then consider imaging of lymphangiography, lymphoscintigraphy, or dynamic contrast enhanced MR lymphangiography. Determine what is the type of injury there. If it is a traumatic leak, go ahead for the thoracic duct ligation, pleurodesis, or pleuroperitoneal shunt, or embolization of the branch of the thoracic duct, or thoracic duct covered stenting can be applied. If it is due to pulmonary lymphatic perfusion syndrome, look for the correctable cause and selective lymphatic obstruction can be done. Selective lymphatic duct embolization can be done. And it is a rare scenario where central lymphatic flow disorder is in very poor outcome even with the lymphatic intervention. So what is the definition of clinical improvement of failure? If the daily drainage is less than 10 ml per kg per day, it is a welcoming sign. But if it is more than 10 ml per kg per day after 4 weeks of conservative treatment, it is a dangerous sign. So 2 to 4 week trial of non-surgical therapy is reasonable to decide when to consider for surgery. And most of the times, conservative management is successful in children. And failure is high in children who have the syndromes that are associated with poor lymphatic system, Noonan syndrome, or Downs or Turner's, and persistent elevation of the central venous pressure. To conclude, chylothorax represents a complex complication, particularly after high-risk pediatric cardiac surgery. Important is a prompt diagnosis, diligent monitoring, and swift intervention are crucial. Recent developments in imaging and surgical methods are offered improved management alternatives, and ongoing family education and psychosocial support play a vital role in ensuring the recovery. And continuous collaboration with multidisciplinary approach across various disciplines is critical for the outcome of these cases. Thank you for giving me the opportunity. If you have any queries,
Thank you, Rajshekhar, for being there. Our apologies for getting delayed. Quite an interesting session. And we conclude for today's
I just
program.
want to ask one question to Dr. Rajshekhar.
Yeah, please go. Dr.
Can we
Tendolkar is
give
there.
that fluid back to the patient?
Yeah. Dr. Rajshekhar, sir has a question, please.
Sir.
Can we give the fluid back to the patient?
No, sir.
It is rich in fat. It is rich in protein.
But sterility
I'm
is
not
the issue,
joking.
sir.
No. It is correct.
Since morning, everybody thinks I'm joking. I will tell you when I'm joking. Sincerely, I'm asking you.
That fluid has been given
Collected
to drink
sterile
also.
manner, can it be given back? See, he said nutritional problem, volume problem. I'm giving back protein. I'm giving back fat. So I'm asking.
But it is a sterility issue, sir.
Collected in a sterile manner. Extreme, not exposed to air.
Yeah, all is this.
People have been returning back post-operative drainage blood. That has been returned back. Here I'm returning back a lymph. And that too may not be IV. I'm asking oral.
Oral, we can put a ice tube and that has been
put an ice tube and give it back.
Yeah, that has been done.
Fat, rich in protein.
Yeah, Umed. Yeah, please, Dr. Umed will speak.
Our intensivist is there, Umed will answer.
Yeah, he is here.
Yeah. Sir, actually already we are providing the nutrition that is less fat. We provide to let fat-free nutrition to these patients because the problem is with lymphatics, na sir. They are only now they are not able to that is returning. the medium chain triglyceride only. That's why in kids we start MCT fluid, MCT fluid and all. So the same fluid is going to be, the issue is the same, sir. Lymphatics if are getting absorbed and it's going to stay there. It's long chain triglyceride. So it's not going back into the circulation. Again, the issue will come the same.
So overcome that. You give back fully. Anyway,
no,
so just give a thought. Don't start laughing.
So, and what one thing I would like to mention from the nursing perspective, recently Rajshekhar Sri operated one patient from the Nigeria, I think. And patient, sir asked the patient that early mobilization decreases this pleural incidence, as well as if this new the chylothorax is developed, then also the mobilization really help. So sir asked the in charge that, okay, this patient have some language issue and this should be mobilized all the time. So one day the patient from the CT5 was going down and up from that fire exit, from backside entry, that was the stairs, the patient going up and down. I came from the upstairs from CT6. I realized that is this patient escaping. I went to the bedside of the patient and asked the nursing officer on duty that where is your patient? So he said, where is he? Where is he? I asked him that I have seen him to go downstairs from the fire exit. Then he rushed all together because he did not took the proper handover that, okay, this patient should be mobilized in all 3 shifts. So mobilizing the patient in the ICU, we try to mobilize. Our target is to extubate the patient in the 6 hours for the Glen and Fontan. And then very next morning, we try to bring the patient out of the bed in the chair. So that is very, very meticulous process for the nursing officer, because there are a lot of inotrope lines and tubes and all those things we have to take care. Most of the time patient is on this and oxygen therapy as well. And despite that, when the patient is in the ICU, then you are the sole person to take care of that the tube should not come out and where my patient is going. And so these are small things, but these are really, really detrimental things. So we should take care of all those things. Thank you.
Umedu, one point to be added.
Sir.
For all the nursing staff, for the Fontan patients, early mobilization and skipping like exercises where soleus pump is activated and shoulder girdle exercise, they will decrease the drainage output. So we'll encourage the kids to do those activities, either standing in one area and they can do the skipping, though chest tubes are there. They can do the jogging type or hopping type things so that it will activate the return of this thing. Yeah. And that's how this Nigerian kid also, initial days, she had a chylous thorax, but she recovered and she discharged 3 days back.
Thank you. Thank you, Rajshekhar.
No doubt, sir. I will admit here that he is one of the best consultants that I've seen. Operating.
I want to ask, can I ask one question?
Yeah, please.
Before they go for dinner, how do you report bleeding to the doctor? I say you, patient mandir ke, tell me how will you report bleeding? See, many people, let me cut the discussion short. After coming to ICU, giving an upright position, 45 degrees, 35 degrees, mark a level and consider that as 0. Because by the time patient shifts, there is some 300 or 400 cc bleeding. I'm talking about adult. So after getting shifted, give upright position, whatever is allowed, 45 degrees, and consider that level in the drainage as 0. No, many girls report, sir, first hour 600 ml. And number 3, many surgeons, perhaps they put angle drains. Angle drains are anti-gravity drains, angled. So the blood has to come up and then it goes down. And typically at 5 a.m., when patient is sponged, I get a phone. And if 5 o'clock phone means I know what that phone is. So, sir, suddenly patient drain 600 because it's an angled drain. So remember, most important, please report hourly drainage. Don't tell total drainage. If I am thinking whether to explore or not, I'm more interested, as he said, 7 ml per kg. So I'm more interested the trend of bleeding. So first hour it will be more, say 100 ml, 150 ml, next hour 60, then becoming 30, 20. Rather they're saying, sir, 100, now 170. So 170 is the total. We are not interested in total. We are interested in hourly drainage. And after shifting the patient, please consider that as 0. We are not trying to hide something. Many people think I am trying to hide. No, it is counting now, starts after coming to ICU. Okay?
Thank you.
Thank you.
Thank you.
Happy
Tomorrow,
dinner. Happy
sir,
dinner.
Tomorrow we are meeting at 8:15 a.m. sharp. 8:15.
8:15.
Yeah, because Tendolkar is taking the talk. Tendolkar's talk is there for 45 minutes on cardiopulmonary bypass. 45 minutes. It's been an amazing talk. If you miss, it's difficult to get it. So see that everybody is here seated by 8:15. Breakfast will be there by 7:30 onwards. And we have topics for artificial intelligence for nurses is another debate. And also we have cardiopulmonary resuscitation. The BLS training program for the nurses with mannequins for all of them. So this is very important. I hope 8:15 people will be there. Hello. Chalo, all the best. You can have high tea and then go. Thank you, Dr.
Thank you,
Rajshekar.
sir.
Thank you so much.
Thank you, sir.